we can transition on to using cosmetic Botox injections in our day-to-day ophthalmic practice. I practice in Mumbai and Pune. Mostly my practice is 50% reconstructive and 50% cosmetic. I request everyone not to click photographs or screenshots of this presentation because face photos will be displayed. Although we have permission, but still it is a legal, it has legal implications. Now, before we begin any cosmetic clinic or service in our ophthalmology practice, we should be knowing that there's a huge difference between dealing with routine cataract and ophthalmology patients as compared to cosmetic patients. For cosmetic patients, the demands are different. Sometimes they don't even like to be called as patients. You need to assess the goals of your therapy, the goals what the patient has set, and the goals what you can set for them, and have realistic expectations from the treatment options available, including Botox as well. There are always some red flags present in any patient which you should notice first. And if you find any of these and you think you cannot deal with such patients, you should just say no to this patient or refer them to your closest competitor. Some of the red flag signs which you notice are being a manipulative patient, a patient who doesn't respect your front desk staff, a patient who doesn't respect your counselor, patient who is obsessed pointing out each and every fault which they might have on their face, and a patient who wants to look 30 years younger to what she is. So you need to find these red flags out and screen them out right before you begin treatment. Now, evaluation of a cosmetic patient needs a holistic approach, which Devraj will talk more about in his talk later on. But if this patient comes to you and tells that I need Botox, you cannot do much just with Botox in this patient. You can do to a certain extent, but you need to assess the whole face. You need to look at the skin quality. You need to look at dynamic and static lines, the bony structure, everything including fluid collection around the eyes. When you are counseling a patient for botulinum toxin injections, you need to use your words with caution. You should avoid words like, I'm going to paralyze your muscles, or I'm going to inject a toxin in your face, you're going to have pain, or we are going to freeze your emotions. But substitute these words with things like, I'm just going to slightly weaken the muscle. Botulinum toxin is a small protein molecule which we inject, which is degradable by the body. There is going to be minimal discomfort, or we are just going to soften your expression. So these are the words which make the patient comfortable and more confident about the doctor. Now, coming to the evaluation of any botulinum toxin patient, you need to first assess the patient at rest, and you need to assess the patient while expressing. So if you look at this young male who's in his early 30s and 40s, you need to assess him both at static expressions as well as dynamic expressions. After the assessment is done, so suppose when you look at him in this way, you can see that his corrugators are very strong. So in male patients, the corrugators are strong. So you need to adjust the dosage accordingly and formulate a treatment plan whenever you're dealing with such pain. Second assessment that you need to do in the periocular region is the frontalis. Now, frontalis relatively in males is a very debatable question, because males have already heavy eyebrows. So you need to approach the frontalis with utmost caution. You don't want to paralyze the eyebrows altogether. But again, the dosage required as compared to a female patient would be much higher as in a male patient as compared to a female patient. So frontalis has to be seen. The assessment of the frontalis involves looking at the muscle as a whole, whether there's a bifid frontalis, whether there's a fusion of the centralis in the center, and whether the patient has a strong lateral component of the frontalis muscle as well. Last but not the least, crow's feet, which a lot of people start getting in their early 30s, has to be assessed with patient in static as well as dynamic position. Now, once you have formulated a treatment plan, next comes to how to get the patient comfortable. So in our practice, we prefer to apply a numbing cream, which is a topical EMLA formulation, either prilocaine with lignocaine, or there are various formulations with phenylephrine as well, which cause vasoconstriction of the superficial vessels and avoid bruising. You apply topical cream in a generous quantity at all the spots or as a paste all over the injectable area. What I do in addition to this is there is an occlusion tape which you get along with the topical cream, which you can apply for faster diffusion of this product in the dermis and the subdermal area. This helps in additional and added comfort to the patient. So in the areas where this tape can be applied, you should certainly go ahead and apply it. So the frontal area is a very good prominent area where this tape can be applied. First, the patient wait time reduces. Second, the patient comfort improves. So this occlusion tape is very important when you're dealing with cosmetic patients in your practice. Once this is done, you need to choose the type of toxin. Now we have multiple toxins. Initially, it was just botulinum toxin by Allergan, but now we have Xeomin. We had Botogeny for a brief time in between. You have Nabota by Dr. Reddy's, which is a Korean product. You have Dysport. And then you have Stanox by a French company called Gufic. I personally have had experience with Xeomin, Nabota, and Gufic both. We conducted some trials recently for one of the products, and I personally have not found much difference between most of them. Maybe for Xeomin, I think that the dose needs to be increased by 5 to 10%. But other than that, all these toxins are safe enough. There have been efficacy trials. So unless a patient is very anal about using only the Allergan Botox, I offer all the other toxins as well to them. And the charges are considerably different. In means you can, for some patients, you can give the cheaper product if they cannot afford the Allergan Botox injection. So there's no difference. The reconstitution remains the same except in Dysport. But Dysport is not very freely available. The only advantage that Dysport has over the others is that the efficacy or the duration of onset of action is shorter. So in Dysport, you see the action within 2-3 days after the injection, while in Botox, it takes around 5 to 7 days for the action to set in. Dilution of Botox is very important. Usually we use preservative-free normal saline. You get it in glass vials. It is preferred because you don't want a preservative because it increases the pain at the injection site. Some people also prefer mixing it with sodium bicarb, 1 or 2 drops of sodium bicarb to reduce the pain. Concentration, I prefer 4 units per 0.1 ml, but you can choose to reconstitute it to 2.5 units per 0.1 ml. To achieve a concentration of 4 units per 0.1 ml, you need to inject 2.5 ml of preservative-free normal saline in a 100-unit vial. To get 2.5 units per 0.1 ml, you need to inject 4 cc of normal saline in a 100-unit vial. The big debate is about storage. So obviously we know that it needs to be refrigerated, but for how long? Previous studies showed that it has to be used within 4 to 6 hours of reconstitution, but we have had people and colleagues using it for up to 1 month, even after reconstitution, if stored properly. The efficacy might decrease, but there is no quantitative study to show how much it decreases. But a lot of colleagues have even used it up to 3 months after reconstitution. Luckily, we don't have to keep it for so long. But if at all you have a practice where your patients are more spaced out, then you can keep it safely up to 1 month after reconstitution in the lower section of the refrigerator. There are no special precautions required, although Xeomin is a company which says that you don't need to refrigerate the product apart from the other product. I always have this chart handy for every patient that comes to our clinic so that we can make notes and we can exactly mark which areas are to be injected in what particular dilution, so that the next time the patient comes, you can reassess the patient and then decide whether you need to increase or reduce the dose. And the patient also feels that their treatment is going up on a certain path and a plan. Now, in the periocular region, I'm going to limit my talk to periocular region today because of the time constraints. But in the periocular region, the main muscles that we deal with are the frontalis, the orbicularis oculi, which is a sphincter-like muscle all around the eye, the corrugator supercilii, the depressor, and the procerus, which are the main depressors of the eyebrow. So we need to understand the interplay between the frontalis and the corrugators and the depressors of the eyebrow to understand the brow dynamics, which is very important for an aesthetic eyebrow appearance. Now, first that we come to is dealing with crow's feet or the lateral orbicularis muscle. Now, these crow's feet is usually formed due to the contraction of the lateral part of the orbicularis. You can see that it can vary from person to person. No person has similar appearance of a crow's feet. Some might have very limited up to the orbital rim or beyond. And some people, especially after you age, get a crow's feet which radiates right up to their cheekbones as well. So you need to assess crow's feet dynamically as well as static. And 3 points of injection are usually recommended, but I sometimes go in fan-shaped fashion and inject 1 centimeter beyond these points as well if the crow's feet are too dynamic. So 3 points of injections. One thing which you need to know is that you're targeting the orbicularis muscle, which is a superficial muscle. So you need to inject just beneath the skin. You need to raise a bleb. And the usual dose range is between 12 to 24 units. You can start with around 8 units per side, 2.5 units at each point, and begin. This is a small video which demonstrates how crow's feet injections are done in a male patient. So you see, the injector is keeping well away from the orbital rim. If you're a beginner, you can even insinuate a finger within the orbital rim or keep a finger as a guard and then inject. Now, this video also shows how the corrugators are injected, but I'll come to that later. But for crow's feet, basically it is 3 points that you need to inject. Now, beware that you need to be very careful about static crow's feet, especially in older females or older males where there is significant brow descent, and the crow's feet are mainly because of static positioning of.
In the interest of time, Adit, I request you to quickly wind up.
Yeah. So not all crow's feet can be treated with Botox. Now, coming to the forehead injections, you need to assess the anatomy of the frontalis muscle. The frontalis is the main elevator of the eyebrow, and it interplays with the corrugators and the brow depressors. While injecting the frontalis muscle, you need to stay 1 centimeter above the rim or above the eyebrow to avoid depression of the eyebrow. So if you inject too low into the frontalis, you can cause a depression of the eyebrow, which is not liked by a lot of women. You need to keep the shape of the eyebrow intact, and you should not over inject to avoid frozen look. So if you look at this male, we have injected at these particular points and we have stayed well above 1 centimeter above the eyebrow so as to retain the shape of the eyebrow. There are different patterns of injection which is decided from patient to patient depending on the anatomy of the frontalis muscle, but on an average women require around 10 to 15 units of Botox injection in the frontalis, and men require around 20 to 30 units. There is another technique called as meso-Botox or watercolor Botox, as I like to call it, where I dilute the Botox with normal saline further and inject around 0.5 to 1 unit and paint it all across the forehead to get a good appearance. Now, eyebrow and lamellar complex is very important to inject when you're dealing with the brow. If a patient wants just a subtle arch of the eyebrow, you need to inject at these 3 points in the orbicularis muscle. Along with that, you also need to relax the depressors of the eyebrow so that you get a natural appearing shape. If some people have a very prominent depressor supercilii muscle, as seen in Shah Rukh Khan, you need to inject at this point. The belly of the depressor supercilii rise well within the orbital rim. But on an average, you inject around 12 to 16 units of botulinum toxin injection in the procerus and the corrugator muscles to get a good subtle relaxation. Sometimes the corrugator muscle might be very strong and they might have a static line. For these patients, although you can achieve a good result with botulinum toxin, you don't get complete result and you need to inject fillers, which Dr. Kasturi would be talking about. You can also deal with eyelid fold asymmetry with Botox by doing an interplay between the frontalis and the eyebrow muscle. And last but not the least, nowadays we can also treat a mild ptosis with botulinum toxin by relaxing the orbicularis muscle over the pretarsal area. You have to be very careful while doing this because you don't want to cause ptosis. So the dose has to be very guarded. Last but not the least, while injecting eyebrow and the frontalis muscle, you need to be very careful about Spock phenomena, where due to overaction of the lateral portion of the frontalis, the patient can get a quizzical look. This is a point which you need to inject to treat the Spock phenomena correctly. So you need to have a holistic approach while dealing with botulinum toxin injections on the face. And the aim of the injection should be to have varied expressions intact on the patient's face and not make the patient look like this, where they look similar with all possible expressions on the face. Thank you. You should also take an informed consent before. Don't consider Botox as a small procedure. Informed consent very important for every patient at every visit.
Thanks, Adit, for a comprehensive talk. Dr. Kasturi, over to you. I don't think there's anything that I can add which people don't know about Dr. Kasturi. So it's a pleasure and a privilege to have you here at MOS. Madam, please continue. Madam, your mic is muted. Madam, your mic is mute. Yeah,
Can
yeah.
you
Now
hear
we
me
can.
now?
Yeah, we can hear you. We can see your slides. Yes.
Okay. So at the outset, I would like to thank Debraj for giving me this wonderful opportunity. It's always such a pleasure catching up with you all. So I'll be speaking about the aesthetic application of dermal fillers, and also thanks to MOS for this wonderful scientific session. So no financial interest. So I'll be basically speaking on injectable dermal fillers, which we all know basically divided into reversible and the irreversible type. And also we can be divided as synthetic and a natural, and the common synthetic being the PMMA, the HOA, and also the polylactic acid. However, basically all of us, all Debraj, Adit, and all present here, we usually prefer the natural source, which is basically the hyaluronic acid. And most commonly used are either the Restylane or the Juvederm that we use in India. So advantage of this filler is that it really gives a wow effect. You get the effect immediately. Like this is some of the glabellar lines you can see just before and after the surgery on the same time, like just a 5 minutes after the procedure. And it really gives a wonderful effect. But we being an ophthalmologist, we usually use it more for the tear trough defect, which is usually defined as an oblique fissure like concavity, which separates this palpable part of the orbicularis muscle from the orbital part of the orbicularis muscle. And this is what you see a tear trough ligament, or laterally, which we call the orbitomallear ligament. This is basically a Z-shaped ligament, where medially we call it a tear trough ligament, and a laterally. And this has been documented very well in one of my patients who was having a thickening of the muscle, and when I was evaluating, I could see this beautiful tear trough, and which I'm thinking that I should share with you all. So this tear trough defect can be either a correct tear trough, which is already I have explained the separation of the palpable part of the orbicularis from the orbital part of the orbicularis, or an indirect or a incorrect one, which is basically nothing but a nasojugal fold, which is basically a separation of the orbital part of orbicularis from the levator labii elegans side. So all this arises because of the change of a positive vector to a negative vector, where you see the malar eminence which recedes, and this malar lines goes much behind the corneal plane, which we call the development of the negative vector, as you can see here. And also because of the changes, which are the visible changes, which we can see in the skin, which has been shown very well by Adit in the form of the wrinkles, and also the hidden changes, which usually involves the fat, the ligaments, and also the bone. So when you have a very prominent tear trough, so dermal filler not only fills up this tear trough, but also it takes care of the pigmentation it takes care of the shadowing effect, as I can see. So in such situation, this is a lady which I injected just yesterday, and you can see like this is so wonderful to see the immediate result after injection dermal filler, where the volvella has been injected, and you can see all these bags, and also the pigmentation or shadowing is much less free and post following the dermal filler injection. So in situation where you have very minimal fat prolapse and also with the pigmentation, it gives a beautiful effect, as you can see in this some of my patients before and after the procedure. And the most important part is the concealment of this fat. You see this fat, this is a month post injection, and you can see the fat is totally concealed, as if you have done a surgery for this patient. So this also not only takes care of the tear trough, but also it takes care of the orbital fat, the fat prolapse, which is seen in many of the patients, and thus it converts this negative vector, which I have already mentioned, into a positive vector, where you can see now the malar eminence like much interior to the corneal plane. So this is also just immediate after a procedure, a cannula treatment that has been done. So not only taking care of the tear trough, the valley, but also it takes care of the heel. And this can be done either by injection technique, as you can see here. Like this is a classical point and a 3-point injection, which we call the TT1, TT2, TT3. What I have already mentioned the Z pattern of ligament. That is this is your tear trough ligament, this is the orbitomallear ligament, and here you have the cutaneous zygomatic ligament. So I draw a zone between this ligament and try to fill up in this zone, and go deep. When I use a needle, I go deep down into the periosteum And the classical 3 points are one in the center and one in the lateral and the middle. See the difference. This side I have injected, this side I have not injected. You can still see the trough here and also the fat here, and then once you inject, you can see the difference on the both the side. So this is what I want to show, that this is not only managing the tear trough, but also it manages the fat, which we see even in very young patients we see. So here, this is another technique of injecting, which instead of using a needle, the same thing, what we do a cannula. You can see here, this is what I draw the zone between the two ligaments and try to place the product within this zone. And even when I use a cannula, what I do, I go in a small droplets. I put a small droplets along the whole of the infraorbital rim, and then you can see the difference, as you can see here, this lady here just before and just after the procedure. I think this is few weeks after the procedure, and you can see, 2 days after the procedure, and you can see the trough along with the pigmentation, it is being relieved following this procedure. So when you have a minimum fat herniation, many people ask me whether we should go for a filler or we should go for a surgery. So what I believe is that if your orbital fat lies behind the plane of the anterior lacrimal crest, so these are the situation where we go for injection dermal filler. But in a very elderly people, and this situation, we do not go for blepharoplasty. So in elderly people like her, you have so much of bags, and when you see that this fat bag lies much anterior to the plane of the anterior lacrimal crest, so these are the situation where we go for the lower lid blepharoplasty, and basically the process of tissue preservation, where the same orbital fat, you release this orbitomallear ligament and transpose this orbital fat down into the SUFI region, where you can form beautiful tree pedicles, and then you can transpose it. So, but sometimes what happens when we do a blepharoplasty and when we don't transpose it, what happens post-operative, we not only lead to a lot of hollowing, periorbital hollowing, but also you can see the shadowing being coming back. So these are the situation where we do a post-blepharoplasty augmentation with injection dermal filler. As you can see here, the CK3 point that is in the malar fat point, you inject in the G point, and then you inject with your cannula the 3 points, which I have already mentioned, the TT1, TT2, TT3. And then you see the immediate changes, the pigmentation. This is just before injection, post-blepharoplasty. Here you can see the pigmentation much less, and also you see the shadowing and the hollowing is much less. So this has become a very common indication for most of us, especially in the early days when we used to do a blepharoplasty and we used to remove all the tree fat bed. And when the patient comes to us years later with changes in the skin and changes loss of the volume, so these are the situation where you need to inject the dermal filler, and where in such situation I usually prefer the cannula, and you can see the amazing result. Like this is the same lady, you can see this whole area has been filled up with the dermal filler, and when she animates, you can see this is before the injection post blepharoplasty. After the injection post blepharoplasty, when she animates also you do not see the the wrinkles and also the fat loss that is being seen. Another common indication for many of us which we practice are for the lips, which usually gives a good volumization of the lips, which can be done with both the injection technique or the cannula technique. I prefer the cannula because it doesn't lead to any bruise. So most of my lips nowadays I go with the cannula, and also for the full face I usually prefer the cannula. And you can see the wonderful result that is before and after the procedure, and it really gives a very good rejuvenation of the lips and also a good volumization of the lips, as you can see here, the before after. This is a beautiful volumization if you look to the pillars out here, and also the sharpening of the sharpness of the cupid board, and this really makes it looks very beautiful, the same lady before and after the procedure. They brush, like initial, I think their brush also does lots of nose augmentation, and especially I feel that this is a wonder product for the nose, especially in situation like this, a traumatic situation where you have so much deformity, the whole of the nasal bridge is being lost. In such situation, the filler injection really gives a very nice nose augmentation. An advantage of a nose augmentation with the filler that it lasts pretty long, because the nose hardly, this is the most immobile part of the face, so it lasts approximately 2 to 3 years, and it really makes your nose look so much slim following the filler injection. A mid face is a very common indication where we inject into the different points of the face, as you can see here. And look, this is her face when she first came to us, a very virgin face, and then you can see her, this is after the second injection. and this is after the third. So once they keep on coming, you can see the ovalization and also the contouring looks much better as she keeps on taking it. Chin and jawline, you can really, this is one of our very renowned people out here in my place. You can see she really wants a very sharp jaw, a very sharp chin, and this is how you can do following a dermal filler. So I'm just showing, ending my presentation with this, a full face filler, where I've already mentioned that we usually divide the face into the three hierarchy, divide into the three parts, and the most important part for us is the periocular region. I think time is over. Or do I have time, Debraj?
Yes, ma'am. You have a couple of minutes left.
Okay, so you can see here, and then this is first the periocular region that we do, then we go for the mid face, and then we go for the lower part of the face, like the jawline. So this is how we do. This is a classical, in the mid face, we have the 5 points, which is the one in the zygomatic arch, then the zygomatic eminence, and the premalar fat pad, then you have the pre-auricular region, which we usually call the CK4 point. So these are the points which we usually go for the lifting of the mid face, as you can see here. And once you're done in the periocular region, you're done with the mid face. Now you do the lower part of the face. So this is where you put a direct injection. In some points, you have to use the needle because you need to reach down deep into the periosteum. So this is the C1 point which we inject in the chin, and then you can go to C2 point where you inject in the just above below the lips, and then here these are the side where what we prefer using a cannula in order to make a very good chin and also to give a beautiful jawline. So this nowadays, which I have already mentioned, the advantage of using a cannula is the bruise is much less and also the recovery is much faster. So it is not that it does not have any complication, because this is not a medical, this is not a medication, it is only a device. So there are no set volume or set concentration that needs to be used. So sometimes it can be too much and sometimes it can be too little, and it can land up situation like this, the lumps and bumps, which can be taken care with the hyaluronidase. And so these are some of the patients, and one of the major complication is a vascular complication, which can be formed in the form of the necrosis. But the most dangerous is that blindness. But we have an advantage because in the face we have this angiosomes, and each of these have either the choke anastomosis or the true anastomosis. Advantage of choke is that if you touch this in undergo spasm, so it will lead to only a local complication. But the disadvantage of the true anastomosis, because it will lead to unrestricted flow and also to the point of the retrograde flow and lead to the blindness. So we should always have the filler cascade with all the medication ready to tackle any of the complication.
Ma'am, I'm sorry, but if you could just quickly wind up.
Thank you very much for your patient hearing.
Thank you, ma'am. That was fantastic as usual. And every time we listen to you, we discover and learn something, and it's fantastic. Thank you so much. It's my pleasure now to play the video of my close friend, Dr. Akshay Nair. Just one moment, please. Let me just open everything and then play it. Just sharing the screen now. I hope you can all see the screen.
Yeah.
I'd like to thank the Maharashtra Ophthalmic Society for this opportunity to speak at the virtual conference 2021 on blepharoplasty. My talk is divided into two halves, the first half focusing on lower lid blepharoplasty. The most important thing in lower lid blepharoplasty is assessment. By thorough assessment, we are able to figure out who is a good candidate for a blepharoplasty and who is not. Once you have decided that a patient is a good candidate, we then need to finalize what is the ideal route to give optimum result for surgery, whether a transcutaneous route or a transconjunctival route. So typically when a patient presents, they have complaints of lower eyelid bags or boggy swelling or tired looking eyes or any other nomenclature that they call it. If it is true lower lid fat prolapse, the appearance worsens on upgaze. This is because here the superior rectus and levator are contracting. Conversely, the orbicularis and the inferior rectus relaxes, which reduces the muscle tone, allows the fat to bulge through the septum. So when they look down, obviously with the lower lid retractors and inferior rectus tightening, the fat is pushed back in and the appearance improves on down gaze. Now in elderly patients, you get a similar effect where it worsens on up gaze and improves on down gaze, but only thing here is you now see excess skin folds which are seen as redundant wrinkles. This is because of the lower lid laxity and excess skin. A lower lid laxity can be also judged from the fact that there is inferior scleral show, which means that a horizontal tightening or canthal fixation may help these patients. It is important to differentiate lower eyelid fat prolapse from malar mounds, which are fluid-filled bags on the malar prominences and are not amenable to treatment through a transconjunctival blepharoplasty. Now compare these two photos. What we see on the left is lower lid bags which extend along the entire length of the lower eyelid over here. Whereas here, it is focally restricted only to the medial compartment and on the right side, and all you have also is a prominent tear trough hollow. So a good guideline is to draw a mid-pupillary line and to see if the swelling extends on the lateral half of the mid-pupillary line. Now you can see that on the picture on the left it does, whereas on the picture on the right it does not. And as we would expect, the appearance worsens on upgaze. So the patient on the left is a good candidate for a transconjunctival blepharoplasty, which is what she underwent, and the patient on the right may actually get a better outcome through a tear trough hollow filler, which is what she underwent, and you can see the optimal outcome in her case. So a quick video on transconjunctival blepharoplasty. The landmarks are important to know. When you see a patient with such a lower eyelid bulge, you can identify each swelling which corresponds to the fat pads, the medial, the central or the middle, and then the lateral. Now, the fat pad location is important because between the medial and the middle lies an extremely important structure, the inferior oblique, which we must be mindful of not to damage. For surgery, I prefer an infraorbital block followed by local infiltration. My incision is about 3 to 4 millimeters below the lower edge of the tarsus, and then you directly through a retroorbicularis approach reach the septum, and then you're able to open it up directly. Once you visualize the fat pad, gentle teasing of the fat by opening up the small loculi and the septae are important. You can then tease it out like you are seeing it over here. Once the fat prolapses out, inject local anesthetic into it before you resect. Always cauterize the stalk or the base and then cut such that it does not retract back into the orbit and bleed. It's very gentle teasing that is needed and no aggressive large bold cuts required in this area. You can either resect or transpose based on your comfort level or the requirements of the patient. A good maneuver is to gently put pressure on the globe. This causes any fat to prolapse outside through the wound, and that gives you an idea of how much you need to resect more. The wound is then closed with 6-0 vicryl interrupted sutures. A single layer is good enough. So these are some patients who have undergone transconjunctival blepharoplasty. The gentleman on the left had only a lower lid blepharoplasty with fat excision. The gentleman on the right had a lower and upper eyelid blepharoplasty. Again, breaking the myth that it is largely women who want blepharoplasty. We are now seeing that men are equally willing to get cosmetic corrections done for blepharoplasty. This was a patient who underwent a transconjunctival fat transposition rather than an excision. A filler was also offered to him, but he preferred something more long-lasting and permanent. So there, we've transposed the fat to completely obviate that swelling. Transcutaneous blepharoplasty is needed in patients who, in addition to fat prolapse, have redundant skin. And it's important to know how much skin needs to be excised without causing lower eyelid retraction. So you do a pinch test. Now, With this much amount of skin being pinched, observe how the lower lid has come down. This indicates that if you excise this much skin, it is likely to cause lower lid retraction. So you need to reassess. And now, with this much amount of skin being excised, a smaller pinch, you can see that the lower eyelid position is maintained with respect to the inferior limbus. So this is a good amount. The next step is, of course, to mark that much area. And in these cases, I prefer to use a blade rather than a radio frequency cautery for the skin incision. Corneal protector with traction sutures are always a good idea because they provide a good taut bed for the incision. Removing the strip of skin and orbicularis can be done with a monopolar radio frequency cautery. And once that is done, the surgery is pretty straightforward. You have direct access to the fat pad. Again, the anatomy is beautifully seen, the medial, the middle, and the lateral fat pads. Inject and then excise. After excision, you might want to again assess the same way, gentle pressure over the globe to see how much fat prolapses, and that gives you an end point to how much fat you want to excise. You don't want to remove intraconal fat in this case, so be a little conservative. And then, of course, the skin is then draped up. This is the maneuver described by Dr. Guy Massey. The skin is draped. You can also add canthal tightening procedures in the same surgery through the same incision. This is the post-operative outcome. Subciliary scars, when done with meticulous closure, leave behind very little remnant. So as you can see in this patient, after 3 weeks, you can barely make out a subciliary scar. Complications are plenty and we need to be very careful. In Indian patients, using a radiofrequency cautery on the subciliary area can leave behind nasty scars, as you can see in this patient. If there is retraction, contraction, or any other scarring that is seen, it is better to intervene early with either corrective surgery or adjuvants like 5-FU and steroids to prevent functional complications later on. Adjuvant procedures, especially in lower lid blepharoplasty, are common. For example, this lady came with lower eyelid fat bags. We did a transconjunctival blepharoplasty with fat excision. Now you can see there is a hill and a valley. There is a bulge and then the tear trough hollow, and then there is dissociation of the lid cheek junction, which is why the cheek is then prominently seen as another hill. So excision of the fat led to a little amount of skeletonization. And here we've gone in and smoothened the lid cheek junction with 0.5 cc of hyaluronic acid gel. The result, compare the before and the after, and you can see a definite stark improvement. Upper eyelid blepharoplasty, again, assessment is important. We need to understand that upper eyelid and upper brow asymmetry is usually acquired, but there may always be some minor discrepancies between the right and the left side, and it is important to recognize these subtle differences preoperatively such that you can equalize them. In women, it's important to know that the eyebrow lies about at least a centimeter above the supraorbital rim, whereas in men, it lies exactly on the supraorbital rim. Make sure you're able to pick up brow ptosis in patients who have it. In this case, if you were to see that there is true brow ptosis, and a blepharoplasty in this case will actually worsen the brow ptosis. Therefore, this was a patient who underwent an endoscopic brow lift. As you can see, the pre-tarsal show has improved and a blepharoplasty was not needed. Superimposition of the bony architecture shows that the brow position has risen to its normal anatomical position. As is for any eyelid position, any eyelid surgery, assess thoroughly the levator function, the amount of motility, and make sure you rule out myasthenia or any other such potentially complicating issue that could be underlying. In blepharoplasty patients, make sure to pick up ptosis early. This is a gentleman who underwent upper eyelid blepharoplasty without simultaneous correction of the ptosis. The result is that the left eye looks improved, the right eye. In younger patients, we see blepharochalasis and dermatochalasis seen in older patients as a result of physiological aging. So quickly run through a surgical video. Before that, the most important thing to know is that there has to be a measured approach, literally and figuratively. We need to make sure that there is at least 2 centimeters of residual skin height, lid height, between the edge of the lower edge of the eyebrow and the lid margin. At least 20 millimeters should be left behind in order to avoid post-operative lag of thalamus. In this video, we have a lady who presented with some amount of hooding on both upper eyelids, and she wanted an improved pretarsal flow. Also, there is subtle brow ptosis, which we address at the same sitting. So here, the most important thing is lid crease marking and marking of the wound, of the amount of skin that is going to be excised. Measure to make sure that the lid crease is symmetrical in both eyes and you have adequate skin, at least 20 millimeters from the lower edge of the eyebrow to the lid margin after wound closure, to make sure you avoid lag of thalamus. In this case, local infiltration is adequate, and I prefer to use a radiofrequency cautery to excise the skin and a small thin sliver of orbicularis. This is because the lid crease gets hidden, the scar gets hidden in the lid crease incision, and therefore it does not appear very, very prominent. Once this is done, it's important to spread the wound out, open up the septum such that you are gently able to dissect the amount of fat that you want to. In this case, there was a limited blepharoplasty done because there was not much upper eyelid fat prolapse. In this case, we have also done an internal brow pexy, which starts by dissecting along the suborbicularis plane superiorly. So here we are now dissecting suborbicular. Taking an absorbable suture in a double arm way, you anchor the sub-brow fat directly onto the periosteum. By doing this, you are suturing the sub-brow fat to the periosteum and creating a subtle lift there. Once this is done, the skin wound can then be closed in layers, orbicularis with 6 or vicral interrupted sutures, maybe 2 or 3, and then the skin is closed in proline continuous fashion. You can see that the postoperative effect is good. The pretarsal show has improved, and there is a subtle lift at the lateral eyebrow. Blepharoplasty surgeries previously done elsewhere, and they want additional corrective procedures. Give full disclosure of the risks. Give them realistic expectations. Show before after photographs of other patients for them to get a true sense of the healing process. Many times all they need is reassurance, and for this they may come multiple times. Most important is that you must photo document at every visit. So therefore, with a thorough assessment, good counseling, and customized management, we all can achieve optimal outcomes of blepharoplasty, be it an upper lid or a lower lid procedure. If there are any questions, I'll be happy to take them.
Thank you, Akshay. I will now move on to my presentation. Akshay will ask all the questions at the end of this. Just sharing my screen. I hope my screen is visible.
Yes. Yeah, Debra, we can see your screen.
Okay. So at the outset, thank you everyone for inviting us today. And we'll try and keep this to about 10 minutes. So we have a couple of minutes at the end for speaking. A couple of disclosures are in place, and I've been faculty with all of these companies for a decade plus now. And as we know, the OG curve is what we see on young women. And that is basically what determines youth. That is an S-shaped curve, resulting from the concavity in the under eye area, which Akshay so beautifully demonstrated, followed by the convexity of the malar area, and then going downwards. Now, obviously, if we think about facial aging, it's mother gravity being ever so kind, and mother gravity sort of pulling all of us downwards and medially. So if downwards and medial is facial aging, it becomes important to consider upwards and lateral movement as anti-aging. What happens as we age is there are a number of subliminal and clinical factors which are occurring. For instance, the fat is undergoing a redistribution. So initially, when we are younger, there's more superficial fat. So therefore, the face appears plumped up. But as we become deeper and as we become older and older, the deeper fat becomes more, leading to the folds and leading to the development or the loss of fat superficially, leading to lines which develop. Also, what happens is as we continue to age, there is also a change in the bony vasculature. And essentially what is happening is that the bed or the bony structure is becoming smaller and smaller, while the soft tissues are becoming more and more. So essentially, aging is a process, we believe, by which the bed sheet is becoming more for the bed, leading to all those loss of definition and the increase in folds, etc., that we end up seeing. Now, if you understand that ultimately it's not so much an excess of skin, it's a redistribution which is occurring, you understand why surgery in some cases may be an overkill. However, you need to know surgery, and that's what I'll be discussing in this particular presentation as well. We conducted a study, and this was the first aging study which was conducted on the Indian face. It's a serial photographic documentation study which was conducted by us. And if you look at some of these pictures, you can sort of start to understand how Asian Indians really age. You look at this lady at 23 and you look at her at 71, and you can see how all her facial tissues have slid downwards and medially. And that's continuing to create two sorts of problems: folds in the mid face and hollows in the under eye areas, etc. The upper face, more or less, is relatively well preserved. Again, another lady. And in this lady, you can see how the jawline starts to lose shape, how the cervicomental angle, which used to be very well defined when someone was young, ends up becoming, worse and worse as we age. And that's what aging is all about. Men, of course, not in this particular gentleman, but many men also continue to lose hair as they age. And as they age, that also adds a significant component of aging. In general, what we found out was that the upper third of the face ages very well in Indians, especially because we have melanin in our skin. We have Fitzpatrick type 4 to 5 mainly skin. And so as a result of which the upper third ages very well. It's the real problem is in the mid face and the lower face, especially because anthropological studies have clearly shown that the mandible in the Asian Indian population is not as well developed as the Caucasian population. That is also the reason why we tend to start losing definition and develop double chins more as we age, even though our weight may have otherwise remained the same. When you look at nasolabial fold formation, very simple nasolabial folds which are there, which are grade 1 to 3, you just need a little bit of filler, and we'll be demonstrating that shortly. There are other things which need to be taken care of as well. When a patient comes in to us, they want holistic treatment. They are not interested in our specialty. They are not interested in which residency we got trained at. It's important for us to acquire skills as we go along, because ultimately people want to be treated holistically. For instance, in this 28-year-old, she came in and she wanted to know, her first thing was maybe she has squint in the right eye, which she does not. You can see the light reflects. But you can see that the right side of the face is very different from the left side of the face. And so you can see how there's an inferior scleral show on the right hand side, which is not there on the left hand side. And also how the right eyebrow is far higher than the left eyebrow. When she smiles, these changes get more and more accentuated. And you can see that the left eye actually looks smaller. And you can begin to appreciate how subtle inconsistencies or subtle asymmetries can make such a big difference in the way we are viewed or perceived, especially under the high definition cameras. In this particular patient, instead of going ahead and performing a surgery, we performed a little bit of Botox, couple of units in the hypertrophic orbicularis oculi, and then a little bit of fillers, which is the Juvederm volbella, which is being used. And then this is how the patient looks after. But more importantly, now when the patient smiles, that asymmetry has been addressed to a large extent. You can see the rest of the face is pretty much the same. It's actually just the way the eyes are behaving, which causes the entire face to look much more symmetric. Go from here to there, and to have the fillers last approximately about 2 years plus, while the Botox has to be repeated every 3 months, is not a bad option, considering that Botox takes less than 10 minutes to perform in the clinic, and it costs possibly a few hundred rupees or 1,000 rupees, as opposed to surgery, which might be more onerous in terms of cost of surgery, as well as the cost of the procedure, in terms of financial cost itself. There are patients who come in for whole face holistic rejuvenation. And this is at a time when basically these patients used to come in with us with only Botox and fillers at our disposal. I'm just trying to demonstrate by doing the botulinum toxin and the fillers. And at that time, we didn't even have the high G prime fillers many years ago. You can actually convert patients from here to here in the space of literally a few minutes. And I think my colleagues before have gone through in detail, so I see no reason to continue on that path. But basically, even if you knew only how to perform botulinum toxin and fillers well, you didn't do threads, you didn't do surgery, you could still possibly give good results to about 50% of your patients. And that's the good thing. That's why you should learn this. Now, in a light face, if you have a nasolabial fold, just using a mild low G prime filler and coating this particular fold can cause this fold to get hydrated and look far better, because this is a filler which will also a hyalocross filler which will absorb water as we go along. This fold will look much better in a few weeks' time. Then there are some people who have very heavy faces. And in this Middle Eastern lady, having this heavy fold means that the mountain has come down. And so until the mountain is taken up, the valley cannot be made better. Just don't stick a needle and try to fill it up. Try to figure out a way using either threads or using a high G prime filler, as we used in this particular case, on the lateral aspect of the face to get the mountain to move up. And once the mountain moves up, you can use a lower G prime filler in order to target the valley. So therefore, it's a creative use of two types of fillers, which some of our colleagues are now also calling a G prime lift or a G facelift. Facial thread lifts are very important, and facial thread lifts are an important way of making sure that the patient can appear years younger. There's an outpatient procedure which is done in the doctor's clinic. Threads have barbed wires around them. These are all absorbable threads, and it's like a rose stem which is going and engaging the facial fat and causing it to get lifted up. Results last 2 years plus, can be done only with prilocaine. So in heavy faces like this, using the threads to lift that particular part of the face and then using fillers to fill up the valley is a good result. And this is a patient who also had a fractional CO2 laser, and you can see the scab sort of falling off. Now, changing the contour of the face using a high G prime filler, a low G prime filler, and threads means that the entire shape of the face can be changed. And this in turn leads to people being viewed completely differently. You can see how this lady looks a lot more elegant, graceful, and probably a little bit more feminine as well because of the usage of the procedures. Knowing surgery is important, and the mid-face lift is one of our favorite procedures, especially in Asian Indian faces which don't age as badly. Use the intraoral route and use the 2-0 proline sutures, which are then which are used to be taken through the malar fat pads. And then at this moment in time, the suture has been threaded up above the zygomatic arch and through an incision which is behind the hairline. And the moment you do that, you see that the left malar area appears higher than the right malar area. That's the sort of traction that you get. This is really a workhorse facelift. We literally don't perform the facelift nowadays, full facelift, because this gives such great results. Then tie this on top of the deep temporal fascia, and the results that you get will last a couple of years, which can further be augmented in terms of a number of procedures by doing the carbon dioxide laser resurfacing. So in general, you could take patients from here to here by performing the blepharoplasties, by performing the mid-face lifts and the CO2 lasers, or from here to there, and make sure that patients look much more rejuvenated and younger. The facial liposuction is something that we perform very regularly, and that means taking fat from the lower, heavier parts of the face and draping or putting that face in the upper parts of the face. And when you do that, you can actually change the facial shape significantly. And if you know all of these techniques, you can sort of transform faces like the one that we've transformed. Please note how the patient looks much younger, but also looks much more aesthetic and doesn't look done. And that's where we need to leave our patients, where they don't look done. In the interest of time, I'm just going to stop the rest and open it up for discussions. There's a lot of rhinoplasty stuff, etc., nasal threads that we end up doing. And I think that, there's only so much that can be spoken about in a short time. So I thank you for your kind attention and a very patient hearing. And if there are any questions, all of us would be happy to take them and take it from there. Thank you very much. Sorry, that's a really long presentation, isn't it? Dr. Kasturi, ma'am, I think Sumit is also here. Hi, Sumit. So good to see you. If there are any questions or anything that we like to discuss, we just have a couple of minutes. We were all a little bit over. So we have about 3 to 4 minutes. Is there anything specific that we would like to discuss? Sumit, thanks for having us here. Thanks for organizing all of this. And thanks for being on the panel as well. Please, if there are any questions that you note which have been sent across, you may please send them here. And open the floor up and over to Dr. Kasturi first, followed by maybe 30 seconds of inputs from all the other speakers before we conclude.
This is an excellent session and you have covered all the topics very well, and right from very basic techniques of botulinum toxin injection, Amit has shown very nicely that what are the indications and contraindications, and we have covered fillers, the surgeries. Akshay has shown beautiful videos, and Debraj, you are always one of the awesome speaker. Like we all look forward to listen to you. So I don't have much to add to anything, but one thing which is very interesting, I feel that being an oculoplasty surgeon, our domain is right from the forehead to the chin. So we need to take care of every features on the face, and not only the periorbital region, because nowadays we need to take care of the mid face, we need to take care of the lower face, and also we need to take care of the nose. And the nose, which can be managed both by surgical rhinoplasty and also non-surgical. And I feel that non-surgical is also a very minimally invasive technique, and which usually gives amazing result. So congratulations to all the speakers. And Debraj, if you allow me, I need to join the next session.
Absolutely. Thank you, ma'am. Thank you. Thank you. Thank you. Adit, any thoughts from you? Thank you so much, ma'am.
No, I agree that this was a wonderful session. Unfortunately, Saturday morning is a press time for everyone. But I think all the speakers did good justice to whatever was, and we look forward to having more such sessions, especially in general ophthalmology conferences, so that the awareness about the subject and the specialty increases. It is the rise. And I see that after maybe 5 to 10 years, we should be on par with most of the world with this specialty as well, with all the hard work that is being put by everyone in developing this subspecialty in this region.
Absolutely. Adit, it's amazing to see oculoplasty go from oculoplasty to oculofacial and then go on to facial plastic surgery. And I would like to remind everyone, especially all the other next session has already joined, but amongst the people who perform facial plastic and facial cosmetic surgery in the US, 40% come from an ophthalmology background. Let's not forget that. And let's look at the entire face holistically as we develop our subspecialties. Welcome to Dr. Anand Pangarkar. Welcome to Dr. Pankaj Shah, Dr. Prakash Marathe. Thank you once again to Dr. Sumit Lahane and Ragini Madam, Lahane Sir, Dr. Samant, everyone. Thank you so much for having us here, and moving on to the next session.
Thank you.
Thank you all of you for completing the session in time and giving us the hall in time. Let's start with the next session, practice management. I welcome you all. We have an exciting session of practice management. We have Chairman Dr. Jignesh Taswala, Co-Chairman Dr. Anand Pangarkar, Convener Dr. Hanuman Bhosle, and myself, Moderator Dr. Pankaj Shah. Jignesh sir? He is not yet joined. Can we start the session, sir? Pangarkar, sir?
Good afternoon, everyone.
Good afternoon.
This is an important session of practice management, and we are covering varied and many aspects of practice management and how to become a successful practice manager. I invite Dr. Prakash Marathe, past president of MOS, to speak to us from his experience of leadership in work.
Sir, Dr. Prakash Marathe will be speaking fourth. You are the first speaker.
Okay. Okay.
Hello.
He will be joining us in a...
Yes, I have joined, but in between I will be shifting to my desktop afterwards.
Yeah. So let's start with Dr. Anand Pangarkar, sir.
Okay.
He will be speaking on need to focus in diabetic retinopathy in national program. Dr. Anand Pangarkar is a past secretary of MOS. and has been today the election results. He has been contesting for second vice president. I wish him all the best for the same.
Thank you, Pankaj. Thank you.
And hope
Yes,
to have a
definitely.
great grand party soon from him.
No results are final till they are announced.
Has the screen been shared?
Has the screen been shared?
No, not yet. Not yet.
Okay, just a minute.
Meanwhile, next speaker is Dr. Jignesh Taswala. He has also not yet joined. If he doesn't join, Rujita Machwe, madam, please be ready with your presentation next.
Yes, I'm ready.
Yeah.
So shall we start with Rujuta?
Rujita, madam, are you ready?
Yes. Shall I start?
Yeah, then we'll start with you.
Okay.
And it's an interesting topic from you. Sound and peaceful sleep, essential for fruitful ophthalmic practice. So let's hear from Dr. Rujita Machwe, how sound and beautiful sleep we will be having later on. Please, over to you, madam.
Yes, yes. Can you see my presentation?
Yes, yes, yes. Please go ahead.
Make it full screen from beginning.
Yes. Yeah. Is it okay now?
No, not yet.
Okay. Wait.
Start from beginning.
One second.
From beginning, madam. Don't close it. Ah, yeah, correct there.
Can you
Click
see?
it.
Can you see now?
No, click it.
Yes, but you have not made the full screen, is it?
I have read it from my side. I'll stop share and do it again once more.
Right.
Yeah, I'll do it 1 second.
Yeah.
Can you see now?
Yeah, please go ahead.
Okay. A very good afternoon to everybody. At the outset, I would like to thank Dr. Parikshit Gopte, President MOS, and Dr. Ragini Parekh, Chairperson Scientific Committee, for giving me this opportunity. And I congratulate all the organizing committee members for a wonderful, wonderful conference. I'm Dr. Rujita Machwe, and today's topic is sound and peaceful sleep, essential for a fruitful ophthalmic practice. So people may think that I'm going to talk about life and work balance, but no, actually I'm going to talk about a balancing act between practice, money, ethics, and success on one side, and legality on the other side, which has become a very, very important and integral part of our practice. So I would say there will be 10 commandments of surgeon's wellness, and the important ones are: thou shalt not resist change, honor thy limits, thou shalt continue to learn, and so many more. So for a peaceful sleep, we have to have a successful practice which is litigation free. As we all know that patient-doctor relationship is going for a toss nowadays, which was considered to be a godship in the past, has become an adversarial relationship. The patient has to understand the doctor is neither God nor demon. And because of this, there is a trend of defensive medicine nowadays. Therefore, costly extra tests, invasive treatment, and more referrals. So who are the saviors in this scenario? Communication, very, very important nowadays in medical profession. Documentation, ethical and protocol-based practice, mishap management, indemnity insurance, and yes, prayers, definitely. So we'll just touch upon important topics. I'm not going to talk about the indemnity because that itself is a different topic. So because of want of time, communication skills and counseling, which is becoming rare nowadays and which is far more important to avoid litigations. The chair time given to the patient is very less according to patients, and most of the litigations are because of that. Empathy shown towards patient and the patient relatives also very important. Whatever you want to convey to the patient has to be really clear and crisp, and preferably in the language of the patient. The risks, side effects, alternative finances involved, and the prognosis of the procedure or treatment, everything has to be clearly explained to the patient. As regards consent, for taking any consent, the patient has to be more than 18 years, should not be insane. The disease, treatment, alternatives, and complications, of the procedure. Everything has to be very well recorded in the consent before you take it, and it has to be a voluntary consent. So real and valid consent is very important. If you want to go to more details about how the consent should be, you can refer to the Supreme Court Samira Kohli versus Dr. Prabha Manchanda case. And we are really thankful to AIOS and MOS because they have made such great inputs in consents for us, and especially MOS, who have given the consents in regional languages also. So thank you so much. So regarding the case laws in consent, in the first case, cataract operation was done and lack of preoperative care was there. No high-risk consent was taken. There was post-operative loss of vision. Negligence was held and compensation was awarded. The moral is that whenever necessary, high-risk informed consent is a must and has to be taken separately. In the second case, cataract surgery was done on a 76-year-old patient. Consent of only grandson was taken and not the patient. There was loss of vision, but that case was well defended and no negligence was found. But because the patient consent was not taken, penalty was awarded. So what is the moral? That always take patient's consent. Though the patient is illiterate, you can take a thumb impression, and doctor should also sign it, not just the patient. As regards the documentation, this may include different electronic health records, audio, video, emails, etc., daily case records. The copy of discharge card is very important. Usually we fail to procure that. So we have to have a copy of discharge card also. So what is the duration of storage of these documents? According to MCI, 3 years, consumer protection, 2 years, criminal case forever, income taxpayer 6 years. So whenever you feel that some complication has occurred and the patient may go afterwards for some criminal case, then you have to store the documentation forever. And how to destroy when we want, for example, stop the practice? Now you can just put a notice in the newspaper. Around 2 weeks and 1 month, you can destroy the documents. The hard copies and soft copies can be stored forever. So documentation case laws. In the first case, cataract operation was done and there was a post-op damage to the eyesight. Why there was negligence? Because they were poor record keeping. So you have to have that the documents should be very clear and procured, and all the documents should be stored. Now comes the ethical practice. Advertising for soliciting patients directly or indirectly is an unethical act. Medical counsel can, upon complaint or suo motu, take action and suspend the registration of the RMP. This applies to the various advertisements in media of centers for correction of refractive errors with lasers especially, and even courts consider this very serious.
And the
case laws regarding it.
Runner-up is Dr. Rajesh Joshi for his photo essay on.
Can I speak? Can I continue? Hello?
And the last year's Golden Hands Award by residents, again by the Lakshmi Charity.
Should I stop? Refractive surgery for myopia was done. Eyesight worsened, and the patient sued that the misleading and false advertisement was done by the doctor, which was accepted by court as unfair trade practice and deficiency in service. Okay, so we are ethically not supposed to procure patients through advertisements. So what is the way out? We can give information in various ways. Like for example, videos on YouTube. Like I am having a lot of videos on YouTube as regards COVID and eye, then eye care, annual eye care and all. So we can have advertisement. This is the way out for the advertisements. Then standard guidelines. Okay, so Bolam test, it states that a doctor is not negligent if what he has done would be endorsed by a responsible body of medical opinion. So protocols and guidelines are very important and are to be followed, and those are the saviors sometimes. So let's just see one case law. That cataract operation was done and lack of preoperative assessment and the patient died. So detailed preoperative investigations are a must, especially while managing comorbidities like hypertension, diabetes, or some cardiac problems. In case of mishap, management documentation is very important. Emergency box should be ready. Avoid prescription on emergency drugs. When there is an emergency, avoid giving prescriptions to the patients. Involve a rush team. Inform police, take collective responsibility, which is very important, and professional indemnity insurance is a must. So just we'll see one case. In a camp, there was a mishap And this is Mittal versus State UP. And more importantly, what is that? The Supreme Court approved the guidelines for norms and conditions for conduct of ICAP. So this is very important in case of mishap management. So basically what I want to say is that the amount of compensation sometimes doesn't really matter, but the decision becomes a precedence which a subsequent judge in a similar case would defer to and follow while giving the judgment. And that shall hurt much, much more. So there is no defense when res ipsa loquitur is accepted by the court. That is the negligence, if there is gross negligence and burden of proof is on the doctor. For example, in ophthalmology is applied in case of surgery without consent, surgery on the wrong patient, surgery on the wrong guy. Okay, so gross error of commission and omission. So basically the art of medicine cannot be inherited, nor can it be copied from books. Communication skills, valid consent, due care during treatment, surgery, etc. are of utmost importance. Please follow ethics and guidelines. And always remember, a pat on the back is only a few centimeters away from a kick in the butt. Wishing all of you a litigation and hassle-free practice and sound and peaceful sleep. Aristotle has aptly said that we are what we repeatedly do. And so, dear friends, make it a habit of having all the saviors all along life with you and have a happy practice. I hope you are lost after my presentation. Thank you so much.
Thank you, Dr. Rujita, for a wonderful presentation and helping us to have a peaceful sleep ahead. Thank you.
Thank you.
And move on to the next speaker, Dr. Anand Pangarkar, sir. Are you ready?
Yes, sir.
Yeah. So he will be speaking on diabetic retinopathy in national program. Please, sir.
Yes.
The icon visible.
Am I visible?
Yes, very much. You are visible.
No, but the slides.
And the hills.
Yeah.
In the next few minutes, I'm going to plead for a focus on diabetic retinopathy in the national program and to find out whether it is a dire need. Are diabetes mellitus and diabetic retinopathy the modern monsters affecting the community? Diabetic retinopathy has moved from diabetes has moved from individual homes to communities. It is emerging as an important cause of morbidity and mortality amongst non-communicable diseases. And India, amongst all the countries, is emerging as a diabetic capital of the world. 31.7 million diabetics in India in 2000, and we project to have 80 million diabetics in India, almost 2.25 times increase in 30 years. We are all familiar with the stages of diabetic retinopathy, but I wish to draw your attention here to the 10.6% prevalence of diabetic retinopathy in a study conducted by Nam Perumal Swamy et al. In 1999 to a prevalence of 20.4% by Gadkari et al. In 2000, 21.7%. So almost double the prevalence. Diabetic retinopathy numbers forecast for India. The disease burden for diabetes mellitus will be about 80 million diabetics India will have by 2030. Morbidity numbers, and which is very important for us, 16 million, that is 1/5 of these patients will have diabetic retinopathy. And out of these, again, more than 1/5 will have sight-threatening diabetic retinopathy causing loss of vision. The productivity lost has been calculated for a patient for cataract, and it is 150% of the surgical expense incurred to treat the cataract. The economic burden on the gross domestic product, blindness cost to India is rupees 88,000 crores in 2020. That is roughly equivalent to the cost we are incurring on vaccinating everyone for COVID. The pattern of diabetes mellitus and diabetic retinopathy has also undergone a change. For example, Gadkari et al. Have reported that 46% of the patients who were screened did not have any family history of diabetes, means they were de novo diabetics. 81% of these diabetic retinopathy patients were on oral hypoglycemic drugs, proving that even proper control of diabetes is not preventing the development of diabetic retinopathy. We will have a look at the cataract success story. Such figures of blindness and visual impairment in Indian context are exceeded only by cataract, our famous bread butter. And the success story of dealing with cataract through the National Program for Control of Blindness in India, 1978, which was launched is in the following figures. Only 0.5 million surgeries, cataract surgeries were performed in 81-82, but the figure rose to 2.2 million in 1994-95. Almost 4 times the increase in the number because of efficient implementation of the national program. From logistics and economic point of view, it is easier to grow by expansion or upgradation of the existing facility than starting a new or greenfield project. So it would be logical to add focus on diabetic retinopathy in NPCB, awareness, screening, aggressive treatment. What needs to be done? First of all is the official change in policy, from changing part focus from cataract to diabetic retinopathy as well. Health education and education of healthcare providers will have to be taken on a large scale. I recall the great effect of this Marathi slogan written on the state transport buses, Moti Bindu var upachar, Shastra Kriyela nahi paryay. It went a long way in convincing people the need for cataract surgery. Education of healthcare providers, it's a massive exercise to train to screen diabetes mellitus patients for sight-threatening diabetic retinopathy. Screening by teleophthalmology has also gone a long way, as has been experienced from various studies and centers, particularly Shankar Netralaya and Arvind Eye Institute. The technical progress is its own contribution in screening of these diabetes. For example, the non-mydriatic fundus cameras and the smartphone-based fundus ophthalmoscopy. Screening and management at least once annually with blood sugar estimation for all above 40 years is done. It will help in early detection of diabetes. Important to note here that 1% reduction in the HbA1c has reduced the microvasculopathy by 35%. Screening of diabetics through workplaces, occupational groups, and encouraging resource persons participation. Strategy to mass treat from amongst diabetic mellitus and DME and proliferative diabetic retinopathy. The latter is more prone to what is known as inoperable diabetic retinopathy and render the patient blind. So pan-retinal laser photocoagulation has gone a long way in preventing progress to inoperable stage. So need to provide for retinal lasers, giving financial assistance to enable patients to undergo it and making it affordable, all will help. Wong et al. Have reported from 1975, between 1977 and 85, 19.5% patients develop PDR. However, there was a great reduction to 0.6% patients because of these development of these facilities. And I propose that the diabetic centers be established in all 718 districts of India at rupees 1 crore for equipment of each center. The center will have all specialties to cater for diabetics, physician, nephrologist, ophthalmologist, cardiologist, dietitian, and people above 50 years of age at risk for both cataract and diabetic retinopathy are going to be 200 million by 2020. So role of state organization like MOS, and I must congratulate Dr. Jignesh and the incoming team for taking up a massive exercise. So conclude, I would say that there is urgent and dire need to focus on diabetic retinopathy in the national program in case we want to get up from our sleep before it strikes us. Thank you. Thanks to the organizers, Dr. Ragini and scientific team and MOS, Dr. Parikshit and Dr. Shirish for giving me this opportunity.
Thank you, Dr. Bangarkar, sir. An excellent talk. You just said we are going to take things forward. This year, we have already, it's a brainchild of Natrajan to have the diabetic retinopathy awareness program and the screening throughout Maharashtra. So I could not join in time because I was held up and Dr. Ragini wanted me to be in the award session. It just concluded. And I would request, I think, Dr. Prakash Marathe, who is already in line, to start his next presentation. Dr. Prakash Marathe, please. He is a good friend of mine, past president of Maharashtra Ophthalmological Society. He is also the past president of the IMA. And now at the national level, he has been the vice president. Welcome, Dr. Prakash Marathe. Please start your presentation, please. can we have the stop share by Dr. Pangarkar sir? I think he's already done it. Dr. Prakash.
Sir, he may be in travel. He said he will be presenting afterwards.
Okay, so should I start my presentation with your permission of the chair, Dr. Anand Pangarkar sir?
Yes, why not? Why not? Why not?
Yeah, I think today.
Welcome, Ragini madam.
Good morning, Dr. Pangarkar sir. Good morning,
Good morning.
Taswala
Good morning.
sir.
How are
We are
you?
waiting. Hi,
Good morning, all of you.
Good morning. Good morning, Jagannath.
Good morning. Good morning.
Rujita.
Morning,
Good
Jagannath.
morning, Pankaj. So Pankaj has worked
Good morning,
not
ma'am.
only as a treasurer, but he has done scientific. He has done everywhere. Wow, the beautiful, vibrant Rujita. Hi. Hi. I won't stop the session. I just wanted to say hello to everybody. And please continue, sir. Taswala, sir.
Just give me a minute. I am extremely thankful to Chairman Scientific Committee, Professor Agini.
Good morning, Marathe, sir.
Maharashtra Ophthalmological Society and the Scientific Committee to have given me a chance to present my talks, 2 talks in fact. I would like to take my life journey first because there are certain points. We'll just take it first, this as a lecture. If we'll club the second one also in case Dr. Marathi is also traveling till now, otherwise take the next stop. My life journey, friends, it will be a real inspiration just because it's not my life. In fact, people will see to it that through the time and the tribulations I've gone through from my birth till today, and in spite of all this, usually people don't share their personal life, but this just because I'm 60+ and this is the time youngsters should know that everybody should face this thing with all the grit and come out as winners. So I have reached this stage, and just a short this thing. When I was told by Dr. Natarajan to present it in the International Leadership Development Program, it was a 25-minute talk. So I tried to cut short. Please, Dr. Pangarkar sir, please let me know when to stop. So that'll be nice of you. You are muted, sir. As of today evening, I'll be becoming the president. I'll be installed as the president. As of today, I am the president-elect of the Maharashtra Ophthalmological Society. I'll talk about my MBBS days rather than my childhood days. The first year of my MBBS in 1977 at the BJ Medical College, Pune. My father was in hepatic coma. He was the sole bread earner. We had absolutely no backing whatsoever. And in spite of getting the coveted seat, somehow it's coming just half. Can anybody help me? Resume slideshow. Yeah.
Screen is not seen.
Not seen.
Screen is not seen by anyone.
Sorry?
Again, you close
Stop
it and
sharing and share it again. Screen
I
is
can
not
see
seen.
it. I can see it fully.
No, we can't see.
Okay. I just stop sharing.
Stop sharing and again sharing.
Okay, sir.
वो तो लाइव जर्नी हमको भी देखना है सर आपकी.
Sir, वही करना है, but I don't know. Last time also in this, is there a saying? I don't know.
सिर्फ सुनने का नहीं, देखने का भी है.
हाँ, बिल्कुल.
हमको और देखना है.
हाँ यार. Is Sai there?
Any technical team, please? Sai?
Screen share करो ना. नहीं किया. I started screen sharing. Yes.
We can see that you have started screen sharing, but nothing is coming up.
Close करो सर आप. Stop sharing.
No, double click to enter the full screen mode. Just see.
एक बार double click करके देखो.
सर वो शेयरिंग बंद कर दो आप वापस. स्टॉप शेयरिंग करो. जिग्नेश सर, यू आर म्यूटेड. सर की लाइफ स्टोरी किसी को सुनने नहीं देने वाले, वो दिखाने भी नहीं वाले.
ट्रेड सीक्रेट है.
ट्रेड सीक्रेट.
Unmute yourself.
Somebody can help me because I am seeing my screen. I don't know why you people are not seeing it.
Are there any charges for seeing that?
अभी दिख रहा है क्या?
No.
नहीं दिख रहा है.
Sir, on screen sharing option now you will be seeing 2 presentations. So just click the other one from that.
I don't know.
You see 2 presentations. There is one presentation that you have to click.
Can somebody start the next presentation? I don't want to waste time. I'll just talk to Sai and then come back.
So is Dr. Jagannath Boramani ready?
Yeah, I'm ready.
We don't
Okay,
waste time.
Boramani sir, you can start.
Okay. Okay.
My laptop has hanged.
Sir, stop तो कर दो sharing.
Dr. Jignesh has to stop. Otherwise, I can't share.
वही कर रहा हूँ. It's नहीं हो रहा है मेरे से इधर.
We welcome Dr. Jagannath, a very silent man, but a very efficient and effective small incision cataract surgeon, very devoted to the concept of residents training in surgery. And it's always a pleasure to listen to his ideas. Dr. Jagannath.
Thank you, Pangarkar sir, for the introduction. Can you see my screen?
Yours has started. We are seeing your screen, Dr. Jagannath.
Yeah, it is a full screen mode and you can hear me also, isn't it? Yeah.
Yes.
Good morning,
Yes,
all
sir.
of you. I again thank Dr. Ragini Parikh, the Chairman Scientific Committee, and the entire team of the MOS for giving me the opportunity again. This is my small talk on surgical skill development for residents. Many times the new entrant in field of ophthalmology doesn't know how to acquire proper skills. They get some chance, sometimes they don't get chance, and they're always struggling. Academic knowledge can always be obtained even from the books, masters, discussion, but surgical skill training, unless you do surgery, multiple surgeries, you do not develop a proper skill. So what is surgical skill? Surgical skill is not an ordinary field of knowledge and procedures, but it is a very complex phenomenon because it is not a math. 2 + 2 may not be always 4 as far as the surgery is concerned. It is an imperfect science, and it is not only science, it is art also, and it is craft also. So it's an enterprise of constantly changing knowledge, and it's an enterprise of uncertain information, because one surgeon may like this type of way of handling particular complication, the other surgeon may like different. So the resident also is always confused how to proceed in a particular scenario. Though it is a science, surgery is a science in what we do, it is also an habit, it is also an intuition, and sometimes it is only plain old guessing. So traditional surgical professional developments have focused on developing the clinical expertise and technical skills. However, only technical proficiency may not be sufficient for a good surgical outcome. You should have a good proper judgment, proper knowledge of decision making, or the proper tact of decision making. You have to develop good visuospatial skills. There is something called as a performance for personality of a surgeon, and you should be very good in communication with your colleagues as well as with your patient. So the surgical skill development is the appropriate modification of all these human factors. Like there is a situation, suddenly nucleus drop take place. Surgeon says, I felt a little loss of support while rotating the nucleus, and the next second the nucleus started sinking. Now, what is the next step to be taken? No guidelines, no consensus statement, and no algorithm will help you now. Everything depends upon your personal surgical skill and your experience. So many times intuitive thinking also comes into play. Like a chess master, whenever an opponent makes a move, suddenly because of that particular move, almost 30 to 40 or sometimes 100 next moves come into his mind. This is an intuitive thinking as well as the thinking which has been developed because of the experience. So similarly, a surgeon also should be experienced one and should develop this type of thinking. Some situation suddenly changes and so many alternative things should suddenly appear in his mind. And it is a development of visual spatial skills also. For example, the PC gets ruptured. Now you have to, within say few seconds, you have to take a decision whether I should implant ACIOL, I should go for a sulcus supported PCIOL, whether I should go for a iris claw lens or a glued IOL. So these decisions have to be taken very fast on table. So how to develop surgical skills, especially for the residents? So there are mainly 6 things. First thing is observation, simulator training, practicing on the animal eyes, operating in the expert's presence, self-assessment, analysis, and the audiovisual aids. So I'll go to these one by one. Observation means you have to watch a lot of videos, live surgeries. Luckily, when we did our post-graduation, videos, live surgeries were not available on, there was nothing like internet, YouTube, and even in the conferences, there was nothing like videos. Conferences were only 35 mm slideshows. We couldn't see the videos in conference. Now, all the residents are lucky that they can watch the videos with so many avenues available to them. But in spite of all this, it is better to attend the experts' operation theaters. In the operation theaters, you can watch the surgery on 2D, as well as if the facility is there, you can assist
or maybe seeing through the assistant microscope, because there you get a proper three-dimensional picture of the surgery going on, and you can get a proper depth perception of the field as well as the depth perception of the skill. The resident should also observe the surgeon's hand and foot movements as well as posture, how a surgeon is sitting, how he's taking the support of a back, and how the movements are there, whether the movements are only the fingers, wrist, or the total hand is moving. So by observing all these, person can slowly develop proper surgical skill. Now there is something like simulator training, which has come into the surgical scanning. Like say, actually for pilots, before sitting in and flying a plane, they have got a similar to life experience by the simulator. So these are the computerized and software guided things wherein they have got the real life experience of driving flying a plane. So similarly in surgery now, simulators have come, and even in the small incision cataract surgery, now the simulators have come. We on behalf of the ISMS also have started the simulator training with the help of Help Me See organization, and we have started training in Mumbai as well as in various places. Now, after the simulator training, the person who has never touched an human or animal eye, he can always have experience on simulators. The simulators also give near life experiences, and all the complications are paid in simulator. Another advantage of simulators is that the software will analyze your surgery, because even during surgery, if your expert is observing, he will not come to know how many times you have touched the endothelium, but simulator will pinpoint those things, how many times you came very near to the endothelium, what was the depth of the antechamber throughout, and all the problem areas will be highlighted in red marks. So a surgeon can improve on that, and he will not have a fear before operating a human eye. But after the simulator surgery, it is better to operate on the animal eyes or the synthetic eyes. So this is a wet lab experience. So we also do a lot of wet labs in India and abroad. And after all this, when a person actually sits for operation, a junior sits for operation in the operating theater, it should be better to operate in expert's presence. Now, experts should not give surgery and go away, because expert should be sitting with the junior so that the junior can learn very fast and he can observe his problem areas and he can develop upon it. So once all these things are, always try to record the surgeries. You just see what you have done in the surgery, where you went wrong, and this is called as a self-assessment and analysis. I'll just give an example. You're doing a capsular exercise. Sometimes something goes wrong. But after watching the video, you come to know that in the left hand, you had holding a forceps and unnecessarily you are pressing the eyeball at one particular where you are fixating the eyeballs. So these points you come to know after observing the videos, and you come across your problem areas and you can improve upon that thing. Now there are a lot of audio visual aids available everywhere on the internet, YouTube, conferences, and we can even on the WhatsApp group also you can have a lot of visual aids. I don't want to go into the detail, but this is an excellent tool. You can keep watching the experts, different types of experts videos, and improve upon your techniques. Now, sometimes, especially operating in the left eye or in some odd situations, how to develop the dexterity of the left hand, because many times a person is either right-handed, left-handed, and he can operate properly only with one hand. So for developing the skill of the non-dominant hand, the person can have some practice at home, like writing with the left hand, or smearing the bread on smearing the butter on the bread with the other hand, brushing the teeth with the left hand, playing the musical instruments with non-dominant hand. This way they can try to develop the skill of the other hands also. Thank you very much.
Excellent talk, Dr. Boramani sir.
Thank you.
You have already been a torchbearer for SICS and now MSICS, and the simulation training which you talked about. Dr. Parikshit had told me, and I think in Sassoon we have just got it recently installed. So
2 days back only BJ has started now.
Sorry?
Correct. BJ Medical has started now, 2 days back.
Yes,
only.
yes. BJ Medical College last week. We have installed that, and we are going to take it forward and see to it with all our postgraduates and also members learn through this simulation training. And it will be a big boost to all the postgraduates. Thank you very much for a illuminating talk.
Thank you.
Jignesh, I'm ready. Jignesh, I'm ready.
Yeah, I think you take your talk because I had some problem regarding
Yes, please.
presentation. You take over and then I'll.
Please.
Next.
Good afternoon, Prakash Marathe sir. Welcome to the practice management session.
Yeah, good
We
afternoon.
would like to hear from you.
Yeah, he is my classmate, batchmate from BJ Medical College. Very nice and humble human being, past president of Maharashtra Ophthalmological Society, past IMA president, and now at the national level. He has become the senior vice president. Welcome, Dr. Prakash Marathe, for your talk, please.
Thank you, Dr. Jignesh Bhai, Dr. Pankaj, Dr. Jagannath Boramani, Dr. Ambekar sir, Dr. Pangarkar sir, all the scientific committee, managing committee, all MOS and delegates. Thank you so much for giving me the opportunity. Let me share my screen. Is my screen visible?
No, now.
Yes, sir. Make it full screen.
Yes.
Make it slideshow, Prakash.
Yes, I'm trying that. Yeah, can the screen be seen now in full screen?
Yes, sir.
Yes.
Yes.
So thank you, organizers, for giving me the opportunity. I think the topic is quite relevant for the conference. Leadership. Basically, most of the stalwarts here in this particular session are leaders. So leadership depends upon one important thing, and that is work delegation. So leadership in work delegation is very important, and that's the topic which is allotted to me. If you are the leader, probably you have got subordinates and you have to share your work with them. Delegation of work is very important for the good leader. So what is delegation? Delegation involves giving another person a task for which the delegator remains ultimately responsible. See, on behalf of you, somebody else is doing that. So by that, the other leaders are also developed, and ultimately you are responsible and they are under your umbrella, under your shelter. So what is the definition of delegation? Achieving performance of care outcomes for which you are accountable and responsible by sharing activities with other individuals who have the appropriate authority to accomplish the work. 5 rights of delegations are there. What are they? That is, the right task has to be delegated. There has to be right circumstance, and you have to choose the right person. This is very important. Whenever you choose that person, you must have proper communication with that person. So right communication has to be there. And whenever you have delegated that work, just don't forget it. You have to supervise it properly. So delegation stages are there. What are they? Analysis. So sorting tasks to be delegated. Suppose there are 10 works to be done. You have to sort out exactly which task is to be given. Then appointment. You have to name the delegate. You have to identify the delegate. Briefing. You must tell the delegate exactly what is to be done. Otherwise, he will never know what exactly you want from that person. Then control. So the end control, that is monitoring and encouraging is with you because you are the leader. And appraisal, reviewing and revising all the time. These are the important stages in delegation. Why delegate? You must be very busy leader. You must be very good leader, but you cannot do all those things. So streamlining your workload, if you have got more workload, streamlining your workload results in more available time for you, reduce stress levels for you, motivated and more confident colleagues and juniors, and development of new leaders in future. Selecting tasks to delegate. You have to select proper tasks. What tasks am I doing that need not be done at all? So you have to identify accordingly. What am I doing that could be done by someone else? So proper tasks you cannot give to others, but some tasks definitely you can give to others. And then what tasks am I doing that can only be done by me? So that you have to identify. You need not delegate that to others. Consider the various roles you can delegate. What are they? You have to address the individuals. You have to look for initiative. Then train the delegates. So train, strengthen, and motivate. These are the proper steps in delegating the activities. Selecting a monitoring system. What is that? So involvement in all correspondence. So like you have delegated that work to your subordinate and you are not taking him into confidence. Related correspondence you are not disclosing. That is not correct. You must involve that person in all the correspondences. Then written reports, they have to be there. Some proof has to be there because the person is working and you have to document in a proper way or ask the person to document in a proper way. Personal reports are to be submitted. And then access via computer is one of the best options nowadays in today's era of software. And meetings have to be misaddressed. Like just you have delegated the work and you are not asking the fellow to sit with you and you are not having meetings with that particular person. It is not correct. So meetings have to be there. So checking progress, once you have delegated the work, it has to be assessed step by step. So checking progress is very important. So what you are going to check, is there anything you want to bring to my attention? That's what confidence you have to give to your person, those who have given this delegation. We fail to meet that deadline. This can happen. So any suggestions as to how that happened? So you can discuss that with your junior subordinate. How do you think we can avoid making this mistake in the future? Same mistake cannot be done again and again. So you have to avoid that. Developing yourself through delegation. Like while you are delegating your work to subordinate, it's your development also, not only your junior's development. What is that? Organize sufficient time in which to research and develop new ideas. This is what you learn. Set yourself a weekly or monthly reading plan and adhere to it. Then if you are aware of a gap in your management education, fill it. And reinforce your skills by taking the opportunity to learn from others. And what is the conclusion? So at the end, this particular topic, which was given to me about delegation in leadership. So delegation is a powerful tool. When used correctly, can create an effective and safe environment in which your team works together to achieve positive outcome. The person can be prime minister. The person can be chief minister. The person can be AIS president. Person can be MOS president. Person can be secretary MOS. They have to delegate their work. It is not that all the work is to be done from your side. You have to involve others. Like for MOS, the president has got so many work to do. He has got secretary, he has got treasurer, joint secretary, joint treasurer, managing committee. And if you are taking everything in your hand, it's not correct. Our leaders of MOS, they have shown how that work can be delegated. And this is the way the managing committee members of Maharashtra Ophthalmological Society, they will bloom, they will develop, and they will be the future leaders who will be taking our association, Maharashtra Ophthalmological Society, at topmost level. So it is with us, all the stalwarts who are sitting there on the dais for this particular instruction course or this particular topic of practice management. I think we have to develop leaders, give them confidence, teach them something, whatever you want. You must be having so much of knowledge. But if you are not giving this knowledge to your juniors and subordinates, it is of no much use. So subordinates are to be developed. Delegate your work with your colleagues. Keep faith in them. Give confidence to them. And I think that is the character of great leadership which you can develop. So I think how well do you delegate? I think this message I have tried to pass to all of you and all the delegates here. Thank you. Thank you so much for giving me this opportunity to share my views on this particular topic. Thank you.
Thanks, Dr. Prakash Marathe. As usual, fantastic talk. Very good tips for all the beginners and of course the seniors also. It has been, and I have tried to implement already, much before taking the presidency, the mantle. I have already have 20 committees and I have the seniors to guide us and the moderators and the coordinators to see that all 21 committees work in full force. So a big thank you once again for imparting knowledge on leadership qualities. We have Dr. Natarajan, who has already started the leadership development program. We have in Maharashtra also a lot of people who have taken availed of the leadership development program. Dr. Preetham Samant, myself, Dr. Parikshit Gokte, Dr. Gitanjali Sharma, and many more. So thanks a lot. I think I'll just try, Dr. Pangarkar sir. I would like to start the session if it is possible. Otherwise, I've sent my PPTs to the side.
No, I thought I will take this opportunity to tell everyone that Dr. Prakash Marathe not only spoke on this, but he led it by example. How in the Marathi consent, he delegated and got the team to do everything. So that was a practical demonstration of how 2 + 2 in a team doesn't become 4, but it becomes 5.
It
Thank you,
becomes
sir. Thank
10.
you so much.
I would say it becomes 10. And
Yes.
Maharashtra Aple Dwari, what is his concept? And he had
Yes.
tried to reach each and every nook and corner of Maharashtra and
So-
see to it that how the leadership should be taken at a greater heights. Thank you,
So he
Prakash.
first-
Thank you,
first-
You are
Pangarkar.
the first president to go at every district headquarters.
Got it.
Thank you.
Yes.
Thank you. Thank you all.
He first did it and then is telling us.
MOS
Normally it is the other way around. Sir, you are enjoying a vacation. Please go ahead. Nice backdrop.
Thank you. Thank you. So it is not vacation, sir. I am at work. Only
He-
the backdrop is like that.
He is always improving his center. हमेशा वो गोवा में ही रहता है.
Dr. Prakash Marathi always does it like this. Adhi kele moga sangitale. He is
Oh.
always like that.
Yes.
Thank you. Thank you.
But
ma'am.
it's a big thing. Big thing.
Yeah, definitely.
We
Let's
have
move
now Dr. Jignesh Taswala, the dynamic incoming president. Dynamic, I don't know whether I should use only dynamic or super dynamic, because Jignesh is like a volcano bubbling with energy. The energy is just coming out in form of bubbles, impacting everyone with enthusiasm and exhorting everyone to work with him, along with him, to achieve something higher. I've seen Jignesh from close quarters for a long time, and part of his tough life I am aware of, but it would be definitely worthwhile listening to him about his real life story and how he made it despite the odds. Welcome,
Sir,
Jignesh.
Sir, tough time now also somehow something is happening here. So I think let's have somebody else's talk now. I'll tell Sai to take the next one.
And
Somehow it's just not loading.
Can I-
I'm doing it. Are you seeing my screen?
No, no.
No.
Can you mail it to
Here I
someone?
can see full screen. I don't know why I've shared it.
Please
also
email it to
twice.
someone.
I have emailed to Sai. So we'll
Doctor,
have
can
to
I
take
share it
off.
on your behalf?
Yeah, somebody else
Doctor,
can
I'm
take
Sai
over.
here.
Yes,
Doctor,
I
I'm
can
Sai
share.
here. Can I share it on your behalf?
Yeah,
Yes,
please,
why
but I
not?
can't stop share here. I'm trying to
I
stop
will,
share.
I will do a stop share.
Okay.
Please.
My
So,
life
okay, now-
journey is if I have two talks. Load the my life journey first, please. Sorry about it. Unnecessary technical hitches. We are delayed.
It's a part of your journey.
Yeah, yeah, it's always been there. Anything I start, there is some obstruction, but we try and overtake it and move forward. So here we are.
Jignesh, your journey all the time is very difficult. It is difficult with hurdles.
No, it just means that problems are there not only in real life, but in virtual life as well.
Yes. I'm extremely thankful to the
Rightly said,
Ophthalmological
sir.
Society, especially Dr. The Chairman Scientific Committee, Dr. Ragini Parikh ma'am, and the MOS committee, who have allowed me to use this podium and share my life journey. Very good afternoon to all of you. I just like to start. I have had lots of problems right from my childhood. In fact, I had an injury to the difficult parts of my body and had to be operated also. During school days, we had one-time meals and a lot more. So it's going to be almost an hour of talk, but to cut short, I'll start from my MBBS days. Can you move forward, please? Next slide. It's not coming up the way it is. I'm not seeing the whole slide, sir. Hello. Can you
No, we
see
can
the whole
see
slide?
whole
I am
slide.
seeing only half slide here.
Doctor, I mean, the whole slide is visible.
Okay,
for us.
I'll go to the smaller this thing then. Yeah, first year of my MBS in 1977, BG Medical College. My father, who being the sole bread earner, was in the hepatic coma. So my MBBS itself was in doldrums. What to do? And we had absolutely no backup and no income whatsoever other than what my father is to earn. So my mamas came to rescue, and somehow Dr. H.V. Sardesai was like a magical angel who walked in as a second opinion, and he got me out. And within 3 days, he was out of the hepatic coma. And here we are as the eye specialist all the way, my journey. Passed MBBS myself in 1982. Here again, I had a problem. A senior, junior, having less marks was given my seat. I had to fight myself and Dr. Wagmare. I had to go to the High Court. Again, we had no money. So we pulled in money and saw that we fight the case. And then ultimately the Pune University was told by the High Court to create new 2 seats for us. So instead of getting my regular residency, I got the postgraduate that time as a postgraduate seat from this. Can you move forward?
Next you say, na?
Next slide, please. I can't do it from here. My entry to Shankar Netralaya, Dr. Badrinath, you know, the premier institute in India, and at BJ Medical College, to have a slit lamp examination was itself a luxury. So I was interviewed by him, and there was the pyramidal session, the pyramidal system there, where if you don't perform within 3 months, you have to leave. So I completed the whole year seamlessly. And then, in fact, Dr. Badrinath was so happy. So he continued me for the diabetic research fellowship for another 3 months. So I was lucky to have 1 year, 3 months at a premier institute. Next slide. Now we start off my professional practice. Back in Pune in 1987, well, my dad had retired. Again, no source of income, no house to stay. Even a rental we had to search, and somehow we could manage one. All the load was on me, and I was the whole to carry on the bandwagon. My brother, who was senior to me, a year elder to me, could not earn. He had no jobs. My sister, younger to me, was still studying, and my mother, a total illiterate, had absolutely no way how to go forward. So with this, I had tried to. I can see a very small screen. I can't read out the whole this thing. Back in Pune, we had no savings. Absolutely, I had to take a loan, and we had no guarantors. The band documents also nobody to sign, because a retired person can't sign it. So ultimately, one of my schoolmates obliged me, and he was a savior, and somehow I could get my loan to start my clinic, where I could buy only a refraction box and an ophthalmoscope to start with. No slit lamp also. So I bought a Keeler's loop to start examining under, say, a microscope field. There was no money to buy a house, no buy, or everything was on rent, and we had no money to pay. Next slide. Was charging a paltry 30 rupees in the first decade of my practice, just 400 rupees for a cataract surgery, and could barely collect my expenses, earn enough to have my expenses. And for that, I had to roam around 50 to 100 kilometers in the periphery, carrying a refraction box and screening at every general practitioner's door, and somehow could hardly save some money to have pay the rent of this and have a rental house for my aged parents. Next slide. Facing on my personal front, well, people don't share it, but this will be an inspiration that how I managed the home front and the personal front and came out a winner out of it. My wife, the first wife, had a psychiatric problem. There are a lot of turmoil in their life. During this period, I had an abnormal child who had undergone 8 surgeries during the first 5 years of life. Simultaneously, I was fighting a family court case where I was falsely implicated, which ultimately led to the divorce. Next slide. Unfortunately, after my second marriage, also within 2 years, my wife developed a severe bipolar depression, and soon that led to separation. During this period, my father fell down and was bedridden for 5 years, and ultimately had an untimely demise. During this period, my brother lost a job. He had to stay. He had no place to stay. The wife was not ready to keep. So he joined me, and he also went into deep depression. Next slide. My brother, in fact, coming and helping me, created a lot of family discord, so much so that I had to, multiple times, I had to admit him in mental health care hospitals, and ultimately lost him in 2015. During this phase, my mother, who fell ill, had morbid obesity, developed hypertension and diabetes, and absolutely bedridden for 7 years. And last year, we lost her in July 2020. Seeing all this, my child went into severe depression and had to take psychiatric counseling and treatment. As of today, he's under treatment. Due to this physical and mental problems, he was not doing well in academics, was pursuing law, but could not pass. So I made him leave and join optometry. And today he's with me, passed optometry with flying colors. Next slide. My professional front, during this 10 years, I just could manage to take a bank loan to buy my own center, medical equipment and surgical equipment. And the society ladder, I became the joint secretary, and then the next slide. Next, the joint secretary and secretary of the Maharashtra Ophthalmological Society. Then I had to fight my election for the vice president. I was told to withdraw. Respecting the seniors, I had to withdraw, and again I fought an election and again lost in 2018. And then last year, I had fought an election at the home ground of the opposition candidate and won at a reasonable margin. During COVID times, there was loss of revenue, there were no surgeries. So I conducted investment webinars where we had a viewership of more than 1,000. During that time, I developed a lot of hobbies also to ward off my depression, to have seen for palmistry, feng shui, and Vedic astrology. In the present times, I am now the president-elect, and 2 months prior to my thing, I have formed 21 committees to see the overall wellness of all the MOS members beyond ophthalmology. And you'll hear my speech during the inauguration, what all I have planned for you people. Thank you very much for giving me time. These are the 20 committees. That is my next talk, so I won't go through it now. We are short of time. Thank you very much for allowing me to speak. I have tried to give it in concise. There are a lot more difficulties which I faced during my childhood and during my and also my practice. And we have tried to see that we face all the obstacles with a smile. Seeing me, people also always tell me, Jignesh sir ko itne problem hai, humko pata hi nahi hai. So that is how every person should be. And that is what I would request all my MOS members, the freshers and the beginners, to take it in their own stride and come out as a winner. Thank you very much.
Jignesh, the famous adage, tough times don't last, but tough men do.
Yes,
so you are a tough
absolutely. So thank you very much. So let's go to the next talk. I think Dr. Ambekar is the next person who is going to speak. Yes. President of the Jalna Ophthalmological Society, a very good human being, a very well-oriented person in academics. He is going to guide us on his topic. Dr. Ambekar sir.
Yeah. Is it seen?
Yes.
Yes, sir. Yes.
Yeah.
Make it full screen.
Yeah.
Madhav is speaking on a topic of dear to my heart.
Yeah, future the small and the medium setups. As I was, this is a topic to my heart since long time. I have spoken with him also sometimes back during the Goa conference. See, presently it's total chaos. Everybody wants to go for all equipments, instrumentation, and everything at an individual level. And are we going towards the dead end because of the heavy investments? It's very difficult to answer as of now, but probably we are trying to find out the solution at the end of this talk. So the small setups are single-handed practitioner with a limited gadgetry and looking after the specific subspecialty, and or a medium setup.
Is it?
Am I audible?
Yes, yes.
Okay, I'll just search and send. Please send.
2 or more practitioners are there, and it is projected as a single large entity, but only the time sharing basis of the instrument is shared, while the corporate hospital is either a profit making organization or a non-profit making organization. So as I have shown that the small fish keeps on eating the larger fish. So that's the point which keeps on occurring. So sometimes this, yeah. So what are the pros and cons for the small and the large setup? It's a one-man army in a small setup, and you are an employee, employer, and everything at the same time. Complicated resource management is very difficult, and you are constantly under stress. And as a small business owner is seen in the various dimensions I have shown, that how the family looks after, how the friends look after, what I actually wanted, what the customers feel like, and finally I'm just doing a donkey work kind of a thing. This keeps on happening with smaller setups every time. But for a medium setup, together everything achieves more. So that's a team. What just now we have listened about the team building. Adi Kili and Mag Sangitle, as Marathi sir has done. Startup may not be a difficult, but the problems are about the sustenance of this, because everybody has to have a wider perspective and a wide horizon to look that sometimes there are issues and egos, but we have to offer the best of their services and with the minimum expectation from the others. It's the only crux of the story to maintain the team properly. Or corporate setup, it's dominated by mostly the non-medical person, those who have got a phenomenal financial resources and looks into the revenue collection because they have invested. So it is, as they call it, as ROI, return on investment. And patient may be skeptical to visit such too big hospital. And as I said, that too big need not be too good all the time. And sometimes it becomes nobody's baby, that the corporate people, those who are non-doctors, are finally responsible, and they, at the end of any complications, they try to pass on that responsibility to the medical person. And the patient's point of view, big hospital is a big charge, small clinic for a minor ailment. But for a big hospital, the many times the queries are unanswered. And as it is said that I shop at a small business because I know I'll get more personalized attention and help from anyone wherever I go. So that's the main crux of the story, that personal attention is possible only at a smaller setups. And how to thrive. Every time we have to look that every patient is an opportunity and not a problem, and come together to form the solution and think always out of the box. So how to build up the team? One, it has to have a common goal with a one thought, that equal efforts, keen to maintain the professional ethics. And as I have said, that tree becomes an organization, and then you keep adding the team members in future as it goes. So colleagues versus opponent. The professional are colleagues and they are not your opponents. So corporate hospital or the so-called non-profit making NGOs, because I have put a specific word at so-called, because many times on document they may be a non-profit making organization, but behind the bars, behind the document, they may be having some profits. And our strength will be our unity and maintain the utmost standards of collegiality, because I have seen people come together and subsequently for some very minor reasons they keep separating from each other, but that cannot be the way. Unless you are together, you can build a proper team. And somewhere you need to look beyond the cataract. I know that cataract is bread and butter, but what has happened is recently I have come across a fellow who looks after glaucoma and he says, sir, mere ko glaucoma ke utne patients nahi milte hai, and I do not want to operate for the cataract, though I am a good phaco surgeon. So how can this happen? He keeps on sending his phaco to someone else, and then he is trying to say that I don't want to, because I want to project myself only as a glaucoma specialist. So try to become comprehensive. In the current backdrop, people have started feeling that refractive error correction is a only job by the optometrist, and ophthalmologist should not indulge into it. But I think there are occasions that people, those who want to see you, even for the refraction, you should give some time to at least reconfirm what the optometrist has given and look towards it as an opportunity. No business opportunity is ever lost if you fumble. If you're competent, you will find it every time a new opportunity to develop. Even during COVID, people have found the new opportunities to develop themselves. And who will win? There are more chances for the medium setup to survive in future. And a famous saying that if you want to walk fast, walk alone. And if you want to walk far away, then walk together with others. As comparison between the small and the medium setup would be difficult for the infrastructure, the smaller setup. Economic burdens are there. The stressful situations will be more and less personal time will be available. While the medium setups, the infrastructure development is much easy, sharing the economic burden is much easy, and less stress will be there, and quality time for everyone will be available. But the only thing is that everybody has to maintain the high standards of the collegiality, which is most important, and never ever try to become prey at the hands of the corporate hospital by giving your working setup to the corporate hospital and trying to see that I am just looking after this. Never it will happen. Down the line, they would dance on your head to say that your revenues have started dropping down. In a nutshell, offering multiple subspecialty services under one roof by a medium setup would do far better over a single-handed practitioner and too big institution for their limitations. A satisfied customer in the best business strategy for all. So see that, as I repeat, that you do not become prey at the hands of the corporates, those who have got funds. Initially, you may find it to be a lucrative proposal, but down the line, they would dance for having the ROIs done. And as it is said, that it is always the survival of the fittest. And the greatest theory for the personal ever, evolution is the continuous process, and we need to remember it always. Will our path cross each other? What is better, merger, acquisitions? I think it will be coming together as a medical person and not becoming prey. I repeat for the third time, not becoming prey for the corporate hospital is going to have a best strategy, and in a medium setup, it will work fantastically well. Thanks a lot for giving me this opportunity, the organizers. Thanks all.
Be friendly and cooperate with each other to form the core of group practice, the way to survive.
Yes.
For a single setup, it is difficult to get on many fronts. But if we are together, I think it can help many. Thank you, Madhav. Very nice exposition. Thank you.
Thank you, sir.
Jignesh bhai, we have...
yeah, second talk I have just sent to this thing. Sai is loading it.
No, it is 1 p.m.
We have already crossed our time, but next session people
I know, yeah.
No, Jignesh, could we have it some other time?
No, we have 10 minutes or 1:30 tak to ye hai na fir. We have melodies. So we have no problem. There's no other session after that. I just spoke to Ragini.
Okay, okay.
So I think we will have it. Just Sai has to load Mr. Sai Dada.
Sharing the screen now.
Yeah. Again, I'm absolutely honored for giving me this platform to speak about my the vision about MOS during my tenure. And big thank you to the Professor Ragini Madam and the scientific committee for allowing me to use this platform to speak on this topic. Friends, as you know, the COVID pandemic had taught us a lot. During the AIS survey, a lot of members were having depression, emotional instability. They were not able to pay the overheads, lots of EMI to pay, falling income, no surgeries, and only emergency surgeries were allowed, and elective surgeries were on hold. Next slide. To keep yourself happy, what have we learned through COVID? A slide prior to that, please. Yeah. To keep yourself happy, healthy, and motivated, boost your immunity, minimize your expenses, only spend on basic necessities, have a corpus, at least 3 months of your income as ready and liquid money for all your emergencies, and follow strict COVID protocols so you don't pass on the infection to others and lose my man hours and be a financial drain to a pocket. Next slide. So this germination of idea of this awareness, wellness, that is how it came into my mind. The second wave is also come, which is more dangerous than the first one. So as I was taking over as the president in October, I thought over this well ahead in August. Let's have committees to form and see that other than the scientific content, let's have something good for all our MOS members. So the various committees which I found, I'll just try to highlight it quickly. We luckily have a senior yogacharya for the yoga and the meditation committee to guide us, and a lot of our own members. Dr. K.T. Pakre, the ex-president of MOS, and Dr. Darade, very good yoga people, are going to help us chart out the whole program throughout the year. Next slide. Public speaking and personality development, I've seen. Now, I've had such a lot of problem, not able to join net. Still, I am trying to manage this. So I want other people also to learn this and see how to go about the crisis and come up, and also be able to speak on public platform. So this concept came in, and also I have seen Mission Rangachari that our people outside Maharashtra are getting the Rangachari and the Reshmi awards. Very few of the people in Maharashtra, we can just name on the fingertips, are getting it. So that is one thing, and having the confidence. The rest, the most remotest person should be able to speak with confidence when given a mic, and should be able to present confidently. That was my aim of having this committee. Next slide. Mentor and mentee. Well, Guru Shishya Parampara, the old age, is what I would like to revive. Here I have a different perspective, just the surgical steps or just the OPD thought process. Instead of that, an overall grooming. In the first years of my practice, and many more you must have faced, that it was very difficult to go about finding about the loans for the vendors, how to set up the OT, the communication skills and all. So we'll have one person and one Shishya, one mentor and one Shishya, one Guru and one Shishya to mentor full year around. So I'm planning to have about 50 people, 50 mentors and 50 mentees to go about and train them and set up a landmark during my presidency and to be carried forward by my successors. Next slide. Financial literacy. During COVID times, as you see, absolutely the surgeries were down, the primary income had gone down. So I had conducted a series of webinars, and from there I took a thought process to train all our MOS members on investment, make them the investment gurus. And that is why we will have a series of lectures. We have our own investment experts who will formulate all the programs throughout the year, and then culminate during the MOSCON 22, having a full session. Next. MOS Observation International Committee. Well, I've seen those who return from the abroad and have the institutional training are very much up the ladder than a person who is domestically trained. So I feel all the new members or a new pass out should be exposed to international foreign institutes. And that's why we'll be having a short observership with all the premier institutes all around the world. Dr. Udayan Dikshit has already taken permission from Dr. Dua, is already readily agreed, and we'll go further. Next. During COVID times, have you seen that all the pre-diabetics have become, majority of them are overtly diabetic. India being the diabetic capital of the world, I discussed with Dr. Natarajan, it is his brainchild to carry forward all over Maharashtra, all the villages should be made aware, and a screening program should go, this being a site-saving measure. So post November and December is the awareness month, and from January we are going to have screening in all the 36 districts. Next slide. E-journal, e-research, and e-library. So research is much lacking in our society. So I thought we have one of our own members who is running an academy. So I have made him the chairman of this, Dr. Sabyasachi Sen Gupta, and he is going to help us structure all the program. Dr. Vaishal Kenya, being already an e-librarian, running the library show in BOA, I said, you take it over. He has already given us a clue that we can access to 18 world-class journals if you are an AIS member. So I plead everybody to become an AIS member. So you have world-class journals, 18 free of charge through one network. And Dr. Parul Deshpande is going to conduct monthly journal club meetings also. And a new concept of podcast is being developed by Dr. Mandar Paranjpe. Many more enthusiasts have joined. The MOS Academic Committee, the next slide. MOS Academic Committee, here you will have to pardon me, you have to give me a little more time. So we will be better able to show you the concept of what I have in store for all of you. Teacher of teacher, Dr. Wangikar sir and Karandikar sir have been included in this, where we are coming up with a new concept of preferred practice patterns in ophthalmology. Well, this is those standard protocols for all the juniors and the freshers to look into, and we are going to come out with an e-book or a booklet, all been done by the subspecialty experts. It's a monumental task, has to be carried forward by my successor. Next. The Public Awareness Committee, well, you see doctors are on the receiving end. The violence on doctors is rising. Dr. Shrikant Kelkar and Dr. Chivan Ladi, I have given the work and the responsibility to have a positive image on all social media, TV and radio, and all the negative news needs to be answered. Other than that, eye donation, diabetic retinopathy and glaucoma awareness, we are going to have rallies and also on the media. Next. Women, are multi-talented and multitasking. Karobi is heading it. She is going to come out with women-oriented programs, the work balance and many more. And the people to help her out, many enthusiastic ladies have joined that committee. Next. The young ophthalmologists, they have their own problems. So when they start off the practice, they have their teething problem. Dr. Amay Kulkarni, son of Dr. Anil Kulkarni sir and Sumit Lahane, a very dynamic young ophthalmologist, has taken over the mantle, and Dr. Aarti is there to help her. They are going to have youth-centric programs. Next. Well, fit hai to hit hai. All work and no play makes Jack a dull boy, as the saying goes. So we are going to have a round-robin tournament both for outdoor and indoors. I have just labeled all the disciplines that we are going to have. And the annual sports day is going to be held during the Ganpati festivals when the OPD is less. Everybody can take part. It's going to happen first time in the history of MOS. We are going to have trekking, cycling and marathon also. Next slide. We are having a cultural committee. Well, we are going to have an annual cultural day where we have enormous talent within our people. So active participation in painting, rangoli, singing, dancing, ramp walk, master chef and many more. So we are going to have this during the annual, the best of the talents on the annual celebration. That will be a Sunday where I'm planning, and Saturday we'll have the annual sports day, maybe in Pune or Nasik, whichever place suits everybody. Next. The grievance committee with the trade and vendors, the juniors and all the remotest few members do face. So we have this grievance committee where Dr. Ranjit Maniar was already heading the AIOS. We have Dr. Shrikant Kelkar also included to solve the problems of the trade with our members. Next. The advocacy committee is required because here we have seen like the ASCAN issue, the crosspathy issues and the daycare center issues are not looked after properly. We as the cold branch is not on the priority, and we have Dr. Padma Shri Dr. Vikas Mahatme sir, Member of Parliament, who has consented to liaise with the government and address all issues. Senior Dr. Colonel Deshpande sir and Dr. Kulkarni sir have readily agreed to help in this matter. Next. Medical Legal Committee, Dr. A. Deshpande has been head of the AIOS also. So I have made him and Dr. Jeevan Ladi, Dr. Prakash Marathi and all the other stalwarts having any medical issue can approach this committee we are ready to help free of charge. Next, we have to stimulate the brain, the gray cells, and to win handsome prizes. We have the quiz committee is going to function all around the year. Ably helped by Dr. Subhash Billani and talented members. Dr. Quresh Maskati is going to head it. We are going to have a round robin tournament in the 36 districts and the knockout at Moscon 22 at Nasik. Next. Membership drives. Friends, I would like MOS to become the largest society in India. Well, it's a very stiff target. It looks like fiction. But if one member adds one person, new member, I think we can cross 5,000 easily. We have Yogesh Shah, the dynamic vast treasurer of All India Ophthalmological Society heading this committee. Dr. Siddharth Kamble, a very enthusiastic person. In the SICS, he did add in a day 27 members. So we do have the potential. We have to work on it. We have a lot of schemes coming up to have the membership drive working up the ladder. Next. Professional indemnity. I had in my election manifesto in 2016 and 18. Well, that was taken up by Dr. Malik Madam. It is working very nice. It's a group indemnity insurance where we have less premium rather than the individual policy. A lot of people have rolled in. We want more to add, and a sincere appeal for the rest of the members to join the show and those who are there to continue reaping the benefits. Dr. Malik Madam, Dr. Deshpande and Dr. Vardhaman Kankari are ready to help you if you have any issues. Next. So here we have all the committees, the 21 committees to look after all my dear MOS members. We see to it, we are going to rock next year. It's already well in function. I have already taken meetings with about 8 to 10 committees, more 11 to come into the picture and see that we have the fantastic tenure next year. And the MOS should rock and reach become a premium society in India, the topmost society. Let's dream for it and work all together. Thank you very much for allowing me to go a little beyond my timings. To sum up the session, I would like to thank everybody, all the speakers, the esteemed speakers. Can we have everybody on the video mode so we can have a screenshot before we sign off? Let's everybody be on this video mode, and Sai Dada, please take a screenshot so we can have it in the posterity that we have conducted a fantastic practice management course. We are extremely thankful to the MOS, the Chairman Scientific Committee, Dr. Parikshit Gopte, the MOS and the Scientific Committee to have allowed us to have this practice management session. And it has been a wonderful session. Sorry, I joined late because I was in the award ceremony. Dr. Bangarkar took the mantle and took it forward. We have gone beyond the limit. We have no other session. So anybody would like to speak, a go-home message? Every speaker about 30 seconds for each of them before we sign off.
Nice session. Everyone spoke well. Jignesh, grand vision. Dr. Prakash Marathi's grand example. Madhav's teachings about group practice, marchways, lessons how to sleep well at night. All were wonderful. Thank you, everyone. It's been a pleasure. Jignesh, all the best to you for your tenure, and we will certainly be with you, helping you out or doing our bit. Thank you.
Have Dr. Ranjit Maniar and Dr. Natarajan there, sir, who have just joined. Sir, a word from you will be a big motivation factor. Sumit is also there.
Sir. Good afternoon, Natarajan sir, and good afternoon, Dr. Maniar sir.
Hi, good afternoon to you. How
hello,
are you?
Hello, Natarajan. How are you?
Very good, Anand. How are you?
Fine.
I'm Anand.
What is?
Anand.
Hi,
how are you?
Good afternoon.
Karobi. Hi.
Very happy birthday.
Thank you.
Karobi, happy birthday. Ranjit Maniar sir. Namaste, namaste.
Birthday.
Thank you.
Hi.
Karobi ma'am.
Thank you.
Hi Ranjit, how are you?
Natarajan, what are you going down to the south or something for the film industry?
I know
क्या चालू क्या है?
He is coming all the way to Pune, sir.
Yes, Acha, okay.
Very good afternoon, everyone.
Hi, good afternoon.
Yes, Sumit.
Good afternoon, Sumit.
A word for Sumit. He has been working so hard in the background.
Yes, really
He is
hard.
the remote control.
Yes.
He has been organizing all the sessions very quietly.
Very
and
quiet.
I am sure this year Dr. Swapnesh and Dr. Sumit need
And
to
very
be
ably.
lauded and applauded, and of course felicitated also. I'll see to it
Yes.
during my presidency we're going to do it in a big way. Thank you, Sumit, for joining. I think, is this next session coming or we are having the music melodies now? Garobi?
No, this is the judging session.
Do I have your permission to leave, sirs?
No.
Oh, hi, Anand.
No.
Yeah, Sumit. I have handed over the session to you. We are through.
Yes, sir. Good afternoon, everyone. Thank you, Taswala sir,
Hi,
for
Sumit.
handing over the session. Hello, ma'am.
Hi.
Wish you very happy birthday.
Thank you, dear.
Oh, wow.
Big
Where are we
birthday
going,
for her.
Garobi?
Come, let's
So
go.
young birthday girl is here with us.
Cake cutting?
Evergreen young birthday girl.
Thank you, thank you, thank you. For your
Love you and a happy birthday again.
Thank you.
Lots of love.
Thank
Lots
you
of
so
love.
much.
Enjoy your day, man. And don't be tense.
Definitely, thank you.
You're going to have all the positive results tonight.
Nati is looking like a Don only with those glasses.
Absolutely,
Yeah,
absolutely.
He's traveling all the way back. He's on the phone also.
He doesn't look a Don, he is a Don.
Yeah, stand corrected.
Karandikar
What are
sahib,
we
you are
waiting
the
for?
chairman here.
Garobi?
Yes, Dr. Karandikar.
Happy birthday to you, which I realized just now. Have a nice day. Have a nice this particular session, and we'll have a cake whenever we meet next.
100%.
Well,
Thank you so much.
He's going to entertain us with the musical melodies starting at 1:30, right?
No, but we are in the...
No, we have got a session.
We've got a
Yeah,
session
okay.
now.
Aswala, we have got a session here.
Please
Yeah.
It is
So, with permission from all the judges, we would like to start with the free paper final session. We have respected judges with us
Kunala,
here
Kunala
together.
द्यायचंय. Sumit Kunala द्यायचंय.
So we have Dr. S.C. Karandikar sir,
Hello, Baniya
mentor
sir.
of mentors, Dr. Ranjit Baniya sir, Karobi Larry ma'am, and Praful Mukadam sir. And Shrikant Doshi sir and Vangika sir could not join. So we will go ahead with our 4 respected judges. So with your permission, sir, Karandikar sir, can we start the session?
Yes, we have to.
Sir, any small message for the students before they start?
I hope they will abide by the rules. Whatever you have said, they will maintain the time limit. Otherwise, their marks are likely to be deducted. With this, I think you should call the first speaker and let him start
just
his
one.
paper.
So,
If everything is ready.
Can I get one word?
Yes, sir.
One
Baniya,
word
sir.
in.
Yes, sir.
All the speakers, to all the speakers, enjoy yourself. Don't worry. We are all lenient judges. And who wins, who doesn't win, really doesn't matter. The fact that you reached a free paper final in MOS, that itself is a great thing. All the best to all of you. Yeah. And okay, yeah, we are going to be lenient. We are going to be lenient.
Dr. Manya, that's a lot coming from you.
So I would request the technical team to have a timer of 6 minutes. Give.
Hello, Darshana. Hello.
So I would like to request technical team, can you mute the mics of the others?
I'll join in between if there is time. Okay.
Technical team, can you mute everyone?
Ishwar Chandra, na?
यांचं काय नाव ताराबाई ताराबाई बबन ना किती वय यांचं
Sumit.
Yes, sir.
Call the first speaker.
Yes. Please keep a timer of 6 minutes and give a buzzer at 5 minutes. We will start with the session with the first presentation, the bubble, and we have with us Dr. Siddharth Deshpande presenting. And Dr. Siddharth, you are here?
Yes, sir. I'm here.
Yeah. Can you please share your screen?
Yes.
Yeah. Please start. Technical team, please keep the time of 6 minutes. At 5 minutes, we need a buzzer.
Okay, doctor.
Yeah. You can start. We can see your screen. Please make it full screen and start. Yeah. Very much visible. You can start.
Thank you. So good afternoon, all the judges. So I present the bubble to center the multifocal intraocular lens. A proper centration of a multifocal lens is required for remarkable results. Under topical anesthesia, a patient fixated coaxial sighted light reflex is possible, but this patient fixation of light may be subjective And some patients may require a peribulbar anesthesia under which a patient-fixated coaxial light reflex is not possible. So the bubble in the anterior chamber, which is aligned with the corneal light reflex and the multifocal central ring, helps to center the multifocal IOL. So the basics of optics. When you look at the eye, the visual axis is normally around 0.3 millimeters nasal to the pupillary center, and the optical axis is temporal to the visual axis. The optimal centration of the multifocal lens is between the visual axis and the pupillary axis. We know the basics. The optical axis connects the geometric center of the crystalline lens and the cornea. The visual axis is the line connecting the fixation point and the fovea. And the pupillary axis is the line that perpendicularly passes through the entrance pupil and the center of curvature of the cornea. So under peribulbar anesthesia, the patient does not fixate the microscope light. So here, in this case, the visual axis is not centered. The corneal light reflex corresponds to the anteriormost part of the cornea, which is the corneal apex. As seen in the video here, when you indent a used BSS bottle, the corneal apex changes and the side and the light reflex also changes. So the corneal light reflex. Light reflex is from the corneal apex, which usually corresponds to the geometric center. However, in certain conditions, it does not correspond. The average location of a decentered corneal apex, if decentered, is less than 0.2 millimeters temporal and 0.4 millimeters inferior to the geometric center. Now, as we know, the multifocal IOL should be centered nasal to the air bubble. So in any case, even if the corneal apex is decentered, it's usually temporal, and the IOL has to be centered nasal to this. So an intracameral air bubble is injected at the end of surgery after removal of the viscoelastic and reaches a position of the corneal apex. The corneal apex here is the maximum anterior elevation, which corresponds to a reflex seen under the microscope. So the alignment of the air bubble with the corneal light reflex confirms that the 2 points indicate the position of the optical center. The diffractive multifocal lens is centered in relation to these points and the small circular air bubble under the microscope. So a question arises, why not just use the center of the multifocal ring and the corneal light reflex? So it's not done because there's always a chance of there being some sort of parallax error. Moreover, a circular air bubble centers better with the central circular ring of a diffractive lens. And as we know, this point now corresponds to the optical center. The multifocal lens has to be decentered nasal to this point so that it can be centered between the pupillary axis and the visual axis. So a small video here which shows that we have to first center the eye under the microscope and align the corneal light reflex, the air bubble, and the central ring of the multifocal IOL under the microscope. It is important to remove the entire viscoelastic. Again, it's important here that the air bubble should be small. The perfect size would be reaches in relation to the central ring of the multifocal IOL. This technique works best for a diffractive multifocal IOL. It's not meant for a extended depth of focus which does not have a central ring. If it has a central ring, you can work with that. So it is important to align the central ring of the diffractive multifocal IOL with the air bubble and the corneal light reflex. So this is now corresponds to the optical center close to the corneal apex, and then the lens has to be decentered nasal to this. It is important because these lenses are self-centering in the capsular bag. It is important to nudge both the haptics also nasally. Thank you.
It's a good presentation.
Question.
Yeah.
Will you take questions now, beta?
Yeah.
You can stop sharing your screen. Yeah. So you described 1A, the technique, and B, the rationale for the technique.
Yes.
Do you have any bibliography on this?
I don't
or
have
are you the first?
I don't have any bibliography with this, sir. In my
Has
opinion,
this
I'm the
been-
first. Yes.
You're the first? Okay.
Yes.
Now, is this a one-man show or is this an institution?
It's a one-man show, sir.
Okay. And any results that you could tell us about, because you gave us a technique, you gave us the rationale,
Yes,
but you
sir.
have not backed it up with any results so far.
Yes, sir. So I've done it in 23 consecutive patients. And in all these patients, the results were satisfactory in terms of centration of the lens, and there was no any problem with this.
That was one, but suppose you did not use the air bubble.
Yes, sir.
In that series, without the air bubble, was there an issue?
Yes, sir. Before using the air bubble, I would center the corneal light reflex with the central ring of the multifocal. I have seen that the lens was not as well centered when compared to the air bubble. Because if the pupil was dilated at the end of surgery, the confidence was not there that post-operatively it would work out fine. But with an air bubble, it has given remarkable results.
No, I am not talking of a personal confidence. I am talking of the visual outcomes in terms of the refraction and other things.
Yes, so the visual outcomes in all these 23 serial patients was very good. And the patient did not have any
before with and without the air bubble का comparison की बात कर रहा हूँ.
Oh, so I don't have any data with that, sir.
Okay, you must get that because this is something path breaking, and it seems a little incomplete today without that data being backed up with actual facts and figures in terms of my experiences without the air bubble, my experiences with the air bubble.
Yes.
Yes.
I have a question for you, Siddharth.
Definitely. Yes, Karobi.
I have a question for Siddharth. Siddharth, what about the patients who this procedure would be defeated in cases who develop subsequent capsular fibrosis?
Yes, ma'am. This technique assumes that the rhexis is perfect, and there's no this presentation does not deal with any decentration of the lens because of a capsular problem. It assumes that everything else is fine. This is just the intraoperative thing, which an immediate post-operative.
Any other steps that you would sort of ensure that you do not get a capsular fibrosis in your patients of multifocals?
Would have an adequate size rhexis, and so just with the routine technique, ma'am. With this lens, I would not have anything else tried with that.
Siddharth,
yes, ma'am.
As Dr. Maniyar sir has pointed out, it's very necessary to complete this with the controls, means where you do not have air bubbles. Then only this particular paper will assume more importance, isn't it?
Yes.
But another thing is, even if in those cases where there was no air bubble, which you have used and put in a multifocal IOL, was there any really significant difference in your results as far as visual acuity is concerned?
Sir, the visual acuity was the same in the sense of that dependent on
then other factors did you consider, like contrast sensitivity or things like that, aberrations and other things?
No, sir, the contrast sensitive aberrations were not considered, but the post-operative visual satisfaction of the patient was much better with this.
Okay.
You have a superb paper here in the making. It's not complete.
Yes, sir.
But it's fantastic, it's innovative, it's brilliant.
Thank you, sir.
It's brilliant. And as Karandikar sir said, please complete this with more data, not just refraction, even contrast sensitivity and other things. Wish you well here. Thank you. We'll go to the next presentation, sir.
Yeah.
Karandikar sir.
Yes, sir. Yes, sir. I will call next speaker, Rajesh Joshi. Are you ready with the screen and everything?
Yes,
the topic is incidence and risk factors for vitreous prolapse in residents performing MSICS. Rajesh, please.
Thank you, sir. Respected judges and my dear friends. I am going to present this paper on incidence and risk factor for vitreous prolapse in residents performing small incision cataract surgery. Nothing to disclose. Cataract is the main cause of blindness. And despite the development in the cataract surgery, burden of blindness due to cataract continues to increase in developing countries. There is need of competent ophthalmologists to tackle the problem, and from we will get this ophthalmologist, either from private institute or government institute. So they should be trained well. Small incision cataract surgery is the preferred for cataract in developing countries due to cost effectiveness and less dependence. Residency
ये
program
तो fast charger है.
developing countries, the focus is on ECC and small incision cataract surgery. But the main issue in learning small incision cataract surgery is vitreous loss. Most studies have focused on finding out incidence of vitreous loss in fellows and practitioners. However, none focused on correlative factors and corrective measures to prevent vitreous loss in postgraduate. Therefore, this study. This was a retrospective record review study in patients who were operated by residents, 7 third-year residents from 2018 to 19 in a eye care center. After ethical committee approval, data was collected from the HMI system and it was fed in the Excel sheet. Data about the age, sex, history of trauma, diabetes, hypertension, all were collected. Patients who were given pseudo-exfoliation, patients, small pupil, subluxated cataract, post-vitrectomized eyes, posterior polar cataract, but usually these patients are not given. If at all they were given, they were excluded from the study. Surgeries were performed under peribulbar anesthesia by residents under supervision of senior surgeon from superior side by viscoexpression method, cortical wash, ivory implantation was done, and tunnel was secured well. The data were entered into the Excel sheet and was subjected to the statistical analysis. The data were expressed in mean and standard deviation. Fisher's exact test was done for categorical variables, whereas student t-test was used for continuous variables. Confidence interval for calculation of odds ratio was 95%. Univariate and multivariate logistic regression was done because there were multiple factors which were involved in connection with the vitreous loss. This shows the demographic profiles. In this, the type of cataract which were operated by the resident was mature senile cataract, that is 43.9%, followed by brown and immature senile cataract. Average surgeries performed by the resident during the period was 68. The incidence of vitreous loss in the previous study was 2%, that is 10 out of 490 patients operated by 7 residents had vitreous loss. 5 eyes had developed PCR, but there was no vitreous loss. These were the steps where the vitreous loss occurred, and the irrigation aspiration was the main step wherein vitreous loss was occurred. That is 5 out of 10 cases which had vitreous loss had a vitreous loss during irrigation and aspiration. This shows the association between the clinical characteristics and vitreous loss. There was no connection with vitreous loss with age, sex, eye of the patient, hypertension, diabetes, and blood thinners. But there was a connection between the anterior capsular extension and the vitreous loss. This was with demographic profile. The data was subjected to univariate analysis because multiple factors were involved, and we could found that the immature senile cataract, anterior capsular extension, and the irrigation and aspiration had association with the vitreous loss. The same data was subjected to the multivariate analysis, and we could see that immature senile cataract and anterior capsular extension and the irrigation aspiration had connections. So it was proved that these 3 factors were connected to the vitreous loss in the residents. The incidence of vitreous loss in the present study was 2%. The rate of posterior capsular rent in MSICS reported in various studies in practitioner and fellows varies from 0.14% to 1.9%. Reasons for inconsistent reporting of vitreous loss could be due to different surgical technique, exclusion criteria, training schedule, and supervised or unsupervised technique. PCR identification is crucial to prevent post-op complications like retinal detachment, cystoid macular edema. Supervised surgeries have less complications than unsupervised surgeries. Small incision cataract surgery study, which was performed in USA under supervision, had vitreous loss 1 in 52 cases. Unsupervised surgeries, which were performed in Middle East group, had vitreous loss in the tune of 10.2%. Older patients have more complications than younger patients, as seen by Gupta in their series in fellows and practitioners. Similar observation made by other authors also, but no such preponderance was seen in our study. Right eye and left eye. Some authors in India were noted the intraoperative complications were more in left eye operated than MSICS operated in right eye. This could be due to nasal bridge which come in the way of right-handed surgeon. In our study, vitreous loss was observed equally in right and left eye of the patient, and none of the surgeon in our study was left-handed. Factors causing vitreous loss in residents learning MSICS, immature senile cataract, intraoperative factors like irrigation and aspiration, and anterior capsular extension are the independent risk factor for vitreous loss. So even if the professor is operating somewhere else, we should keep in mind about these factors. Limitation of the study was single center study. Multiple surgeons were involved in the supervision, but they were trained. Non-randomized study, neither the patients nor the residents were randomized, so it's prone for selection bias, and it was a retrospective design. So conclusion of the study is vitreous loss 2% in the observed, 2% in the study. Residents require strict supervision while performing certain steps in small incision cataract surgery. These findings may serve as a guide for future trainers or residents in learning MSICS. So what is the solution? Designing of surgical schedule may ensure uniformity in the postgraduate training in the surgical procedure. And we have designed this schedule along with all the professors of ophthalmology across Maharashtra. And of course, simulator-based training. Thanks for your patience listening.
Karandikar, sir, can I go ahead? Karandikar, sir. You are muted, sir. Karandikar, sir, you are muted. Dr. Karandikar, you are muted.
Now, am I audible now?
Yes,
Rajesh,
yes,
you have presented the things very well. What I wanted to know, how it differs, the surgeries done by residents and practitioners as against the professors when they are doing MSICS, because the risk factors and incidence remains almost same, whether the professor is operating, I mean the senior person is operating, or the residents and the private practitioners.
In fact, if we consider residents, they go through various steps of cataract surgery that we teach them from JR2, while the fellows and practitioners, they are well versed with the surgery. The thing is that the duration of the surgery and the type of cataract which are being operated by the residents in the training and those who are postgraduates, they are entirely different. It has been found that in patients performing cataracts, in patients having mature senile cataract have more complication rate compared to mature senile cataract. This is important to phacoemulsification.
Rajesh, that's right. What I wanted to know, are there more complications with these people? For example, in a deep-seated eyes, or whenever there is a poor red reflex, or whenever there is a frontal bossing, things like that. Because in those circumstances, residents are likely to commit more mistakes as compared to the experienced surgeons.
Yes, as far as deep-seated eyes are concerned, in fact, we are giving perivalvular blocks. All the patients were operated under perivalvular block. And if you see the block eye after a perivalvular block, usually it comes up. So there is usually no problem in patients who are having deep-seated eyes. And the second one, like having red glow. In red glow, no red glow. Usually we stain or tell them to stain the anterior capsule with the help of Trifam blue. So that takes care of the red glow, particularly the capsular axis, which is a problem in patients having no red glow. So that takes care of this thing. And it's easily, if there is a mature cataract, you can prolapse the nucleus into the anterior chamber very well if you see the capsular axis margin very well. And,
are you giving same microscopes to the residents as the experienced surgeon in the medical college setup?
Yes, sir.
Is same microscope.
Rajesh, can I come in with a few questions here?
Yes, sir, sure.
Yes.
Acha, on these microscopes where the students operate and they are being taught,
yes,
do you or do you not have a camera to record the surgery?
Yes. In fact, we have one microscope having a side tube and which is connected to CCTV also. So whenever they are operating, we see through the microscope as well as the front CCTV that is in one microscope, and other microscope do not have side tube, but other microscope have CCTV arrangement. So surgeon who is supervising the surgery, he is continuously watching that during this.
That's fine. That's fine. So you do have a camera.
Yes.
Now, as part of your analysis, did you put in all your video recordings to find out where exactly the mistake occurred and why?
In fact,
I mean, having that resource and not alluding to it in this paper, I think that's a major lacuna.
We don't have recordings of this patient, but they were well noted by operating surgeon. So we could tell them, we could tell the residents that this is a problem with your surgery, and you can try to rectify in next procedure.
In fact, one of the key elements in learning or in skill transfer is that the student would have to look at his own video recordings in the evening, sit with his teacher or mentor or guide, and make sure that he doesn't make the same mistake again.
Yeah,
how many of your residents had repeated vitreous loss, or these were all were different patients, different residents? You know, you could have somebody like Dr. Maniar who keeps getting the same mistake and keeps getting vitreous loss again and again. And you have Karobi who never got vitreous loss.
Because you don't
Idiot with the posterior segment.
we
I do.
away all the victories.
Yeah, I do agree with you, sir, but that was not the part of the, in fact, this article. In fact, those who are high myopes and having depth problem, we could found out that they had repeated vitreous loss, or may not be that repeated consecutively, but more frequently.
No, but can I suggest that you have a recording device for your teaching aids, you know, your teaching microscopes? And I don't know if this is relevant here, but at Chitrakoot, we have a recording of every surgery for the last, I think maybe 15 years or so. So it's a fantastic resource in terms of learning. The second thing is that in the patients that had vitreous loss, you're all doing automated IA or manual IA?
This was manual one by Simcoe's cannula.
Simcoe cannula manual IA. Okay.
Yeah.
And most of your vitreous loss occurred during eye irrigation aspiration.
Yes.
So now, as a consequence, after this study, have you made it a point to reinforce the correct and proper way of doing IA for the students?
Yes, definitely. We have told them that you use a large bore cannula and make sure that your irrigation line is not having air bubble. Sometimes there is air bubble in the irrigation line and that blocks the irrigation and you tend to aspirate. And what happens, there is no dexterity to start to begin with. And irrigation and aspiration, you need to have proper aspiration through your left hand. And the irrigation probe goes inside with your right hand. So there is always a problem with this. So you have to learn it properly. So that could be the reason of vitreous loss in most of the residents performing cataract surgery in irrigation and aspiration stage.
I suppose every time they held the capsule erroneously, they pulled away, and that was the reason for the vitreous loss.
Yeah.
Rather than stop and reverse, they pulled. I mean, this would be evident on a video. You know, any amount of statistical analysis that you put, but there is nothing to beat a video analysis and the student to go through that himself with his mentor, of course.
Yes.
And the third final point is that every time you get a vitreous prolapse or any other complication, do you record it on the table in the op notes for the student?
Yes, sir. That was recorded.
Okay. Fine, sir. Thank you. So, Karobi, any questions? Karobi.
Yeah, Dr. Rajesh, you presented a very, very nice paper. You have looked into so many aspects of the paper, and it is good to take the inputs of Dr. Karandikar and Dr. Maniar as to the extra features which you could place in your paper for the next presentation. But I wish to say that, you know, apart from all this also, there are so many other factors which go into teaching a resident a proper type of surgery. So the thing is that these must be students or people who have been trained by various teachers, or is it by one single teacher?
No, by various teachers.
Various teachers. So each one's technique differs a little bit. Their way of functioning differs. The character of the student also differs, because some are very bold, some people are a little skeptical, some are nervous. So all those kind of translate into what kind of surgeries you dole out when you do it, and especially when you are learning. But all in all, I have no questions for you, but I just wanted to congratulate you on the toner of your paper. It was really good because you've looked into many aspects which are important.
Thank you so much.
Good
See,
comments.
Rajesh, we told you the judges are lenient. Na? See, Karobe is so lenient.
Okay, let us pass on to the next paper. It
Yes,
is
sir.
from Suruchi Arya, Demographic and Microbiological Profile of Infective Keratitis in Aurangabad.
Thank you, sir. Good afternoon. The title of my paper presentation is Demographic and Microbiological Profile of Infectious Keratitis at a Tertiary Care Hospital in Central Maharashtra. So I would like to start with giving a brief intro about my topic. So infectious keratitis is a suppurative infection of the cornea characterized by the presence of white or yellowish infiltrate in the corneal stroma. It can present with or without an overlying corneal epithelial defect and can be associated with signs of inflammation. So WHO recognized that corneal blindness resulting from the microbial keratitis emerging as an important cause of visual disability, which is responsible for around 1.5 to 2 million new cases of monoocular blindness every year in our country. Gonzalez et al. Study, which was done in Madurai district of South India, estimated that annual incidence of corneal ulceration was 1,130 per million population. In India, approximately 6.8 million people show vision less than 660 in at least one eye due to corneal diseases. And among them, about 1 million have bilateral involvement. Number of individuals with unilateral corneal blindness in India was expected to increase to 10.6 million by 2020. So the aim of my study was to evaluate demographic and microbiological profile of patients with infectious keratitis at a tertiary care hospital in Central Maharashtra. So coming to materials and method, it was a prospective observational hospital-based study conducted on 37 patients. Inclusion criteria: all patients with infectious keratitis attending ophthalmology OPD were included in my study, and patients with impending perforation or perforated corneal ulcer were excluded. So procedure: complete ocular examination was done with the consent of the patient. Visual acuity was tested with the Snellen's chart. Detailed anterior segment examination was done on slit lamp. Sec patency was checked, and detailed microbiological evaluation of corneal scraping was done on gram and pH staining and blood agar, chocolate agar, and seborrheic agar. So this is a fungal culture obtained from one of my patients, showing a very nice brown reddish hue, which is suggesting of the species Fusarium oxysporum. This is another isolates obtained from another patient, which is showing a brownish blackish granular deposit growth, which is suggestive of the growth of Aspergillus fumigatus. This fungal culture is showing a nice fluffy cottony-like growth, which is suggestive of the Trichophyton mentagrophyte species. Blood culture is showing the growth of Staphylococcal species, and the gram stain is showing gram-positive cocci, which is present in pairs, and they're also present in a cluster-like fashion. This gram stain is also showing gram-positive cocci arrangement in a cluster-like pattern. So coming to results and discussion, so I would like to start with the demographic profile. So 72.9% of my patients were male, and this preponderance of male patient could be because male are more involved in outdoor work. As per age group, maximum patients were between the age group of 41 to 60 years of age. 64.86% were from the rural population, which was similar to the other studies which was done in the West Bengal, South India, and Kashmir. As per occupation, most of my patients were farmer by occupation. Coming to microbiological profile, so total 37 patients, out of 37 patients, 54% patients were gram-positive cocci, and 5.4% patients showed gram-negative cocci on bacilli on gram staining. If we compare it with the 10% KVH mount, 37.8% showed positive growth for fungal elements. If we look at the isolates, in my study, microbial culture was positive in 40.7% cases. And if we compare it with the various studies, these are the following culture positivity which was observed in their respective studies. So in my study, 18.1% of patients showed pure bacterial growth, 63.6% patients showed pure fungal growth, and 18.1% showed mixed growth. If we look at the isolates, among bacterial isolates, 27.2% showed Staphylococcus species, which included Staph hominis and Warneri. 9% patients showed Streptococcus species, which included Strep pneumonia. And if we compare it with the fungal isolates, 63.6% patients showed Fusarium species, which included Fusarium soloni, Oxysporum, and Dimarium. 9% patients shows growth of Aspergillus species, which include Fumigata, and another 9% patients showed Trichophyton species, which included Trichophyton mentagrophytes. So Streptococcus pneumonia was a predominant species in South India and Kashmir, but in our study, only one culture was positive for Strep pneumonia, which was similar to the study done by Aarti et al. In Ahmedabad. Fungal isolates were seen in 81.8% of the total cultures, which were similar to the other studies. And studies from West Bengal and South India also showed a relatively higher percentage of fungal etiology. The most common fungal species isolated was Fusarium, which matched with other studies by Aarti et al., which was done in Ahmedabad. So the conclusion of my study is farmers residing in rural areas most commonly affected with male preponderance. In our study, fungal keratitis was more common than bacterial keratitis, with Fusarium species being the predominant fungal pathogen and Staphylococcus species being the predominant bacterial pathogen. Finding of this study shows difference in epidemiology as well as microbiological etiology. Regional differences should be borne in mind while treating this microbial keratitis in culture negative cases. So, microbiological assessment of every corneal ulcer patient should become mandatory so that appropriate treatment is instituted at the right time, and in the long run, we can save the vision and get the better outcome from the patient. Because if incorrect treatment go on for a long time, so managing the ulcer and
Time up, please.
This is the last one. So initiating accurate evidence-based treatment at the outset itself will always show a better outcome in the long. Thank you. These are my references.
Thank you.
Can you go back to the slides where you are showing the incidences of your cultures? Back one more. Yeah. Hold it. Just go down, scroll down on this slide.
Yes.
Scroll down. Or this is the full slide? No. Yeah. This is the full slide. Now, let's talk about that. You had 37 patients.
Yes, sir.
Of which 11 had a positive culture.
Yes, sir.
16 showed no growth.
No growth.
And 10 were not done.
Sir, yeah, in 10 we couldn't done it.
Now, the question is, when and how is the microbiological study done? Is it done in the OPD? Is the patient sent to the micro department? Who does it in the micro? Because 16 no growth is a fairly large number, and 10 not done needs an explanation as to why it was not done.
Sir, actually, it was a hospital-based study. So this corneal scraping was done on OPD basis, and it was done by me only. So I have sent the corneal scraping and mounted on gram stain and QH stain, as well as the blood, chocolate, and sabarat agar, and then sent it to the microbiology lab. And there, their technicians had done these investigations, the further investigations. And in
what about your
Yes.
reporting of the micro lab? Was it immediate? Was it delayed?
Sir, actually, gram stain and QH stain came within 1 hour, and routine culture took around 2 days. but fungal culture took time, around 1 to 2 weeks.
Yeah, about the not done, you were saying?
So not done because the patient was not affordable. That's why, sir.
Not affordable.
Actually, the 10 patients were.
They refused.
Yeah, exactly. They refused to do
No,
it.
that's what sir is saying. But now that is a prompting. What I'm asking is from 37 of them, 10 of them are just not part of the study at all.
So
Because you have not done. So you have 27 patients in effect, from which 16 are no growth and only 11 are growth. You are looking at less than 20 or less than 30% of your patients who had some growth, based on which do you think it is justified to have a conclusion?
So the
That
16
is the question. Statistically,
yes, sir.
27 patient from 27 patient, only 11 had some findings, and you have made a conclusion based on that, and you have presented that conclusion. So the question to you is that conclusion statistically valid?
So it can't be actually. So because gram stain and KH staining was done in every patient, all the 37 patients, but the culture was not done in 10 patients. So
Oh, I see.
So you are
Show me the slide again.
yes, sir.
screen sharing.
Okay, this is the culture, and go back one slide. Go back one slide. Okay. Gram staining 22 and KOH mounts 10% KOH mount. Understood. I got you. So your culture was deficient, but your staining was there for all.
Yes, sir.
Okay.
Means
So on the basis of yes, sir.
your study was basically based on smear reports, what we call, whether it is KOH or whether it is a gram staining, isn't it? Rather than the actual culture reports, because culture reports will definitely be taking more time as compared to the smear reports, based on which you can start your treatment quite early.
Yeah.
Significantly, in the fungal culture, you found more of a fusarium as against aspergillus, which is very commonly seen in the southern part of India.
Yeah, yes, sir.
So it has got a implication in treatment part, I suppose.
Yes, sir.
Right. ठीक है. Any other question? Judges? Karobi?
Hi, Suruchi.
Hello.
Good compilation.
Thank
The
you,
only
ma'am.
thing which I wanted to ask you, did you encounter any patients of acanthamoeba keratitis?
No, ma'am. Not in my study.
I mean, none of these were contact lens wearers or whatever.
No, ma'am. No, ma'am.
64% male rural. कौन contact lens डालने वाला है इसको?
They are from rural area, agricultural workers mostly, isn't it? Okay,
Yeah.
sir. Should we
Sir,
pass on to the next?
there is one observation here, is that
You
what
can stop sharing the
percentage
screen.
what percentage of your OPD patients had these keratitis, infective keratitis? Meaning, if you had 100 patients a day, how many had infectious keratitis?
Sir, we have actually in our OPD, we have cornea clinic 2 times a week. So almost in 1 month, we are getting 50 patients for corneal. Sorry, not
Now, in view of that, would it be logical to get the microbiological department to be part of your cornea clinic setup in terms of being present in the OPD itself?
yeah. Yes, sir. Sure.
Because your no growth at 16 is pathognomonic of a delay and of a poor culture, of a poor methodology of culture. if you go to LVP and if you see the systems and the anatomy in terms of getting more results is so well developed that I think you can emulate them on this score at least. Thank you. Go ahead, please.
Suruchi, just one more question for you.
Yeah.
You said you did all the scrapings and the cultures, etc. yourself, right?
Yeah.
And
Yes.
so, can you just elucidate how did you do the scrapings? Just your technique?
Yes, ma'am. Ma'am, the cornell scraping was done on the slit lamp. So I have used a 15 number Bart Parker 15 number blade. So on the slit lamp, post topical anesthesia was instilled. After that, the cornel was scraped at the floor and from the margin, I have scraped the cornea. And then I put it on the gram stain slide and the 10% pH mount slide. After that, I have inoculated the cornel scrape on the blood agar, chocolate agar in a C shape, C pattern. And then fungal Seborrheic agar was inoculated with the help of a sterile loop. It was available in our lab. So from
which area of the ulcer? From which area of the ulcer?
So from the margin and from the base.
Okay.
And then
Okay, continue.
Microlab.
And do you feel that getting a negative report is anyway not part of your effort, but it is a part of lacuna on the part of the microbiology department?
It could be, ma'am. It could be.
Okay. Thank you so much, Suruchi.
Okay. Thank you, ma'am.
Thank you. The next speaker is Dhananjay Prajapati.
Yes, Ragini, you have a question?
No, I just wanted to wish you a very happy birthday. May you be blessed and you are surrounded by the stalwarts and gurujis in ophthalmology on your birthday.
I know.
Respected Karandikar sir, respected Mukadam sir, Manjit Manyar, Bapuji, and you. Pranam and thank you so much. Thank you so much.
Thank you so much for all
Thank you,
I have
Ragini.
to run away from this session because I cannot be here. My students are here. But I just wanted to say Pranam to all of you and I couldn't resist myself.
Don't run away.
Ragini, all the best and all the best to you, Ragini. You're doing really great work.
Your dad is also here.
No, he's not. He's here as a speaker. He can't talk right now. He can't talk.
Okay.
Yes, Prajapati. Dhananjay. Dhananjay Prajapati. Next presenter. Is he there?
His slides are on, but I don't know where he is.
Prajapati, are you there?
I think we'll pass to the next one. And if he comes, we will accept it. Okay?
Yes.
Next one is Supriya Bauke.
Yes, sir.
Are you ready with your slides and everything?
Yes,
Stop
sir.
screen
Yes.
share.
Please share the screen.
Yes, sir.
Yes. And start with it. Here the topic is comparative study of binocular indirect ophthalmoscopy and reticam done with the for screening ROP. Yes.
Yes, sir.
Retcam.
So shall I start?
Yeah.
Good afternoon, everyone. So topic for my presentation is comparative study of binocular indirect ophthalmoscopy and made in India RedCam smartphone-based screening for retinopathy of prematurity. So my aim of the study is to compare the efficiency of made in India RedCam with that of indirect ophthalmoscopy in screening of ROP. So now what is the need of the study? As India has the highest overall number of premature births in world and currently facing an ROP epidemic that has penetrated into the peripheral rural districts. So the incidence of ROP in different regions across India has been reported to range from 38% to 47%. So this increasing incidence warrants for early screening and diagnosing of ROP in preterm babies for appropriate and timely intervention. So this MII RedCam can be a potential alternative imaging tool for objective documentation and monitoring of ROP in low resource setting. So my study is a prospective study which includes 94 preterm babies, out of which 50 are males and 44 are females. The inclusion criteria is preterm babies with less than 32 weeks of gestational age and less than 1500 grams of weight with additional risk factors like oxygen supplementation, respiratory distress, and sepsis. So So the instruments used in the study are the MII RedCam device. As we can see, it consists of 2 slots, one slot for smartphone and one slot for the lens. The lens used in the study is 2.2 pan-retinal lens. So now the procedure. Consent was taken from the parents, as well as the importance of ROP was explained to the parents before screening. For study, iPhone 4S and VOOC 2.2 pan-retinal lens were used. The device was held in one hand, and therefore the other hand was free to perform the scleral indentation and to perform other maneuvers. The device was held in front of the baby's eyes by holding the handle near the smartphone end. The constant illumination in the video mode was switched on, and once the red glow was seen through the dilated pupil, it was slowly withdrawn till a clear image of the fundus was visualized on the smartphone screen. To get a good quality image, it was important to ensure that the image fills the entire lens without any light reflection, and this was achieved by slight forth and back movement or tilting of the device and stabilizing the baby's eyes with scleral depressor. First, the posterior pole was examined, which was followed by the entire peripheral retina in a sequential manner, which was facilitated with the eyeball maneuver towards the desired direction using the scleral depressor. After completion of the recording, the good quality images or stills were extracted from the videos. And babies with immature retina and retinopathy of prematurity are followed up as per the guidelines, and the same protocol is repeated at each visit. So these are some of the photographs which are extracted from the videos I've recorded. As we can see in photograph number B, there is a demarcation line between the avascular and vascular retina, thus giving a staging of zone 3, stage 1. And in last photograph, we can see the ridge formation. So in zone 2, that is zone 2, stage 2. Here in first photograph, we can see the vessel tortuosity over the posterior pole, while in second photograph, we can see there is a ridge formation in zone 2, giving a staging of zone 2, stage 2. So total 94 babies have been examined, out of which the binocular indirect ophthalmoscopy documented ROP in 44 babies, while that of MII RedCam documented ROP in 34 babies, thus giving a success rate of 77.27%. So this is the staging done according to the International Classification of Retinopathy of Prematurity. So as we can see here, the MI RedCam was successful in documenting the ROP in babies which were in zone 1 and zone 2, but which were not documented or missed by the MI RedCam were in zone 3, stage 1. So mainly according to the statistical analysis, the sensitivity of MII RedCam as compared to that of the standard indirect ophthalmoscope was 78.57%. So concluding, modern smartphones with its constant and coaxial and powerful light source, when coupled with the 2.2 pan-retinal lens, it creates a binocular indirect ophthalmoscope-like system, thus enabling us visualization of the fundus, and also the built-in automatic focus camera enables the imaging of the fundus. In my study, the MII RedCam was successful in documenting about ROP 77.27% of the babies as compared to that of the indirect ophthalmoscope. Though it is less than that of the wide field RedCam, it has certain advantages like the device is more affordable as compared to the wide field RedCam. It has minimal learning curve if one is well versed with the indirect ophthalmoscopy and smartphone photography. It is cost effective, non-contact and user friendly, and which can be used in any setting. So earlier the study has been carried out using 20D lens, which has a field of view of 46 as to 60 degrees. Well, so in our study, we used 2.2 pan-retinal lens. The field of view was 56 degrees. Also, the RedCam offers MII RedCam offers a low-cost substitute for wide field RedCam imaging, adding another dimension to telescreening of the ROP, mainly in the rural areas. Also, it has a real asset in the practice of evidence-based medicine, and it can be valuable proof in the medico-legal situations. The MII RedCam can also help in creating the image database, which is useful for academic as well as research purposes. Also, the paramedical and ophthalmic assistants can be trained for ROP screening in the rural India, and a telemedicine network can be set up. So thus, I can conclude saying that the MII RedCam is a potential alternative tool, imaging tool, enabling the objective documentation and also for the monitoring the retinopathy of prematurity in low resource settings. These are my references. Thank you.
Yes, Karubi.
Supriya?
Yes.
Well presented paper. Only a few things I want to to know what was the learning curve like for you with this particular gadget?
Yes, ma'am. As for ophthalmologist or for me as a resident, as we are well versed with the indirect ophthalmoscopy, so it was less than 1 week duration. But if we are saying about training for the paramedical staff or the ophthalmic technicians, it will at least take 15 days, but which is comparatively lesser as compared to the other instruments.
But you mentioned something that it was unable to pick up patients in the far periphery. That
Yes,
was
ma'am.
in zone 3, you were not able to pick up. So the thing is that sometimes you get these kind of problems sometimes over there. So like, how would you place it as a telescreening model? I mean, in the sense, would you use this as a telescreening thing where you are not going to be seeing the patient and you will be relying only on the photographs to make a decision whether the child requires treatment or not?
No, ma'am. In such patients, we'll see the other risk factors like the gestational age of the baby, the birth weight of the baby, and if there is any suspicious signs, then we can refer the patients for the further any second opinion, like in suspicious fundus examinations.
No, because in the telescreening models, it is the paramedical people who go and photograph and they send it to the parent center where they see all these images and they decide which patient has to come, you know.
Yes.
And so obviously it is because there is no trained person over there that, you know, some help goes over there and then the help is given by the parent center over here. So I really don't feel this would be a very viable kind of thing unless there is a posterior pole disease. But the risk of missing out things which are there in the periphery would be
Yes, ma'am.
definitely there with this kind of technique. And you cannot afford that kind of thing in prematures because you have to know,
Yes,
because
ma'am.
there is, as you know, there is a window in which they have to be treated. Also, can you just describe your technique by which you did it? Means, did you mummify the child? Did someone hold it for you? What were you holding? The depressor, the this, and how were you aligning the MI2 MI2 RedCam for getting a clear image, because most of the images that I found were not very
Yes, ma'am.
sharp.
The quality of.
Yes, the quality of vision.
Ma'am, actually, I would like to show. This is the red cam which I had used, ma'am. So here is the slot for the lens, and the other slot is for the smartphone. So this comes in one hand. So lens and the phone. This device was held in my one hand, and with the other hand was free for rotating the baby's head or do the scleral indentation. Also, along with me, there was actually the study was carried out in the neonatal intensive care unit. So there were the sisters or the staff available in the intensive care unit. They helped me to hold the baby steady, and I had hold this device in one hand, and my other hand was free to rotate the baby's head, and accordingly, then I recorded, ma'am.
Okay, fine.
Can I come in, Karogi?
Yes, yes, sir.
Yeah. Okay. I think it's Supriya. Yeah.
Yes, sir.
Supriya, your what is the weight of your device? The weight. What you just showed us. What is the weight?
Sir, actually it is not much, around 50 to 100 grams or less than that, sir.
Okay, so it's made of plastic.
Yes, sir.
Okay, so there is no significant weight increase over just the handheld lens.
No, but Dr. Ranjit, the weight increases because of the lens, which
Lens
is
and the phone.
and the phone. So
And the phone.
effectively it
Okay,
becomes
that's one.
1.8.
The second thing is, are you comparing this study with the indirect ophthalmoscope or with a RedCam?
Sir, I'm comparing with the indirect ophthalmoscope because we have here the retina specialist who screen the ROP babies. So I had this
Okay,
double-blinded.
hold on.
Yes,
Now
sir.
go back to your conclusion then. Go back to your conclusion.
Yes, sir.
You have in your conclusion made a reference to the RedCam. Now, if the study was not designed for it, go to the second last slide or whatever. RedCam. Iske baad.
So this one?
One before this, I think.
So this one?
No, the one after. I'm sorry. The one, yeah. Advantages.
Yes, sir.
Device is more affordable as compared to the Whitefield RedCam.
Yes, sir. Sir,
That's one.
Yes, sir.
That's one. Now the point here is we are comparing quality and we are comparing results in terms of diagnostic value.
Yes, sir.
And suddenly you have jumped to a financial data, which was not part of your study at all, na?
Sir,
Follow where I'm leading you. I'm trying to tell you,
yes,
when you have a study which you have defined for something, your
yes,
conclusion must be limited to that.
Okay, sir.
Now, limited learning curve. Okay, cost effective, no contact, can be used in any setting, but you have used it only in one setting, and that is in your neonatal ICU.
Yes, so but we can, sir, I have used in the intensive care unit, but it is the device is very portable and handy, so we can carry like it can be used in the OPD as well as in the intensive care unit, or also we can carry any places we are going for screening. So, sir, I've written it in any setting.
And then this third question is about this 77.27%.
Yes, sir.
That is a percentile of the indirect results.
No, sir. That is the percentage of MII RedCam that the RedCam was able to successfully document ROP 77.27% as compared to that of the indirect ophthalmoscope.
Can I interject at this point?
Yes, ma'am.
Supriya, see,
Yes,
the thing is
ma'am.
that comparing those two for documenting and visualizing, they are two
Yes,
different
ma'am.
things. Visualization is possible with the indirect, and documentation is possible with your MI2 RedCam. So
Yes,
instead
ma'am.
of saying a binocular indirect examination, it would have been better if you had said a video indirect, where you document as well as you see the patient, because here we are comparing documentation and not visualization.
Yes, ma'am.
What we call it as a subjective or objective. Whatever you are seeing with your indirect ophthalmoscope is a subjective thing.
Yes, sir. With
While
indirect is
documentation as a objective thing, isn't it? And as sir has pointed out, it is not a comparison which you made between the BIO and your MFSI. It was
Yes.
a comparison which you made with the RedCam.
Right.
Okay. Any other question?
No more question. Thank you.
Okay.
Thank you. Thank you, ma'am.
Thank you.
Thank you.
Thank you. So, Dr. Dhananjay, you are ready?
Acha, Dhananjay has come back.
Please share the screen.
Please start.
Yeah. 6 presentations more to go. And, please start the timer.
Good afternoon, everyone. This is Dr. Dhananjay Prajapati, and I'll be speaking on mascarates of mucormycosis. I have no financial interest in this presentation. This past year of COVID has taught us many things, including my mucormycosis, which is surely one of the feared things. It was rare before that of COVID, but during this COVID, we have seen a lot of mucormycosis in our OPD. Mucormycosis is basically an opportunistic fungal infection, which is seen more frequently in patients who are immunocompromised or are diabetic with uncontrolled blood sugar levels and have a very high rate of morbidity and mortality. The patients of mucormycosis usually clinically they present with sinusitis, periorbital pain and edema, external ophthalmoplegia, proptosis, ptosis, diminution of vision, and advanced cases also presented with complete loss of vision. The diagnosis of mucormycosis is not just clinical or imaging, but it's a correlated thing between the clinical, imaging, and histopathological. Treatment of mucormycosis is a multidisciplinary approach with combined efforts of physician, ophthalmologist, and ENT surgeon. Now, talking about the case, a 57-year-old male presented to OPD with right eye diminution of vision, periorbital swelling, congestion, chemosis, restriction of extraocular muscle movement in all gazes. This is the clinical picture of the patient. Unlike the other cases of mucormycosis who had history of COVID infection or were diabetic, this patient was neither nor he had a history of COVID-19 infection, but he was recently diagnosed as a case of hypertension. The fundus examination of this patient revealed this picture, which was typical of central retinal vein occlusion. The imaging CT scan of this patient showed right glotoptosis, bulky extraocular movement, muscles with intracorneal fat stranding, mild mucosal thickening of bilateral ethmoidal and maxillary sinus. So a presumptive diagnosis of ROCM was made and the patient was admitted and was started on amphotericin B. FES was performed on this patient and specimen was sent for histopathological examination to look for any fungal element, but turned to be negative. After a couple of days, the patient unfortunately turned positive for COVID-19 and was shifted to COVID care hospital, where he was started on amphotericin B, steroids, and antibiotics. A week later, this is the clinical picture of this patient with almost resolved clinical complaints of this patient, except for engorged conjunctival vessels. So a repeat MRI was done with contrast angiography to look for anything which had been missed out earlier, but this came to be inconclusive. Finally, a digital subtracted angiography was done, which revealed keratocavernous fistula of low grade. A digital DSA intervention was made. The patient is now doing well. So conclusion of this is that in this pandemic, mucormycosis was endemic in many parts of India. There are many other conditions which are clinically present like mucormycosis, but clinicopathological correlation helps to come to the diagnosis. Thank you.
Dhananjay.
Yes, sir.
Do you have a stethoscope?
Yes.
Do you have a stethoscope?
Yes, sir.
Did you auscultate the globe?
No, sir.
It's diagnostic. A CCF, keratocavernous fistula, will have been picked up immediately without any venogram and other things by just pure auscultation. The other test that you do would be to confirm your diagnosis, but not to reach that diagnosis. So an ophthalmologist must also use his stethoscope, especially in a case of proptosis, to check if it is pulsatile or not.
This was basically an indirect CCF, which was not even picked up by MRI scan, MRI angio.
Arey bhai, you pick it up in the clinic. Where is the MRI in the question? You pick it up at first with a pulsatile proptosis. You pick it up immediately in the OPD itself.
Okay, yes, sir.
Karandikar, sir.
Oh, nothing. No question. Robi.
How many of your patients responded to amphotericin B, and how many required this exenteration or anything of that kind?
Around 50 to 60% of the patient, they responded well to amphotericin B, but the patients who are progressed to ophthalmic involvement or central nervous involvement, they did require centration.
And amphotericin B was given for how many days and what dosage?
Around conventional amphotericin B was available, ma'am, which was given a 50 milligram dose per day for around 20 days.
And what did you monitor when you were giving the amphotericin B?
Serum electrolyte levels and RFT levels, ma'am.
Okay. In any patient, did you all try ambisome, that is the liposomal amphotericin?
Yes, we did try it, ma'am.
And how many patients?
Actually, depending upon the availability, it was, ma'am, not available every time, ma'am. So,
what about the cost factor?
Which factor, ma'am?
Cost.
Cost factor.
Cost factor. Yeah, it was. The cost of liposomal ampho was quite high. So many of the patients, they could not afford it.
And for how many days did you give the amphotericin to any patient?
Max which was being given was 8 days. Later, he was shifted to conventional, ma'am, because of availability. Liposomal was not available.
What do you mean by conventional?
Deoxycholate.
Okay.
Okay. See, as far as sir has pointed out, the importance of a stethoscope means other clinical examination also is important, because as we are ophthalmologists, we may miss it many times. As an ophthalmologist, for mucormycosis, we should divide it into 3 stages minimum: the probable, possible, and positive. And accordingly, you should go ahead. What I was wondering in your mode of treatment for the use of steroids also along with the antibiotics and amphotericin B. Is it right? Whatever I observed in your slides, you have given steroids also along with it. Was it given from the very beginning?
No, sir. When he turned out to be COVID positive, there in COVID care hospital, it was started.
See, it is also very rare to get, as your title suggests, it's true, but it is also very rare to have a COVID and a mucormycosis together at the same time, because mucor occurs later on.
Actually, in this case, the swelling preceded the COVID.
Yes.
Yeah.
The swelling preceded the COVID diagnosis. So, what was the rationale for the amphotericin B and the other treatment? Just one small auscultation would have solved your problem.
Yes.
I think, okay, we should pass on, isn't it, sir?
Okay.
Okay. Next paper is on experience of offline artificial intelligence in detecting diabetic retinopathy by semi-skilled health workers by Dr. Netty. Yes. Yes, start with Natarajan. Dr. Natarajan?
Yes, sir. Yes, sir. Yes, sir.
Yes.
Thank you very much, sir. Thank you, Dr. Kandikar and judges.
Yeah.
My paper is on our experience with offline AI in detecting diabetic retinopathy by semi-skilled health worker in Municipal Corporation of Greater Mumbai Clinic. And I have no financial disclosure. And diabetic retinopathy is one of the leading cause of blindness in diabetic population. And the global prevalence of diabetes mellitus is estimated to be 9.3%, expected to rise by 10.3% by 2030. And India has around 77 million diabetic, which is the second highest number of diabetics in the world. And the institutional review board approval was obtained. Study conducted across 174 dispensaries of the Municipal Corporation of Greater Mumbai that offer diabetic mellitus screening. An informed consent was taken in a prospective cross-sectional study. Known diabetics visiting the MCGM dispensary were screened for diabetic retinopathy by semi-skilled worker who are actually a non-skilled worker trained by us and made a semi-skilled worker in imaging and use of AI and patient counseling. The Remedio non-metastatic fundus on phone camera was used to capture fundus images, and the images so captured were subjected to automated analysis by the Meteor's artificial intelligence, a proprietary software, and the AI was run offline on the smartphone to detect referable diabetic retinopathy on images taken by a semi-skilled worker. And this is a picture showing the screening at the dispensary happening. And we have a camp information which was sent to one month prior to dispensaries and medical officers in the Municipal Corporation of Greater Mumbai. Counseling of all diabetic patients were done by the medical officer for diabetic retinopathy checkup. Written informed consent was taken from all participants before screening. Preliminary details such as age, sex, occupation, phone number, address, duration of diabetes, and postprandial blood sugar were recorded. Pupils were dilated using a single drop of 1% tropicamide. Fundus imaging was done in 10 minutes by the semi-skilled worker using smartphone-based fundus camera. The device was also equipped with an offline AI for diagnosing referable diabetic retinopathy, defined as disease severity of moderate non-proliferative diabetic retinopathy or more. And the images were uploaded on the cloud storage and were graded by a vitreoretinal surgeon into mild, moderate, and severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. The AI algorithm was run offline on the smartphone by the social worker immediately after the image acquisition. The offline automated analysis graded these images as referable diabetic retinopathy and no diabetic retinopathy. And class activation map mapping shows the lesion which are detected by the AI, and that's what you see here. The blue color which detects the diabetic retinopathy. It can be held handheld or a slit lamp, and both the infrared device and the phone can be charged, so that there's no need for electricity or internet when you work in the villages or anywhere. And here you say diabetic retinopathy detected in 29%, 39% could not be graded due to cataract, and 32% were due to other condition. 2,241 diabetics were screened, and of those, 506 subjects were detected to have various eye diseases. 147 were detected to have diabetic retinopathy by the artificial intelligence, which is offline, while 197 images could not be graded due to cataract, and 162 were detected with the other eye condition. The discussion and conclusion: the current study uses a public-private partnership model for diabetic retinopathy screening to use the resources from both the sector in the best possible way to increase the efficiency of screening. By using the already existing government infrastructure for diagnosing diabetes, the diabetic population can be easily targeted for screening. The results from the study showed that this model can be an ideal tool for community screening, as it does not require the presence of eye doctor or ophthalmologist at the screening site. The ophthalmologist can view the images from his or her office to diagnose retinopathy, and reports conveyed later to the patient. And even here, the semi-skilled worker also can convey using the offline AI. The conclusion: the AI gives real-time presumptive diagnosis. It's a cost-effective model. It can be easily integrated into the national program for control of non-communicable diseases, making diabetic retinopathy screening accessible to all. And these are the references. And this is the machine which
in order to the macula details.
So you can see the macula can be focused like this, and then it can be, this is a non-skilled worker who are being trained, and you can take pictures like this, and then you can save it, and then you can apply the artificial intelligence, and that will say that this has a diabetic retinopathy or not. Thank you very much.
Good presentation, Nati. May I ask you one thing? What was your normative data for Indian population whenever you are using artificial intelligence for that?
So they have taken this Medias company is situated in Singapore, but they are working with the Remedio company in Bangalore, and they have taken images from the diabetes clinic called Vircon in Bangalore, and 50,000 images from in Bangalore were taken. And then that's what is used as the standard. And now the numbers have increased in the last few years to more than maybe 2 lakhs.
Did you encounter difficulties with the artifacts, resolution and things like that?
Yeah, that's what. If you have a cataract, the images don't come. In the beginning, when we did an initial publication in JAMA, where we had only 253 patients, without dilatation, only 45% could take a good picture. And with 1% tropicamide, after the NHS study published, where they didn't find any secondary glaucoma, so in 10 minutes it is semi-dilated, and then you use the Remedio camera. If the media is clear, there's no problem at all.
How they used to transfer the data to you?
Here, the semi-skilled worker in the clinic actually has it in the mobile phone itself, the AI. So that will say detectable, non-detectable. And then to counter-check, the images were sent by the internet, because it's in the Mumbai Municipal Corporation, so there was no problem.
What I wanted to know, are they having good camera, I mean the good mobiles with them to transfer the data? Otherwise, the resolution and other things will create a problem.
Yes. This
in
media
also.
No.
And what about the other diseases? What about the other things if their diabetes is mixed with hypertension, retinopathy, or any other disease? Then that can be a problem in making a correct diagnosis. And
correct, so this is field screening where we want the, for example, in a village where there's no internet and electricity and no eye doctor, the images will be later when they come to this town where there's an internet, the images will be transferred. But at least in the place, but in municipal corporation here, this particular Remedio is using only the iPhone, and unfortunately, it's still not available in the Android phone. So only in iPhone model 5 onwards till 8, I think they're using, and then the software is installed in the iPhone. And where this 8 standard pass or fail for social workers, we have trained them and they can use it. So you don't need any education, and that's the advantage of giving a job opportunity. and also may screen all these diabetics without they going to the eye clinic in the diabetes.
A few questions here.
Yes, sir.
You said you have no financial interest.
Yes.
But you are marketing the iPhone here. Okay, jokes apart. Now, these AI diagnosed images, the AI diagnosed images were later confirmed by a retina surgeon, like
yes,
at
that's
your
what we have
clinic?
done. Yes.
Okay, and what was the positivity comparison? What was the delta?
So the referable diabetic retinopathy was 100% matching, but with the media not clear, and then even then the referable was 100%, but non-referable where the other things were there was about 13% having a false positive if the media was not clear, and the other thing like if you mixed with, as Dr. Karandikar asked a question about mixed with the hypertension. That is the reason that when the place is done without an eye doctor, later it is compared by the eye doctor and the patient is called back.
So there is a follow-up for every patient who is positive. There is a follow-up indicated.
Yes.
Yes, definitely.
Yes.
It's
Great work, Natu. Great work. Now, one more observation. Since you are doing this with the MCGM, and since they have such a large spread of diabetic clinics, would it be possible to evaluate more than one fundus camera in terms of image quality and diagnostic accuracy?
No, what is the last part of the question, Ranjit? The last part of the question.
You already have an existing base of say 100 or 56 clinics or whatever.
Yes.
You have so many clinics available with you. You have the patients available to you. You have zoomed in on one particular camera.
Yes.
Model XYZ.
Right.
Could the study be extended? Could the study be extended to take model Y, model Z, model P, model Q, and then compare the data to say, okay, model X gives me the best or Y gives me the best or something like that. As part of a continuing study, I'm taking it further from where you left off.
Yes. So actually, we have a mobile van with the Zeiss camera. It can be done, and it was done in the clinic in the hospital-based study, but not in the municipal corporation. We can do that. And now the municipal corporation also wants us to take the van. So this can be as an extension study using a regular standard fundus Zeiss camera, which is about whatever the price. So we can definitely compare.
No. I'm talking about Indian-made fundus cameras.
Right.
You have one model X.
Correct.
Dr. Karandikar manufactures model Y. Karobi manufactures model Z. Okay. So with Zeiss as a standard, presumptive standard, can we not grade our Indian cameras also?
I think we also have a forest which we are using it.
Yeah, I was not mentioning names.
Yes.
I was purposely not mentioning names, but the point here is that since the study is already ongoing and you already have this database available to you, why not do a comparative? That was the suggestion.
Sure, I think it's a very good idea. Definitely, because there is no financial involvement. Absolutely, we'll do it. Because we have the donors who are giving the money for buying.
You have no dearth of donors. I know. Thank you. Thank you, Nati. Thank you. Karobi, any questions? Sorry.
Nati, one observation. I was wondering why you were not talking about, because you mentioned Zeiss, and I knew for a fact that you also have a forest in this detection things. But coming to artificial intelligence, we normally find there are a lot of lacunae in this artificial intelligence as of now. I mean, there are times when you are like confronted with statements like, I do not know this, when it is a simple, clear-cut, sort of scenario. But what I would like to ask you is that of the patients who had hazy media or cataract, or where maybe mild vitreous hemorrhage, where the fundus camera could not pick up in these rural setups? How did you manage these group of patients, and like what was the kind of feedback that you get from your paramedical personnel who are examining these patients in these setups?
So it is actually monitored by the medical officer before itself who are going to be screened, and whoever we cannot conclude, those patients are brought to the either they're, for example, if it is somewhere near Nair Hospital, they are taken to Nair Hospital. If they are near Sion, they are taken to Sion Hospital. And if they are near our clinic in Worli, in this one, they are taken there. So the social workers follow the patient and make sure that if they have vitreous hemorrhage, they come, and then if they are ready to get operated in KEM or Nair, they are going, or if they want to come to our charitable part, they come there. So we make sure that the patients are continuously followed up, because we do door-to-door screening also, apart from the what we are doing. What this I presented is only the municipal clinics.
So you mean to say that there is a ophthalmologist who accompanies these people?
No ophthalmologist. So these people will find out, for example, they can't get an answer from the mobile phone after they're detecting. Those patients are separately called and they are taken to the clinic to check why we are not able to find what's the problem.
Okay. So all in all, we can say that AI as of now cannot replace the human being.
Yes, definitely not. And that is the reason we are still using the images in the center by the ophthalmology, not the same day, maybe the next day. And then we call back the patient if something has been missed by the AI.
Okay.
So one day, I think if the AI works, we want this to work in the villages without the eye doctor.
In the villages, it would be much more difficult because you would not probably have centers close by to certain districts where you could take them for an evaluation and find out about that group of patients who cannot be detected with the cameras.
No, the idea is in villages still they are not diagnosed at all. The IDF has declared 58% of the 77 million are not diagnosed with diabetes itself. So that is the reason we are the only we are doing the PP sugar as well as the HbA1c now, and along with this Ornate India study from UK. And now we are doing only in Mumbai, but villages we are not still started, except in Palghar we have an MOU with the government of Maharashtra. But again, there is a Palghar hospital there, and then there's also a trust hospital there. I think Dr. Mania.
Nati, we have 11 minutes and 4 people to go. Okay. My apologies, but can we go back to Akriti Sharma here?
Good afternoon,
hello.
Everyone.
Akriti, you're on.
Yes, sir. Can you see my screen, sir?
Yeah. Yes.
Good afternoon, everyone. The topic I'm discussing today is analysis of the awareness of retinopathy of prematurity amongst parents of neonates admitted in NICU. Now, a brief introduction on what is ROP. Retinopathy of prematurity is a retinal vascular developmental disorder characterized by development of abnormal vessels of the retina in premature infants and mainly affects premature babies born at or before 34 weeks and weighing 2000 grams or less at birth. Several risk factors have been found to be associated with the development of ROP, and the incidence reported is 22 to 52%. Examination should be performed by an ophthalmologist skilled in the identification of the ROP, and first examination is done at 4 weeks of birth, and it ends with a period of gestation less than 28 weeks or less. Should be screened at 2 to 3 weeks after delivery. Now, risk factors of ROP include prematurity, low birth weight, high exposure to oxygen for prolonged period, apnea, sepsis, anemia, cardiac defects, multiple blood transfusion, and respiratory distress syndrome. The aim of our study is to analyze the awareness of retinopathy of prematurity amongst parents of neonates admitted in NICU, Western Maharashtra, India. The objectives is to analyze the adequacy of existing ROP screening strategies to analyze the awareness about ROP in parents of babies admitted in NICU. Now, stages of ROP. Stage 1 shows a demarcation line. The stage 2 shows a ridge. Stage 3 shows extraretinal fibrovascular proliferation. Stage 4 shows partial retinal detachment, and stage 5 shows total retinal detachment. A bit in brief about the pre-plus disease. Pre-plus disease indicates posterior pole tortuosity and dilatation that are not sufficiently abnormal to reach the criteria of plus disease. Now, plus disease consists of increased venous dilatation and arteriolar tortuosity of the posterior retinal vessels. Now, AP-ROP is an uncommon, rapidly progressive and severe form of ROP. And if untreated, it usually progresses to stage 5 ROP. Now, complications of ROP include myopia in about 80% of infants, strabismus and amblyopia, retinal detachment in 22% of the patients, and acute angle closure glaucoma. Now, the process of screening in brief. Baby receives the feed an hour before the screening. Pupils are dilated 30 minutes before the examination. Baby is swaddled and arms restrained to minimize general movements. Topical anesthesia is instilled in conjunctival sac, and lid speculum inserted beneath lid margins and examination performed. Photos showing ROP screening. Now, materials and methods. A questionnaire was given to 96 parents of newborns admitted in NICU at tertiary care hospital and was collected in person between 1st May 2021 and 30th October 2021. The questions asked were if they know why their baby should undergo an eye examination, if they knew about the disease called retinopathy of prematurity, if they know why premature babies should undergo a dilated retina evaluation by an eye doctor. Number 4, did their pediatrician or neonatologist advise an eye examination for their baby? And number 5, was ROP screening of their baby done? Now, results and observations. Patients aware versus patients referred by a neonatologist. Basically, 95% of the patients which were screened by us were referred by a neonatologist, and only 5% were aware of the disease. And neonates delivered by C-section versus a normal delivery, almost the same amount, but around 65 patients were delivered by C-section. Now, gender distribution of neonates was almost similar. There were 46 males and 50 females. The NICU stay of more than 4 weeks and less than 4 weeks, mostly more than 4 weeks, was 55 patients out of the 96 patients, and 41 patients were less than 4 weeks of NICU stay. Now, the distribution of score. This includes our questionnaire and a score of 2 on 5, which basically they knew only did your pediatrician or neonatologist advise an eye examination for your baby was one of the scores which was maximum answered by the patients, along with do you know if they should undergo an eye examination, which was 2 on 5, which was seen in 62 patients, and 1 on 5 score was seen in 28 patients, and 3 on 5 was seen by 5 patients, and 4 on 5 by only 1 parent, and 5 on 5 was seen by none of the parents. Now, discussion. Out of 96 babies, 50 were females and 46 were males, and all the patients were low birth weight, admitted in NICU. Mostly the patients were admitted for more than 4 weeks and more than 4 days, and oxygen supplementation of more than 72 hours. And they were screened by us and follow up every 2 weeks or weekly follow up depending on the stage of ROP. Out of this, 97% patients received screening during hospital stay, which was guided by the pediatricians, and approximately 3% patients were not guided for a screening, and only 5% of the patients knew about retinopathy of prematurity. Now, the importance of the study is to educate the parents regarding ROP and its long-term effects, and to diagnose ROP at an initial stage, thus preventing blindness, and to identify neonates who need urgent treatment, and to promote a communication between neonatologists and ophthalmologists, and to form combined units between the same and the treatment of severe ROP. If it's diagnosed early, it's treated early. Limitations of the study is it has a small sample size, and the study is done over a small period of time. These are my references. Thank you.
Akruti, matching with your title.
Yes, sir.
It is about the patient's awareness. I mean the parents' awareness, isn't it?
Yes, sir. Yes, sir.
You devoted lot of time on other aspects than this particular aspect.
Okay.
You should have gone and analyzed the questionnaire, whatever the parents know about the stages, what harm can be done, and things like that, much more matching with your title of the paper. Because more than half of the time was given to the ROP only. Anyway, it was a good presentation. Any question from other judges, please?
No, there is a total mismatch here between the title and the presentation and the talk. And as Karandikar sir said, you're looking at the awareness of parents.
Yes, sir.
You're telling me about the grades of ROP. We are looking at how many parents are aware. That is what we want to know. What have you done to make them aware? What kind of a paper have you given to the neonatologist
Yes, sir.
that these will be your counseling notes? You will counsel the patient, or the obstetrician will counsel the patient. Those kind of notes that you prepare and give to these people about ROP, that is what the paper should have been about.
Yes, sir.
Karobi.
Yes, sir. Sir, we had defined 1 day in a week where we would go to the NICU, educate the parents and also the ancillary staff along with the pediatricians regarding the same. And even while asking the questionnaires, I tried educating the parents regarding the disease.
Ekha divshi awareness yet nahi. It has to be a sustained effort.
Yes, yes.
One day awareness can't be created. It's only a visit. It's not an awareness.
Yes,
In fact, we were waiting for a long time की आता तुझा कुठे सुरू होतोय म्हणजे you were elaborating about mainly the ROP most of the time. And finally, when you discuss the main topic, it was very curtailed, like to a great extent.
Can I say something?
As everybody is saying,
Can I say
yes,
something? See, the thing is that what Dr. Karandikar and Dr. Maniyar said is very true, because same here, I was waiting for the slides when you actually discussed how many parents knew what had been done for their information by you or by the NICU, and how educated they were, what were the kind of methodologies which were used to forward this information, whether you had done it as posters or whether you had done it as CMEs, or whether you had gone to the villages or certain areas and talked to patients about it, because we need those answers. Another correction which I wanted to draw your attention to, that the current classification classifies APROP as AROP. That is a recent classification, so you have to correct that in your slides. And the thing is that the slide which told us about the awareness of 5% and all was just one slide, so it really did not justify whatever you had started out as an initial thing. The concept is good, the concept is very necessary. What I would request you to do is that work on it, because this is something which requires working on, and awareness has to spread in this way.
Yes.
Thank you.
Thank you.
मनातलं पुश करतोय सगळ्यांना सर करतोय मॉडरेट पण तुम्ही जर एक 5 मिनिट
So can I start my presentation?
Now, because there is a request came from.
You'll have to mute.
Yes, sir. Yes, Swapnesh Sawant, start with your paper.
Yes. Okay. Good afternoon, all my dear judges. And the topic for today is PDR management, the use of modern new surgical techniques with old gold standard principles. So the challenges that we faced in the modern era, in spite of a good vitreoretinal equipment, are the complex vitreoretinal interfaces, ischemic processes, and we still struggle to control the hemostasis. However, the preoperative assessment of all these cases, especially the slit lamp examination, the fundus examination, as well as a good ultrasound by the operating surgeon himself, holds a key to get the success in these cases. So this is a video presentation where the modern 23 gauge, 25 gauge, as well as the 27 gauge trocar cannula system have reduced the incidence of iatrogenic bleeds as well as iatrogenic retinal tears near the incision sites a lot. It's made the visualization system which we have, the biomes as well as the resites, have made the surgery more clearer. As you can see, the principles remain the same, that we clear the vitreous near the incision area, go to the core and clear the bleed as we move forward. Induction of the PVD is the cornerstone for these surgeries, and to find the correct plane in the subhyaloid space is also very important. Otherwise, there is always a chance that there is vitreoskisis. With the modern cutters, the mouth of the cutter is now moved more and more towards the end, which helps us to make use of the cutter just like a scissor and also a lifting instrument. And the modern methods of lift and cut, as seen, really helped in dissecting these tough fibrovascular proliferations. The curved endolaser probes help to ablate the area, and the principle that ablation, the laser photocoagulation, is still very, very important for the stabilization of the retinopathy holds true. Another case, the most important principle for any vitrectomy before we start is to ensure that the infusion cannula is inside, especially in these cases where the visualization can be difficult because of the heme which is abutting the anterior hyaloid phase. As you can see here, this patient already has some amount of laser done, but in spite of that, there is bleed inside, and induction of PVD is again very, very important. We can use forceps, we can use controlled suction with the modern vitrectomy machines to induce this PVD. And once we are sure that the entire layer is getting lifted, then we can proceed forward with the remaining cutting of the vitreous gel. Also, these gaps which are seen in between the laser marks, as a principle, they have to be filled in, because if we leave them behind, there are always a chances of rebleed. Ensuring that the vitreous is lifted in each and every quadrant is also very important. Though we have faster machines, still these old principles remain good. Not to be heroic and try and tease out a tough blood clot near the fovea is also a gold standard principle. At the same time, we have very good backflush functions and very good suction mechanisms in our cutter, but we should use it very wisely. So you can see the fill-in endolaser being done. This particular case was like a tabletop PHF. Again, a principle that we can stain the vitreous with the IVTA. It will help us in also stabilizing the underlying macular edema. We can use the cutter as well as the forceps to induce the PVD, but I am finding tough in this particular situation. Sorry. So I'm using a 24 gauge needle to open the posterior hyaloid, and then again going back to the modern instrument of cutting to dissect out in this plane. We have to be ambidextrous because the FVPs can be on the nasal as well as on the temporal side. And with the IOP control of the modern machines, the desegmentation and the delamination is pretty good without having a lot of hemorrhage, and that hemorrhage then obscuring the view. We can immediately control with a click of a foot switch that the bleeder is stopped, and then we can take care with the diathermy that particular area. Again, I'm using a forceps, going step by step, chunk by chunk, quadrant by quadrant, and lifting up the membranes. So for the dearth of time, I'll move forward and show you at the end with a C3 effect, and this is the end result of this surgery. So hemostasis can be achieved with the modern instrumentation as seen in the videos. the role of the anti-VEGF agent should be, it is definitely useful to reduce the surgical time and the intra-op bleed, but has a questionable role in post-operative rebleeds and a questionable role in worsening the ischemia. I use usually 3 to 4 days before these surgeries, depending upon how vascular the FVP is. Thank you very much.
Swapnesh,
Yes, sir.
this is a talk on use of a modern equipment based on the same principles. Where is the study?
Sir,
this is the presentation, this is the paper reading which we are having a competition of, not a talk on the use of modern equipments, how that they are helpful and other things.
Sir, I had submitted the paper and it was accepted, and the means I myself had that query. So few case reports were also selected, and this was considered as a small group of 3 cases.
Anyway, Karobi, sir, Maniyar sir, Mukadam sir.
Did you
Any
use
question?
chandelier for any of your cases?
Madam, bimanual dissection was not required in these particular cases, but in a case of CRD, I definitely switched to chandelier, where dissection is more difficult and bimanual dissection and handling of those membranes is important.
Okay, there is a little constraint of time, so we'll limit our questions. Dr. Maniyar, what about you?
Karobi is saying don't ask questions, so Swapnesh, I'm not going to ask questions.
Okay, we move on now to Dr. Vinky Babu. His presentation is on case series of conjunctival lymphoma.
Wow.
Yes, yes.
Am I audible, sir?
Yes, you are.
Yes.
Good evening, everyone. Today, I'm going to present a case series on the topic conjunctival lymphoma. I have no financial interest in this presentation. Sir, it's not working. That is, I am not able to
advance your
forward the slide.
Just close and open it again.
Can I restart it again, ma'am?
Yes. Can you reset the timer for her, please? Numerotech timer. Can you reset the timer again? Reset the timer.
Is it moving?
Advance?
I think.
Yeah.
Yes.
There is a lag and it's hanging.
Okay, can we go to the next presentation earlier then? Sumit?
You can advance it.
Yes, sir, definitely.
She will have a chance after this.
You can, technical team, you can stop her presentation, and next in the line can share the presentation. Already we are running.
Okay. Now the next presenter is Seema Manik. Seema, yes, please. Yeah. Yes, you can.
Can you
start.
hear me?
Yeah.
Yes.
Yeah. Can I start now?
Yes. By all means.
Yeah. So thank you for giving me chance to present my work about cryopreserved donor corneas for first time in India for PPK, that is therapeutic penetrating keratoplasty, during COVID-19 pandemic. So during pandemic, there were strict lockdown restrictions. We could not do any eye retrieval. Large perforated corneas, how to deal with them? Many patient has lost eyes. Even my one patient has lost eye because of unavailability of cornea. So next, what can be done for large perforation? You cannot manage with cyanoacrylate glue, multilayered AMT or scleral patch graft. You need a cornea, where I came across the option of Cryopreserved cornea. So mine is a case series, 9 patient, 9 eyes, 10 graft as 1 patient required, repeat TPK, 8 patients were of fungal corneal infiltrate, 1 patient neglected severe peripheral ulcerative keratitis. This cryopreservation technique is done only in EBCRC, Mumbai in India. It is unused corneas on completion of expiry period are transferred to the sterile empty vial under the lamellar flow hood. They are stored at -80 temperature, special preserve for the cryopreservation. It allowed indefinite preservation. For us, travel time was more, 24 to 36 hours due to strict lockdown restrictions. So this is a cryopreserved cornea, intraoperative. It has a more DM folds, more stromal more epithelial defect compared to usual therapeutic graft. How to use this graft? You have to remove it from the and keep it at room temperature. After about 10-15 minutes, you can use this. The usual therapeutic PK protocols were followed during TPK. Large graft were used in 5 eyes. 1 mm oversizing was done to form deep anterior chamber. 4 eyes graft size range till 9.5. This is one of the 8 mm graft. You can see little bit clarity in this graft. And all the donor corneal rim were sent for bacterial and fungal culture, as we don't know how sterile they are, because this is one of the new techniques. And routine post-operative management was done in these patients. So regarding my case series, persistent epithelial defect were observed as large grafts were there. Over 1 month, it healed in 5 eyes. In 2 eyes, 2 to 3 months, it took place, and recurrence of infection was there in 4 out of 9 eyes. 1 eye required repeat TPK, 3 eyes responded well to the treatment. Large fulminant fungal ulcer to start with were the reason for recurrence. Luckily, none of the eyes went into the endophthalmitis. So this is one of the persistent epithelial defect patient, 1 month post-op. I advise him for AMT, but patient, because of the financial constraint, 3 month post-op, there is total conjunctivalization of the graft. This is the repeat TPK patient. This is 1 day post-op of the first TPK. This is 1 month post-op of the first TPK. Later, glue BCL was done, but unfortunately, patient went into the prethysis. So out of these 9 eyes, this one with the severe PUK patient and this repeat TPK, we could achieve the anatomical integrity in the rest of the eyes. These are the 4 patients with the recurrences. Only 1 graft grows the Aspergillus fumigatus. Otherwise, there were no growth in other donor corneal rims. So cryopreservation is something not new. It is an age-old method. The technique used by EBCRC was Mosgan et al. There are different techniques also. It has proved the viability of endothelial cell can be preserved, but it can be acceptable only for therapeutic, not the optical purpose. First time clinical use was done by Neil P. et al. Like us, therapeutic PKP was used by YF Yao et al. And in them, among 45 eyes, 39 eyes, they could successfully eradicate the fungal infection without recurrence and anatomical integrity maintained. But to mention here, their infection were small, not like us, total or subtotal corneal infiltrate. And the duration of cryopreservation, that is the day from cryopreservation is done to till the day we have used. So in our, it was more than a year after we have used that cryopreservation. It has also been used for DAL by the people. So in short about our case report, 10 cryopreserved cornea were used, successful eradication in the 4 eyes in first attempt, other 3 were managed successfully, 1 eye required repeat TPK, anatomical integrity was maintained in 7 eyes, and we did face some major issues because of COVID-19 strict lockdown period. So conclusion of my whole work is that at least we could save the anatomical integrity of 7 patients, in when later on we can use a better corneal tissue. And the COVID-19 pandemic has opened the door for these cryopreserved cornea, where you don't have access to other usual tissues. You can consider these cornea as one of the option available. Don't let the patient eye go into the vein. And thank you for your patient listening. A special thanks to Kuresh Maskati sir and Nishita Agrawal ma'am, who guided us about the use of cryopreserved corneas.
Good, very good. So the pandemic gave you a chance, isn't it?
Yes, sir.
to use it for therapeutic purposes. I think it's a good presentation. Can you tell me something about the endothelial loss because of a cryopreservation? Does it differ if it is with dextran or other things?
Yes, sir. They have actually used the dextran and other things in other techniques, but none of the technique has properly mentioned about endothelial cell count. One or two patients, two studies were there, but the endothelial counts were like something 1,000 or something like that only, not more than that.
Okay.
The viability cannot be, nobody has particularly mentioned the viability of the endothelial
No,
cell.
no, no, no. What sir was asking is, did you do a viability study? That was the question.
But actually, I use cornea for TPK. So for me, once I use that graft, I could not have the access, and because of the edema, the specular microscopy could not be done post-op in these patients.
Quick question for you is this. Actually, what is the duration of a cryopreserved cornea? If I'm not mistaken, it is 90 days.
No, sir. Means, ma'am, once cryopreservation is done, that cornea can be used for indefinite period, which I have used corneas. Like they were from the date on June 2018, they have preserved the cornea, which that cornea also I have used. So it's like a 1 year, 2 year also old cornea. Means once you preserve that cornea, it stays into that form and it can be used for therapeutic purpose.
Okay.
That's why means it is written that it allows the indefinite preservation. There is no time limit for that preservation.
Thank you. Thank you. Thank you.
Thank you,
Shall
ma'am.
we go ahead to
Pinky?
Lymphoma case.
Yes.
Vinci, come on, start presenting.
Yes, ma'am. Good evening, everyone. Today, I'm going to present a case series on the topic conjunctival lymphoma.
Oh. Yeah.
I have no financial interest in this case presentation. As you all know, redness of eye is a common presentation for various ophthalmological conditions, but it can also represent certain uncommon serious conditions. Here, I'm presenting 3 cases of red eye with uncommon diagnosis. First case scenario. 59-year-old male patient presented to our OPD with complaints of redness, protrusion of eye, and diminution of vision in left eye since 6 months. He has been treated as a case of scleritis with a topical steroids for the past 1 month, but he didn't improve. On examination, his vision in left eye was PL positive, with conjunctiva showing chemosis as well as congestion, and there was proptosis in left eye as compared to the right eye, and rest anterior segment examination was normal. And his fundoscopy revealed a Klaus-Mennel RD. We did a CT brain plus orbit in view of proptosis for this patient, which showed a hyperechoic mass over the left conjunctiva, which was pointing towards the diagnosis of lymphoma. For confirming the diagnosis of lymphoma, we did a conjunctival biopsy for this patient, which confirmed marginal zone lymphoma. To rule out any other systemic cause of lymphoma, we performed both bone marrow biopsy as well as CSF analysis for this patient. Both came to be normal. As lymphoma is a malignant condition, we performed a PET scan also to rule out any other malignant foci, which was also normal for this patient, and he has been treated with external beam radiotherapy. Second case scenario was a patient, a 59-year-old male patient, came to our OPD with complaints of redness as well as blurring of vision in left eye since 1 month. He has been treated with both topical steroids and NSAIDs in view of episcleritis, but this patient also didn't get improved. On examination, his vision in left eye was 618, with conjunctiva showing minimal chemosis with congestion. There was a salmon patch appearance. Whereas anterior as well as posterior segment examination was completely normal. Like before, we did a CT brain plus orbit for this patient, which was pointing towards the diagnosis of lymphoma. For confirming, we did a conjunctival biopsy, which was suggestive of follicular lymphoma. And to rule out any other systemic lymphomas, we did both bone marrow biopsy as well as CSF analysis. CSF analysis of this patient was normal, but bone marrow biopsy was suggestive of lymphoma. And in this patient, the PET scan showed weakly metabolic right level 6 cervical lymph nodes. He has been treated with 6 cycles of chemotherapy, that is intravenous CVP regimen, along with external beam radiotherapy. And the third case scenario was a 63-year-old male patient presented with complaints of redness, painless progressive mass, and protrusion of left eye since 1 month. He was diagnosed as nodular scleritis and was given topical steroids. This patient was also not improved. On examination, he also had proptosis with a vision of 6/18, and there was a mass over the bulbar conjunctiva. The rest anterior as well as posterior segment examination was normal. And here also we performed a CT, which was pointing towards lymphoma, and congenital biopsy was performed, which confirmed the diagnosis of marginal zone lymphoma. And bone marrow biopsy of this patient showed features of lymphoma with minimal involvement, but CSF analysis also showed abnormal lymphocytes. PET scan was performed, which showed metabolically active lesion in the left orbit and right lumbar region with mesenteric lymph nodes, neoplastic. And he has been treated with IV chemotherapy, that is top regimen was given, cyclophosphamide, doxorubicin, vincristine plus prednisolone along with external beam radiotherapy. All the 3 patients was followed up after 6 months. They have a good prognosis without any recurrence. And coming to the discussion part, lymphoma is a malignant lymphoproliferative tumor. 5 to 15% of all the lymphoma occurs in ocular adnexal region. And among the ocular adnexal region, conjunctiva is the most common site. And congenital lymphoma can be further classified into low-grade as well as high-grade lymphoma. Low-grade lymphoma includes extranodal marginal zone lymphoma as well as follicular lymphoma. And high-grade lymphoma includes diffuse large B-cell lymphoma as well as mantle cell lymphoma. I am showing a study presented by Shield et al. On the epidemiology of histological subtype of conjunctival lymphoma. In his study, that's the mean age of presentation of conjunctival lymphoma was around 60 to 70 years, and most of the cases was found to be low-grade conjunctival lymphoma. And among the low-grade conjunctival lymphoma, extranodal marginal zone lymphoma was the most common type. In my case series also, all the 3 patients, the mean age of presentation was 60 years, and all the 3 conjunctival biopsy showed a low-grade conjunctival lymphoma, and out of the 3, 2 patients were having extranodal marginal zone lymphoma. And coming to the conclusion, clinical features of conjunctival lymphomas are non-specific, so it is crucial to obtain biopsies and further immunohistochemistry. Treatment of conjunctival lymphoma is determined by the stage as well as extent of the disease. These are my references. Thank you.
Thank you. One thing, what is the message you want to give? For primarily, you will carry out those advanced investigation before biopsy, or primarily you will do biopsy, and if you find something, then you will subject the patients for rest of the investigations?
There is most of the time the patient present with there is presentation is different, like a conjunctivitis and all, so there will be lag for the diagnosis, no, sir. So after a CT only we will confirm it with conjunctival lymphoma.
See, there are so many patients which will come with the Salmon patch appearance and little bit of growth here and there. You cannot subject all those patients for those advanced investigations.
We can do a peripheral smear.
Pardon?
We can do a peripheral smear before performing biopsy.
That is all right. So you will be doing simpler investigations primarily, you know,
Yes,
and
sir.
then only you will subject the patients for further investigations, not the other way around.
Yes, sir.
Sir, Maniyar sir.
Karandikar sir.
Yes,
Yes,
sir.
Mukadam sir, please go ahead.
I think there is a point she has suggested that you have to think about a lymphoma in such cases which are not responding to standard treatment. The presentation looks like episcleritis or scleritis. They are not responding to the treatment. So maybe this is a good pointer that we should think of this diagnosis.
You build up your index of suspicion.
Yes.
And what Karandikar sir said, beta, is that you give an algorithm on how to proceed once you are suspicious enough. Once you are suspicious of lymphoma, you should have a clinical algorithm how to proceed. That is what sir was referring to. Am I right, sir?
Yeah, absolutely right.
Very nice presentation. Your 3 cases were very nicely documented and presented. So I just congratulate you on that. I won't have any questions for you.
Okay. I think Sumit.
Yes, sir, Sumit, do you have a question here?
Yeah, please.
Do you have a question here?
Yeah.
Karen Shields was
just
mentioned.
have a request and the thank you note.
No, Sumit, let there be last question from Maniyar sir. Yes, sir. Please go ahead.
No question.
No. Okay. Thank you all the participants. Thank you all the judges who were with me. With this, we end this particular session and hand over the mic to Sumit for further proceedings.
Acha, how do we submit the reports? How do we submit
Sir,
them?
either mail me or WhatsApp me the picture. That will be enough. I will compile the marks and let you know.
Okay. Karobi, don't show it. Karobi, don't show it.
No marks. No marks.
No.
This is
Okay,
the sheet
okay.
you write and mail it to him.
Yeah.
Okay.
So thank you everyone. Thank you,
Thank you.
Karubi ma'am,
Thank you. Bye.
Karanjika sir,
Bye.
Maniya sir, Mukadam sir
Thank
for
you.
your time.
Thank you very
Thank you all
much.
the participants.
Thank you,
And we
Sumit.
hand over the session with apologies
just
to Marathe sir,
so-
Viral Shah sir and Deshpande sir. We are really sorry for being late.
We are
But
not.
since there
We
was
had a
lot of
lovely session. We are
presentation,
not
yeah.
sorry. We are not sorry. Deshpande
Sir,
sir,
I
we are
am
not
so-
sorry.
Okay. It's all right. We had a
We
chance
hand
to
over
hear
to
you at
Marathe
least,
sir.
sir.
Yes,
That is a good thing.
yes.
What is the
Good thing.
what is the deadline for spending? What is the deadline for sending marks?
Pardon?
Sir, today any time.
Today, well, 12 midnight today. 12 midnight.
Okay.
Will do, sir. Thank you, sir.
We'll send it to you in the next half an hour.
Viral, Prakash.
Good evening,
Namaskar.
sir.
Thank you, sir. Thank you so much, sir.
Bye-bye,
Deshpande sir.
Maniar sir.
Sir,
Namaskar.
Mukadam sir, Mania
Namaskar.
sir, Karobi madam. Good evening.
Everybody.
Okay. Marathe, Viral. Okay, bye.
Okay,
Bye.
sir.
Bye.
In the session. Okay. We
Bye.
are leaving. I'm leaving. Okay.
Good evening, all of you. I think it is a wonderful session. Everybody enjoyed it. The next session is now about medical legal symposium. I think most of us are clinicians and handling our patients, doing the surgeries. But then this medical legal aspect cannot be neglected. Nowadays, there are many more problems the practitioners are facing. And we have to deal with medical legal aspects. And our stalwart, Dr. A. Deshpande, who is the chairman, co-chairman, Dr. Viral, myself as moderator, then Dr. Kuresh Maskati, Dr. Anil Kulkarni, they will be there. And let us start the session.
So I welcome all and I request Dr. Marathe to start because he has to travel after this for a hybrid session. So I request him to start the session.
Thank you, sir. Thank you.
Yes, you can share the screen.
Yes, sir. I am trying to share.
And after that, you can continue the talk of the Kuresh also because he is not going to be there.
Yes.
He has passed the slides to you, I think.
Yes,
Kulkarni sir has not joined. Deshpande.
Kulkarni sir has not communicated anyway.
I think he is also the part.
Yeah, he is also a part. Can you ring to him or I should ring?
Yes,
I will ring. You continue, I will ring.
Yes, sir.
Mute. Sir, Deshpande sir, mute yourself.
Yeah.
Share नहीं होता है सर?
नहीं, yes,
Do
I'm
not take
trying.
for-
Just a
Yeah.
minute. Can you see?
No, sir.
Not yet. Okay. Just see now.
No, sir.
No, just now.
Yes,
I have to give you some.
Yes,
yeah, now it's okay.
So, good afternoon, everybody. Is it seen now? Properly seen?
Yes,
Am
sir.
I audible? Yes.
Perfect.
Okay. Thank you so much. The topic allotted to me is importance of consents in local language. I think this is very important topic because most of us have been talking about consents at various conferences, seminars, and symposium. But consent in local language, that is the topic allotted to me. Why this topic is important? Because most of the consents are in English. They are available everywhere worldwide, even all India level and local level. We were using ready-made English consents. And there were some aspects to be dealt with those English consents because it was not in local languages, as most of the Indians, means at various state levels, they have got their own like a local language. And when you ask the patients to sign on that particular consent form, which is there in English, I think probably they never understand the matter which is there. And hence there is a need of consents in local language. all patients, the relatives may not understand English consents. That is a very important criteria. So medical legal point of view, afterwards they may say that, okay, they had taken the sign. They just blindly took my sign, but they never explained. Hospital and doctors, they never explained. And that is the problem with medical profession. So real meaning of important clauses in the consent form. Most of the clauses, they are written in English format. But when they are written in local language, probably patients and their relatives, they are able to understand exactly what is written in the consent form. Recently, All India Ophthalmological Society, along with DOS, that is Delhi Ophthalmological Society, thought that there should be some compiled format of informed consent. And they came out with the book, AIOS and DOS. The same way, All India Ophthalmological Society last year informed various states, AIOS representatives like us as managing committee members, to take initiative to form local language consents. And at Maharashtra level, I am very happy to share here that we came out with the Marathi booklet in very much successful format. Our team of all important people, those helped me a lot as coordinator of this particular project. And this booklet was the success of that particular mission. So it is available in our MOS website. You can go to website and you can share those consents. You can take printouts of those consents also. So for Marathi people, you have to use Marathi consents because it is their local language. In that particular consent of Marathi, important sentence is always written. हे संमती पत्र मी वाचले आहे, मला ते समजावून सांगण्यात आलेले आहे. या विशिष्ट अशा ऑपरेशनच्या प्रोसिजर मध्ये असणारे धोकेही मला सांगण्यात आलेले आहेत आणि हे संमती पत्र मला समजलेले आहे. या उपर माझी कुठलीही शंका नाही आणि मी समजून उमजून याच्यावर सही करत आहे. This is the nomenclature which is written in that Marathi consent, so that afterwards patients cannot say that they haven't understood. And at the end, it is again written that they have no queries about this consent. So coming to the proper consent part, most of us have talked about consent even in the past. Essentials of a valid consent. Consent should be person specific, procedure specific, consumer, then without undue influence or persuasion, misrepresentation, fraud, or mistake of fact or law. So it is again coming under Indian Penal Code. So consent, valid consent, competent person has to do this. For major, you can take direct signature, and for the minor, you can have the guardian signature. There is the gray area about child ranging from 7 years of age to 12 years of age. 2 witnesses are to be taken in that particular consent. It has to be simple. Here it is written any language, but the language which is related to the patient. It can be specific language, then clear, unambiguous. There shouldn't be any complicated language in that. Mention common complications and alternatives. This is very important. Which top planes you are putting? What are the alternatives? What are the likely complications? If you are not doing this, what's going to happen? If you are doing some other procedure, what are the advantages? So everything you must tell to your patient. And even in emergency, like evisceration and enucleation, second opinion is must. That opinion must be given by 2 ophthalmic surgeons. So don't be in hurry without taking consent. After operating evisceration and enucleation patient, that particular day, patients and relatives, most of the times, they say, yes, doctor, do this operation. After 15 days or few months, they come to you, doctor, you did the operation, but I cannot see. This is the magic question. After evisceration and enucleation, patient is not going to see. On the day of operation, probably they have signed on the consent form, but afterwards, their relatives, their friends, they tell, okay, you have done this operation, still you can't see, go to the doctor. So that misinterpretation is taken care by proper consent. So written consent or implied consent, informed consent, relevant information of illness and treatment has to be explained. Significant material risk has to be explained. Alternative modalities. Nowadays, patients are very much clever. They are themselves Google doctors. They read everything. So alternative modalities, you must tell to your patients and relatives. Unusual or special risk may not be explained. See, some risks are there, you may not explain, but the percentage of that should be less than 5%. Refusal for consent, this is very, very important. Patient is not ready to sign. Think of postponement. Don't operate on that particular day. Operate only if it is urgent. Then you try to convince the patients and relatives. But for planned surgeries, never operate if the consent is not given by the patients and relatives. Doctors should not feel shy of informing and taking written statement to that effect. Most of the times what we feel, he is my friend, then he is my relative, he will not do anything. Why should I explain to him? I already told to him, he understands everything. He is educated, he is very clever, he is very close to me, and you are not taking consent. Very bad. I know one doctor, his patient just came casually, he took him in the operation theater. It was just a small cyst and patient died on the table. The consent was not taken. After the death, doctor tried to take that thumb impression, but the patient was educated. The sign was not there on the consent form. So this is the big lacuna. So boldly document the non-compliance of any of your advice. Suppose patient is not listening to you, he is a little bit reluctant about any point. Take other patient's signature also for witness. Consent of a child after 7 years, up to 12 years of age is a must along with guardian's signature. There is no law as such as consent is a must, but MCI has given the guidance. Even medical legal point of view, yes, consent is a must. Implied consent can be constructed by the history. However, judgments from Supreme Court and National Consumer Forum stress the need for the consent. And I think, in short, I have finished my talk. Hopefully, it was beneficial for all the delegates. And if there are any questions by the stalwarts, you can ask to me. I'll stop share now. Hello, sir. Unmute yourself. Deshpande, sir. Unmute kara.
Should we go for question answer just now, or we will take it afterwards? Whatever.
I think we are running late, so we'll take it afterwards.
Yes, sir.
Okay.
Okay.
So you have to go there for hybrid also.
Dr. Marathe sir, yeah, Dr. Marathe sir can share the slides of Dr. Maskati sir. And
Yes, Maskati is there now.
Yes.
You can share and he can speak.
Okay.
Good afternoon and good evening to one and all. So this is an unusual thing which occurred to me, which hopefully will not occur to any of you. Patient of mine died in my nursing home. So
sir, screen share is yet to start. Marathe sir.
Okay.
Marathe sir, you are on mute. You are on mute.
Marathe sir, you start his screen sharing.
Sir, you are on mute. Marathe sir, you have to unmute yourself.
स्क्रीन शेअर करतोय जस्ट
Screen share
कारण मला माझ्या ह्याच्यातून घ्यायला लागलं.
Yes sir. Yes. Start the show. Yeah, start slideshow. Yes sir, Kuresh sir, please.
Yes.
Kuresh sir, can you see the screen?
Yes, I'm fine. Go ahead. Put it on full screen.
Yes sir.
So I want to recount my experiences when my patient died in the OT, not strictly in the OT, but just outside the OT. This is something which was the first time for me. It will be a first time for many of you all. So this presentation is based on an actual incident. Patient had multiple medical problems. He was obese with thyroid, diabetes, hypertension, heart disease, and collagen disorder. And I was telephoned from Indore by an eye surgeon from Indore saying that the patient had bilateral corneal perforations. And so he was being airlifted to Mumbai. So when he came here, I explained to the relatives that because it's a bilateral perforated cornea, I needed to put the patient under general anesthesia because I was planning bilateral amniotic membrane grafts. And there was no possibility of twice giving anesthesia, so it had to be done in the same sitting. So relatives were talked to me by me at length as Dr. Marathe says, informed consent. And the anesthetic also spent an hour talking to the relatives. And they were briefed about the very real possibility of death on the table because an obese person with so many medical specialty problems. The inevitable happened. The patient had successful surgery, came out of anesthesia. Luckily for me, he was wheeled out of the OT and he said hello to the relatives. Then he had a sudden cardiac arrest before he could be shifted to the room. So he was on a trolley being taken from the OT to the room. On the way, he said hello to the relatives. And then on that same trolley, he had a cardiac arrest. Anesthetist was standing over there. The IV line was on. So all attempts to resuscitate, including wheeling him back into the OT, just failed. We called an ambulance to shift him to the ICU. Say, I'm in a private nursing home, not in a hospital. There is an ICU with a hospital just across the road. So we called the ambulance from the ICU from the neighboring building, opposite building. But by the time the cardiologist came with the ambulance to my hospital, he was declared to came with the ambulance. Next. So what next? Now relatives were very understanding. They created no problem. They wanted the body back. Sir, please give us the body now. We understand. And we will take the body back to Indore by train and cremate him over there. I refused. I called in the police. After making sure that my OT notes and the anesthetist notes were complete in every way, I insisted on calling the police. The police took their own sweet time in coming, 75 minutes. So the police station is 10 minutes from my hospital. They took 1.5 hours almost to come. Then they asked me why I had bothered to call them, because they talked to relatives. Relatives said they don't want to make any trouble. So the cops questioned me, why are you troubling us when relatives are not troubling you? So what next? Next. So the police requested me to get a friendly family physician to certify the cause of death as heart attack and give the body to the relatives for disposal. They kept pushing me. Patient relatives are fine. You just get a friendly doctor to give cause of death. I refused that also, as I did not want legal trouble later. So the cops then requested for 5 witnesses, which we call as panchas. It's called a panchnama, to be present while they talk to the relatives. So then I summoned 5 of my staff and some outsiders. The further procedure, the cops explained to the relatives that after the panchnama, the body will go to the state government hospital, that's the JJ hospital, where a post-mortem will be conducted, which is authorized by the coroner. Only then the death certificate would be issued, that is cause of death certificate. This they would have to take to another government office, which would then issue permission certificate for the body to be taken out of the state. So it's a very lengthy procedure, the cops explained. I stood my ground. Next. So cops were taking their time. It had become 4 hours by then. Since I had a clear conscience and the relatives were cooperative, the cops were getting frustrated. They were not getting any chai pani. They took over 2 hours to record 2 pages of statements before calling a government hearse to take the body to JJ Hospital morgue. By this time, now those poor relatives were really tired. Sensing this, the morgue peons, the fellows, class 4 employees in the morgue, told them there were many other bodies in the queue and things could get delayed by hours unless they gave him speed money. So the peon was being told, the peon was telling the relatives, give them money. So relatives got conned. Though I had sent my hospital manager with the patient's relatives to the morgue, they readily agreed and gave the peon all the money they had. The PM was then finished in less than an hour and a certificate was issued. Then there was no taking to any other building, which the cops had told them. The morgue attendants themselves accompanied the body and the relatives to the railway station, completed the paperwork required, held up the train by 10 minutes, put the body in the luggage compartment and the relatives in the second-class compartment with Tatkal tickets, and for the 18-hour trip home. I didn't even know about this till the whole thing had been done and my manager came to me. So what are the lessons that I learned from this? Number 1 is stay cool. Take the relatives into total confidence before the surgery. If the patient is bad risk, tell them about it before surgery. When death occurs, don't leave the hospital under any circumstances. I did not leave that hospital 1 o'clock in the afternoon to 7 o'clock in the evening. I was at the hospital. I was with the relatives and talked to them all the time. Don't allow the relatives to be without you. You must understand basics of the law and call in the cops. Insist on this and insist on the post-mortem. Next. Read pages 13 to 14 of AIOS CME series on legal aspects of ophthalmology. It is book number 27, which has been compiled by our very own Dr. A. Deshpande, who is part of this panel. I relied on this, and this explains everything that I've told you. Doctor cannot be arrested, though it is a cognizable offense under section 304A, according to Supreme Court ruling. A death at our hands, either with consent or without consent, if the surgery or treatment is done in good faith, earns us exemption under section 88 and 92 of IPC. So don't worry, nobody is going to put you in jail if a patient dies. Do not try to bribe the cops. Do not submit to blackmail by relatives or pay them any money to hush up the matter. At most, you may not charge your surgical or nursing home charges or refund it to them if charged as a goodwill gesture, making it clear that this is not an admission of guilt. Next. In conclusion, don't wash your hands of the situation. Don't put your manager in charge. You should be there yourself. Stay in control. And you will never need to go behind bars. You will never need to spend 1 minute also over there if you do not panic. So I thank you. Next. May you never face such a situation. And I thank you. And we have legal experts like Dr. Deshpande, whom you can telephone if you are in a problem. Thank you.
Thank you, Dr. Quresh, for giving such a nice talk and giving actual experience which you felt or you had in your life, and that gives a lot of knowledge and courage to our friends. And definitely ophthalmologists will have a courage when such situation comes to them. Nice that you have given your experience. So, yes, Prakash Marathi,
Thank you, Dr. Quresh, sir. I think it was nice experience to share the slides from here. And it was the great talk by Dr. Quresh, sir, when he was driving, sitting in the car. Nice synchronization. Thank you.
So I request Viral Shah, I will keep my keynote in the last because it has started. I will request Viral Shah to continue his talk, to give his talk.
Yes, sir. So thank you so much, Dr. Deshpande, sir, for making me part of this medical legal symposium. I would also like to thank the Maharashtra Ophthalmic Society and Scientific Committee of Maharashtra Ophthalmic Society. The topic allotted to me is importance of meticulous record keeping. I would like to acknowledge the help of Professor Dr. Rajesh Joshi from Nagpur and Dr. Jay Bhopi from Pusat. So what is the importance of record keeping? Evaluation of our own result. It is important for data, for scientific paper presentations, analyze the data for publishing, and helpful if any medical litigation occurs. The legal
Sorry, Viral, I got logged out just after I finished my talk. So
yes, sir.
I'm sorry. Yeah, you carry on. Yeah, thank you.
The legal system relies mainly on documentary evidence in situation of alleged medical negligence. Poor record means poor defense. No record means no defense. So whenever you are in a trouble, the court will only see your papers, what you have written there and what you have omitted to write there. Only that will form the basis of their opinions and judgments. So there are various methods of record keeping. There is a manual method, which has its own limitation. Large storage area will be required and it is very difficult to retrieve records. Nowadays, EMR or electronic medical records are the norm, and these are the most preferred. They are neat and tidy and easily stored and retrieved. Data can be easily retrieved by EMR. Prescription is fully typed, so no error in understanding your handwriting. Previous data of patient is easily available, and just a click of a button and you get all the number of visits, previous visits also that patient had with you, and what were your findings and what was the treatment offered. Fundus photo, OCT, perimetry images, and all investigations are available in a single file and just a click away. So medical records consist of history records, clinical exam records, diagnostic tests, preoperative care records, operative notes, and post-operative care records. We will see how documenting history is important and how it can save us if a patient goes in the consumer forum. So there is a case, cataract surgery, uneventful cataract surgery, but after cataract surgery, there was non-improvement of vision. Patient approached consumer forum, but the result was in favor of doc because in the history notes itself, it was clearly mentioned that there was decrease in vision of that particular eye since the childhood. That is, amblyopia was there, and patient was explained about this beforehand only, that how much vision he may expect to achieve post-operative. So there is a handwritten note in the writing of patient itself that there is a chances of that he is suffering from amblyopia, and chances of recovery of vision not up to expectation. So documentation of clinical findings. Example 2, cataract surgery uneventful, recurrent post-op inflammation and arthritis with all possible treatment. Even with all possible treatment, I ultimately went into phthisis. Patient approached the consumer forum. Result was in surgeon's favor only because in preoperative documents it was clearly mentioned it is a complicated cataract with all the signs of healed uveitis, and cataract was operated under steroid cover under guarded prognosis. This shows documentation of clinical finding always comes to our rescue. So always write some key points in your own handwriting, in your consent forms or in your medical documents for the patient, and ask the patient or relatives to countersign those key points. Investigations, importance of documentation for investigations. Cataract surgery in a diabetic patient, approached consumer forum for non-improvement of vision. Result still came in favor of the surgeon because there was attached pre-op OCT which showed the finding significant preoperative macular edema, and patient had received anti-VEGFs with cataract surgery. This is a classical case where documenting evidence of investigation done before cataract surgery comes to the rescue of the operating surgeon. Preoperative care documentation. A patient for cataract surgery, patient had endophthalmitis early post-op period. Intravitreal antibiotics were given, referred to a VR surgeon, vitrectomy was done. The patient approached consumer forum and a case was filed for compensation for non-improvement and non-improvement of vision, all the mental and physical trauma. Surgeon still escaped unharmed because pre-op notes mentioned the following details. Fumigation and autoclaving of instrument was properly done and documented. Register was maintained. Betadine eye drops were put and mentioned in the case paper. Pre-op antibiotic drop instilled and mentioned in the case paper. Patient was referred to a VR surgeon. Date and time mentioned in the case paper. So all the documentation was perfect from the doctor's side. So the judgment came in his favor. Operative notes documentation. Cataract surgery with compromised vision. Post-op, a case was filed. Result was in favor of surgeon. So what was the point? Case paper showed it was a case of posterior polar cataract. The operative notes showed rent occurred and anterior vitrectomy was done with IOL implantation in sulcus. Pre-op notes mentioned cataract surgery advised and anterior vitrectomy may be needed. It was clearly mentioned in the consent and pre-op notes also. As we all know, PC rent is bound to occur in PPC and it happened. Good part was everything was documented. Detailed OT note made the consumer forum result on surgeon side. OPD prescription, it is a very important document. Prescription of drugs should include name of the patient, date on which the prescription was made, treatment, preferably in capital letters, duration of eye drop should be mentioned, and signature of doctor must be there. And also you should write when is the next review date expected from the patient. Date on the prescription, OPD prescription is very important, as an undated prescription can land a doc in trouble if the patient misuses it and recurrently is buying the medicine showing the old prescription if there is no date on that. Like in this example, a case of giant papillary conjunctivitis, steroid eye drops were prescribed for limited period. It was clearly mentioned for 3 weeks, 4 weeks like that. But patient used steroid drop, he used to get relief and continued buying steroid drops showing the same prescription time and again. Patient developed steroid-induced cataract. Patient sues the doctor, but doctor got clean cheat from the court because he had clearly written it for 3 weeks, drops to be used for 3 weeks and not for a longer period. OPD prescription, because his prescription clearly mentioned eye drop to be instilled for a particular period and tapered off gradually. Tip mentioned below on OPD paper, long-term tip was also there. Long-term use of steroid eye drops can cause cataract or glaucoma. Discharge summary, as we all know, it is one of the main documents which we hand over to the patient after the procedure. So discharge summary must clearly mention date of admission, date of discharge, the date of the surgery, surgical procedure which was done, treatment as advised, precautions to be taken post-operatively, and date of the next follow-up. Discharge summary should be signed by the consultant. Copy should be kept with the surgeon. Discrepancies in the discharge summary and hospital records can raise suspicions about tampering of medical records and should be avoided. Referral letter, another very important document. It should include date, time of issue, patient's condition, cause of referral, and a duplicate copy with patient signature should be kept with us. Another very important document is medical certificate. Medical certificate, always maintain a register of medical certificates issued with at least one identification mark, physical identification like a mole or a scar or whatever of the patient, and also take a patient signature on your copy. Lots of cases of patient misusing medical certificate has been seen due to lack of date, time, or backdated certificates being issued by doctors. MCI guidelines for record keeping. They are not clearly mentioned anywhere, but for consumer forum, patient can approach an outdoor OPD case within 2 years and indoor patient or a surgical patient within 3 years. You have to maintain outdoor records for 2 years. You have to maintain your indoor records for 3 years. In case a patient demands his case paper, it should be given to him within 72 hours of his request. In pediatric cases, a medical negligence case can be filed by child after acquiring the age of majority, that is after 18 years. So in all such cases of pediatric case, you have to keep the records for 3 years after the patient becomes 18 years. So till the patient achieves the age of 21 years, you have to keep all the pediatric cases records with you. And if a medical legal case occurs, so you have to preserve all your record till the case is disposed of and all the period of appeal is over. So in summary, medical records are important aspects in one's medical practice. It not only helps to improve our patient management, develop our treatment plan, improve our personality by presenting and publishing studies, but it is also very helpful if legal problem arises and one is sued in the consumer forum case court. Thank you. Thank you.
Thank you, Viral Shah, for giving such a nice, elaborate explanations about the record. Now, I will share my own slides.
So I will be introducing Deshpande sir. Dr. Arun Deshpande sir, as it is, needs no introduction. He is the past president of Maharashtra Ophthalmic Society and a key legal advisor to not only to all the doctors from Maharashtra, but all over India. And everyone, whenever they land up in trouble, always rings Dr. Deshpande sir first. So thank you so much, Deshpande sir, for creating this symposium for our members. And I request you to please start your talk, sir.
Thank you. Thank you, Viral Shah. The Supreme Court judgment on capping of the medical expenses. So there is a misnomer or a misunderstanding that such case Supreme Court has given some guidelines for capping of the medical fees and medical charges and hospital charges for private patients, private hospitals. But it is not that. It was during of the COVID period, some decisions were taken because of some particular conditions which were available that time. The High Court passed the order of petition filed by Hospital Association of Nagpur and Dr. Arora against the notifications. So this was filed at Nagpur bench of the High Court. The bench said that it cannot be issued such notification because before that, the Maharashtra government has issued one after another 2 notifications, which was showing that there can be capping of all the patient's charges. Even the private practitioners should be under that, and their charges should be capped till the COVID is there. So some Arora and challenged this notifications in the High Court bench of the Nagpur. The bench said that it cannot be issued such notification the time when the state government itself does not have necessary infrastructure to treat non-COVID patients, government hospitals. So the bench said that unless you have infrastructure where you can treat all these patients with so equal efficiency as the private practitioners or the private hospitals are treating, so you cannot ban their cap their charges until you have an alternative availment. The court held that the Epidemic Disease Act or Disease Management Act and the COVID regulation do not power the state government to issue directions in the relation to non-COVID patients being treated in private hospitals and nursing homes. So they said that for COVID patient, under these acts, one can issue the orders or you can issue the notifications. But for private patients, you have no authority to issue such things. So on October 27, 20, the Nagpur bench of the Bombay High Court had said the Maharashtra government does not have a power to frame any law or issue the notification regulating the rates, charges by private hospitals and nursing homes to non-COVID patients, and squashed and set aside 2 notifications issued by the state. So government in April and May last year to extend applicable to non-COVID patients in private hospitals and nursing homes. So in April and May, they issued some notifications and the same notifications were set aside by the High Court. At the same time, while hearing a bunch of petitions on the same issue, another Supreme Court bench led by Chief Justice of India, S.A. Bobde, he was at that time the Chief Justice of India, and he so moto, when the cases were there, he so moto done that the earlier said that it would be inappropriate for the court to impose a ceiling. We are not equipped with what could be the best model of treatment for COVID patients. So they also said that if we are not well worth for a good model for COVID patient treatment, we cannot say anything for that. So Chief Justice Bobde said there is unanimously that cost of the treatment cannot be same in all states. Thus, it is ambiguous to impose a ceiling of the cost of treatment, because you say, you can see that in Bombay, the cost of treatment is different when compared to Delhi and when compared to Pune or when compared to Aurangabad or when compared to a district place. The same treatment is available, but the cost of the treatment changes according to the city, according to metropolitan cities or the state also. And that is accepted everywhere because it depends upon so many things, other things. And so we agree that the cost of the medical treatment should not act as a determinant to access to medical care, and that no one should be turned away from doors of healthcare institution as costs are too high. So at the same time, the Supreme Court accepted that nobody should be turned out from the hospital because the cost is very high and he cannot take the treatment. This attitude was also there in the court. The Supreme Court bench, which also included Justice R.S. Reddy and M.R. Shah, they said Supreme Court ruled on Friday saying that the right to health includes affordable treatment. So right to health is not only healthy life, but it is also affordable treatment should be available to everybody. Cap on the fees charged by the private hospital, such can be in excess of powers under the Disaster Management Act. So states should take adequate arrangements in government hospitals to treat COVID-19 patients or cap charges in private hospitals. So they guided that the state should take the precautions or they should make availability of such treatment available to the COVID patients, or if it is not possible, then only you should cap the treatment of the patients in private hospital for COVID patient and not for other patient. That is also very well clear. Supreme Court rejected Maharashtra's plea against orders squashing New Delhi. The Supreme Court on Friday sought response from the center on a PIL seeking capping of treatment cost of COVID-19 patients in private hospitals in the country. So whatever Maharashtra government has given, the decision was set aside, and for the limit to the COVID patients, they say that there should be a capping, or there should be a particularly treatment cost of the treatment should be fixed for different cities according to the things available there, and the patients from the private hospital also, that should be done. A bench headed by Justice Ashok Bhushan issued notice to the center of the PIL filed by the Ashok Gorika and for fixing up upper limit of cost of COVID-19 treatment by private hospital in the country. So they limited upper cost for the treatment of the COVID patient, and it was not for non-COVID patient. So capping was done by the Supreme Court. In particular thing that highest charges can be taken, that how much should be there, and above that it should not go. But it was not for non-COVID patient in private hospitals. The bench also observed that it is not possible to lay down cost of medical care across the country by this court. So it was not possible for the court to uniformity charges of medical treatment all over the country, since the condition and available medical facilities vastly determine the cost of the treatment in each state, and this varies in every state. We are neither inclined or equipped to see how to treat COVID patients. The court said we do not think the union should regulate the price of treatment, but this is not to say that the union government should do nothing. There is no reason for the union not to exercise powers under the National Disaster Management Act 2005. The attitude of the court was that it was not that the uniform charges should be there for all over the India, but they said that the government, central government, should not see only and stand still, but they can act or do the things wherever it is necessary, and whatever is necessary with the help of the National Disaster Management Act 2005. The latest order, however, is unequivocal in stating that when the state is not well equipped to provide affordable treatment to everyone, it must ensure private hospital center care to COVID patients at fixed and inexpensive rates. It has also ordered that whenever a state government has issued order to the private hospitals for reserving a certain percentage of beds, they must comply. So these two things were governed by the Supreme Court, and they said for a COVID patient, there can be capping, but for non-COVID patient in private hospital, there was no verdict for that. Thank you very much.
Thank you so much, sir. Sir, you can stop sharing the screen, sir.
Yeah,
sir. Dr. Kulkarni, sir, is held up in the OT, so he won't be able to join. So I think, and we are already running behind the time by 10 minutes, and the speakers for next session has joined, sir.
Yeah.
So in case you have received any questions, we can take it, or we can give the.
I think there are no questions with me. So I thank you all the panelists and speakers, and I hand over the mic.
Marathe sir wants to add something.
Yeah.
No, I think it was a wonderful session.
Sir.
Very nice talks by Dr. A. Deshpande, Dr. Quresh Maskati sir, Dr. Viral.
Yes.
And definitely all the topics which were included in this particular symposium by Dr. Deshpande sir were fantastic, and those were useful for all the delegates in their day-to-day practice. That's what I feel.
We were handed over half an hour this hall, late. Now we are handing at least 10 minutes late. That
Yes,
we
sir.
have
Yes,
covered
sir.
that time.
Thank you.
Sir,
Thank you
for
very
Thank
much.
you, sir.
Thank you. We
Good
are
evening,
deeply
madam.
Thank you,
grateful.
everybody. Thank you.
We are
We are
really grateful.
And
really
Yeah.
welcome to
grateful.
the new panelists.
Yes.
Yeah,
डॉक्टर
for new
देशपांडे रुक
session.
के मेरा टॉक सुन के जाना, ऐसे मत
अरे
चलिए।
बस रुकता हूँ भाई, कहाँ जाऊंगा मैं?
मैडम हमको नहीं बोल रहे हैं।
उनका
आपको तो बोलना ही है, आपको
अनगा
तो
का
रुकना
नहीं
ही है।
सुनूंगा, इसका इसका
हाय
शर्मा का
अनगा।
नहीं सुनूंगा तो कैसा होगा मेरा?
बिल्कुल कैसे होगा?
madam, you
मैं
can start
रहना
the
मुश्किल
session.
हो जाएगा।
Gitanjali, start the session.
Yeah. Good evening, everybody. So let's start our today's session, and that is about challenges as a woman ophthalmologist. And this is mainly for the young lady ophthalmologist. We have experienced panelists today. And the first one is Dr. Sunaina Malik, madam, who needs no introduction. She is the past president of MOS, and she is my role model, and everyone knows her, a dynamic lady. So over to you, ma'am.
Thank you so much, Gitanjali. Thank you so much for those kind words. I am really, really grateful to you. I'm just starting my share screen. I don't know why it is not working. Yeah. Okay. Good afternoon, everybody. And thank you so much, Gitanjali, for giving me this wonderful topic, because as soon as you told me about it, I loved it. And I must thank Ragini and the scientific committee in particular for giving me this, because, it took me back into my past. And my childhood was very strongly influenced by my father and my grandmother, who we used to call Pabiji. She became a widow on the night of August 1947, and she came with 14 children to India from Pakistan, from Lahore. My father, who was a GP in Nagpur, was very modern in his thinking and outlook. So he brought me up just as he would a son. And because I was the first child of the eldest brother, you can imagine how pampered I was. I was really pampered to bits, as I would say. And he gave me full encouragement to do everything that I wanted to do. He said, just do it, you can. So that's where I think I got that confidence from. And he was very proud of me also, as I was always a topper right from school days. I think he's the reason for my being strong, bold, and confident, even if I say it myself. And moreover, I always wanted to be a doctor because of him, because I would see him seeing patients, and I would always play with my doctor set, put the stethoscope on my dolls and auscultate them, put the thermometer in their mouth or under their arm, and so on. So it was always being a doctor. These are the two people who have influenced me, my grandmother, my father. My journey into ophthalmology. The moment Professor Ishwar Chandra taught us acute iridocyclitis, I think I fell in love with ophthalmology, because he taught it so beautifully. And when I went back after the lecture and read up Parson, I couldn't find anything of what he had taught us in the book. It was only later, when I was doing my PG, that I realized that he was teaching us that day as undergraduates from Duke Elder. Imagine the greatness of this teacher. And this love affair with ophthalmology is continuing even today. But due to certain reasons, which I won't go into, my ophthalmology marks weren't very good. So if I didn't get the ophthalmology house post with my own batch, I wouldn't be able to at all with the next batch. And this is where Lord Tirupati enters. This is a small story which I must tell you, and I'll keep it very short. So I was very keen on ophthalmology. So my best friend, she asked me, do you really want to do ophthalmology? I said, yes, I do. She said, then let's pray to Lord Tirupati. I said, how will that help? She said, no, he grants wishes, you have to really want it sincerely and badly enough. And after you get what you desire, you must send him something, by way of donation. I said, that I don't mind doing. So we both sat and prayed. And you won't believe that there were 8 people ahead of me who had opted for ophthalmology house post. One by one, all of them got deselected because of certain reasons or the other, and I got the house post. And that's how I became an ophthalmologist. So my faith in Lord Tirupati is, goes a long way back. We invoked him again when I was choosing my husband, because my friend again asked me, do you really want to marry this guy? I said, yeah, it'll do now. I'm fed up of seeing guys. Enough. I'll marry this guy. So again, we invoked Lord Tirupati, and again the same thing happened. Yeah, yes came from their side. My entry into government service. The one and only person to thank for this is my husband, Dr. Anand Malik. He had the foresight to guess rightly that the only way for me to get into GMC Aurangabad was to get a lecturer's post elsewhere, because I would never have been allowed to join a lecturership in Aurangabad directly. The MAD was very strong at that point of time. Like a gift from God, a vacancy came up in BMMC Sholapur, and because I was already a diploma holder, I became a lecturer there in February 1979. There's a story in that too, but let it be. And I got transferred to Aurangabad in August 1979. The rest is history. My entry into MOS. This is also interesting. All credit for this goes to Dr. Sadashiv Athavale. My very first MOS conference outside Aurangabad, it was in Kolhapur. And just before that, he had visited our home along with a surgeon from Jalgaon who came to meet my husband. I was also introduced to him, and he told me, I don't see you in MOS. So I said, no, sir, with small children, I don't get to go. He told my husband, next conference, you have to see to it that you send her. And my husband told me, ab to terko jana padega. You have to go. So we went all the way to Kolhapur from Aurangabad. Those days, it was not easy traveling. And as soon as we went into that conference, he told me, you have to attend the managing committee meeting. I said, sir, but I'm not a managing committee member. He said, you will become. And I became a zonal member for Marathwada, one of 3. Can you imagine at that point of time? He said, yes, she is going to be a zonal member for Marathwada, and nobody raised a voice against him. That was how things were those days. So I was very happy. From then on, joint secretary, honorary secretary for 2 years, my first vice president election in 2000 at Sangli, 3 more unsuccessful elections followed, a bout with breast cancer in 2017, which was the year I became second vice president of MOS, unopposed, thanks to so many people. It would take a whole webinar to list all those people, and it was my dream come true. Believe me, I had always wanted that, but I thought that maybe I'm going to go up without realizing this dream, but God had something else in mind. My presidential year and Corona. My year began with much fanfare and grandeur at Nagpur in 2019 October. 3 CMEs and 1 POS conference later, lockdown. Then began a series of very successful webinars along with NTOD, culminating in a highly successful MOS Vircon 2020. Full credit goes to my team of Drs. Vardhaman Kankriya, Pritam Saman, and Santosh Bede, who assisted me so ably, and we could do so much. This is a picture of me in Nagpur. The highlights of my presidential year. There were many firsts to our credit. First time webinars were introduced in MOS. First time MOS membership updation was done on a massive scale. First time new membership numbers were given, which wouldn't need any change for the next 10 years. First time total online elections were held with a record number of 1,200 plus members voting. First time MOS PGIIO, a professional indemnity scheme, was introduced. The first MOS virtual conference, MOS Vircon 2020, was held. Looking back, I feel immense satisfaction of having achieved what I did. And I think I have achieved something. Immense gratitude to God, my immediate family, my friends and colleagues for all their help and support. And an immensely satisfying feeling of having been able to achieve my potential, which I think everybody, not only women, everybody needs to do. It's not just women who need to realize their potential, even men need to. A sense of happiness of having touched so many lives in so many ways. I think this election campaign gave me back a lot more than I gave to it, because I came to know from so many people what they think about me. It was really nice. I really enjoyed it. A sense of having given back to society what I got from it. Thank you so much. Wish you all a very sparkling Diwali. Thank you.
Thank you, madam. Thank you for this. Always wonderful hearing to you. And you are so motivational and inspirational as always.
Thank you so much.
I'm just, is Dr. Ragini Madam joined? I don't see her, so maybe I'll take my talk first.
Please,
And
go ahead.
yeah, I would like to share the screen.
Yes.
A very good evening to all of you. This is Dr. Gitanjali Sharma. Madam just mentioned that her presidency of MOS and the pandemic started together. So the same thing happened with me as well as the president of Pune Ophthalmological Society. But madam, I would say you were much more fortunate because at least you got a few months in hands where you could do something physical. For me, it was exactly the whole thing went on virtual. Saying so, it was a wonderful year for me. And so I would like to talk about COVID times, a new challenge. When you consider about doctor women, we have history like Anandibai Joshi, Dr. Rakhmabai Raut. They are our inspirations. When I took ophthalmology as specialty, the most popular branches were gynecology, anesthesia, pathology. I was already married and I was already a mother when I opted for ophthalmology, and everyone said, yeah, that's the best branch because there are no emergencies for you. Believe me, in last 25 years, ophthalmology evolved more than any other specialty, and it was so challenging to convert yourself into newer technical knowledge. Surgical techniques, instrumentation changed, laser refractive became a specialty. Learning was a big challenge, and especially with family responsibilities. I could not go for a long-term fellowship because by that time I had another child, so I was mother of two. But COVID attack was something, a totally different new challenge for me. It was unexpected. It was unknown entity. Even today, I would say, not many scientists know 100% about this virus. It was an invisible enemy. It was unimaginable. We had many challenges. There were hospital challenges. There were challenges at home. Economical crisis happened. There were health challenges and there were mental stress. Women in ophthalmology had given different kinds of roles during COVID pandemic. There were deans of various medical schools, institute heads, heads of the departments, there were faculty, there were private practitioners like me, and there were resident doctors as well. And everyone gave the best possible thing during COVID times. Ophthalmology challenges include red eye, which were not getting resolved easily. There were dry eyes, there were cranial nerve palsies, there were vascular occlusions, there was mucormycosis, a big challenge. And nowadays we are seeing so many white cataracts, hypermature, stony hard cataracts. But I think these challenges were easy to tackle for us because we were all expert in that. The main challenge were the practice challenges, safety of us, safety of our staff, and safety of our patients. It was very difficult to use 2 or 3 masks with a shield when it used to cause fogging and still do the retina examination. Staff issues were many. When the lockdown started last year, if you all remember, many of the staff were removed from their residential societies. I mean, the society wanted the healthcare workers to give services, but at the same time, they felt they were risk for them. So they were removed from their residential societies. These problems we handled in a different way. I think that was the time when I developed more strong bond with my staff and we formed more like a family. I encouraged them that this is the golden opportunity for us. We are the Corona warriors and we should give our services. And my staff, till today, they are all with me. In fact, there are additions and nobody has left. Online consultation was another challenge. Till then, we were already giving a lot of advices on telephone to our friends and relatives, but this became legal. We had to learn the legalities of online consultation, about the consent, about the audiovisual thing. There was no face-to-face communication. This was another challenge. Just see this photo of mine. Nobody knows whether this is a lady or a man when you see one in PPE with the face shield and mask. Now we have our personality, to convince our patients. That was totally gone. So here we have to convince our patients only with our skills, especially with my pediatric patients. This was more important because I didn't want them to get scared of me. And I did take that challenge. Most of the doctors, most of the ophthalmologists have taken that challenge. We are tough women. Remember that. We all are very tough women. And so I salute to all doctors and all women ophthalmologists. Now, there were personal challenges, especially at home. As you all know, there were no maids, no cooks. And then we were working in the hospitals. There were software professionals. They were working from home. Teachers were working from home. So for them, it was easier. For us, it was difficult. There were online schools for children. I always believe that parents must take active interest in children's education, but online school was totally different. And our ladies did take that challenge as well. Hubbies in kitchen was another stress. Suddenly, most of the husbands started doing something in kitchen. For them, it was hobby. For us, it was a challenge because there used to be a lot of pasara later on, which we had to manage. I come to mental stress. There was fear of unknown, children's education. There were no entrance exams. So those teenage students, teenage children have a lot of mental issues. There was stress on them. Mothers had to tackle with that stress. There were a lot of health issues like dry eyes, backache problems, and other issues. We managed those. Psychological issues in children were very, very important because of online schools. They were not playing with their friends. Socialization was less, and they were always on their mobiles. So being continuously on mobiles had another problem, psychological issues among children, and all mothers had to tackle with them. Elderly lockdown at home. Our parents, our in-laws are used to going for walks, going to temples, going for satsangs, going for laughter clubs. Everything stopped, and they developed that kind of fear. Second wave gave another important mental stress to all of us, and that was death of our colleagues. I remember as president, the toughest job for me is to organize the condolence meetings. So that stress also we had to manage. About financial crisis, I may not go much into details about this because Dr. Bagli madam is going to speak about that. But I always told myself, financial crisis, we were not the only one. The whole world was facing financial crisis due to COVID. And now I come to the main thing, leadership challenges taken by women. Here are all those women today in this webinar. Dr. Namrata Sharma gave us the direction, like you should not say no to anything. Everything is possible. And these leadership challenges were taken by all of us. There are special qualities in women leaders. We have very strong mind. We are ready to do hard work. When I became the president of Pune Ophthalmological Society, and when there was lockdown and 144, many men, they said, what are you going to do, Gitanjali? सगळ्यांनी घरातच बसायचंय, काही नाही तू करणार, 0 year होईल. I said, no, I fought, I bounced back. So I put a lot of hard work. We have resilience. We are non-fragile women. And then we do everything from heart. There is caring and sharing. We consider our association, our society as a family. We women are always fighters since birth, but during leadership, we have to think beyond our womanhood. My presidency and pandemic, as I mentioned, started together. But लहरों से डरकर नौका पार नहीं होती, कोशिश करने वालों की हार नहीं होती. I proved that. I was an elected president. Remember that. When you are elected, you have more responsibility because people have voted. They have shown trust in you. So you have to prove yourself. There was vision, there were ideas, there was planning. I formed my team. Team building was there because I wanted implementation and execution in a better way. The ultimate measure of a man is not where he stands in moments of comfort and convenience, but where he stands at times of challenge. Martin Luther King said that, and that's my favorite saying. My theme line was vision beyond sight. We did vision beyond sight. It was a most memorable year in the history of POS because everything happened for the first time. Mine was the first virtual installation as president. Any competition we declared, it became global. Our conference became global. Even we did the skill transfer course virtually. Surginar was virtual. Rural ophthalmology webinar was a success. So everything was unique and nice. What I did was I just had goal of keeping my managing committee together and keeping the whole Pune Ophthalmological Society together. So I had bonding with almost every member. Every day I used to write a blog for Pune Ophthalmological Society, giving a chance to one member to show his art or his achievement. I think that brought a change. Whenever you have to take challenge, you have to first recognize the problem and find solution. There are people who just create problems. You have to find solutions. Then only the challenge is well taken. Now I feel that we have to think as doctor beyond ophthalmology. I'm into IMA as well. So we are doing a lot of vaccination drive, awareness programs in other issues as well. And that's what COVID has taught me. So this is another challenge. Saying so, I would tell all my women friends and girls that you should take care of your own health. Take care of your diet, fitness, mental issues, discuss with others. You should have health insurance and always follow your hobbies and passion. So fitness is most important, but I never left my Kathak, which is a meditation for me. And my poetry is my introspection or self-realization that gives you peace of mind. COVID pandemic has given us a pause. Let's think about introspection, self-exploration, self-analysis, family values, relationships, being a good human being. And most important, take care of nature and environment. And also preserve our culture. Many people say culture is not just the responsibility of women, पण जिच्या हाती पाळण्याची दोरी ती जगाते उद्धारी. त्यामुळे आईनं ही रिस्पॉन्सिबिलिटी घेतलीच पाहिजे and we have to maintain our culture. I believe in Bhagavad Gita. I always suggest that please read Bhagavad Gita. It gives positivity, it gives love, it gives peace. Thank you very much for patiently listening to me. I must say, this slide I must explain. That's my daughter. She is a physician endocrinologist in the USA. She was giving her services in COVID times over there. I was giving my services here. Even my son is pursuing internal medicine in USA. So even he is giving services for COVID patients. As a mother, it is very, very tough when your children are also serving COVID. In COVID, they are also facing the risk. Here you are facing the risk. And most important, you cannot meet each other for last 2 years because of travel ban. But I always believe and I always tell my children that God has given us this opportunity. This is the lifetime opportunity in a century. We are the selected fortunate ones. So let's give whatever we have to the society. And that's how we believe in. This is the photo when we clicked, when we reached at the summit of Mount Evans. But I tell my daughter, it is the journey which is more important, not reaching the summit. Because after one summit, there is another. So let's walk this journey. COVID times will go, some new challenges will come. But let's continue walking the journey of challenges. Thank you very much for patiently listening to me.
That was excellent, Gitanjali. Beautiful.
Amazing talk, ma'am.
Very nice.
I would now just stop sharing my screen. And Dr. Anagha.
Dr.
Yes,
Ragini has joined. Gitanjali, Dr. Ragini has joined.
Dr. Ragini has joined?
Yes.
Okay.
I saw her just now.
Yeah, hi, ma'am.
Sorry, Dr. Ragini, because I
Hi,
did not
Ragini.
see you. I completed my talk. So Dr. Ragini madam needs no introduction again. She's the Dean of JJ, a very dynamic
Professor and
lady.
head, actually.
And of course, now as scientific committee chairman, we all have witnessed what a wonderful conference she has organized. Every aspect, every minute thing. She's a true leader. So let's listen to her now. Over to you, Dr. Ragini.
Thank you, ma'am. Thank you. I think ma'am was responsible in getting me nominated at the scientific chairman with all my gurus over here. I can see Deshpande sir, Dr. Lane sir. Thank you, the wonderful, the glowing, the shining Gitanjali. I think it's your spirit which makes you so beautiful with your physical beauty. Anagha, Dr. Meenakshi Bagli ma'am, and everybody present here today. Thank you for giving me an opportunity to be a part of this session. Saidada, would you please share my presentation? So I must thank Sumit for this lovely presentation. He's been working hard for the conference and also helping with our presentations. Thank you so much. So large volume surgery challenges, I would not call it a camp because they are no longer camps. They are large volume institutional surgeries. Next slide, please. So, you know, we started with very little. When Lohane sir joined the department, it was doing around 600 surgeries per year. And now, not only in 2016, 17, 18, now the work is little low, but up to 17 to 18,000 surgeries a year now. So the volume has really increased. Next slide, please. So you see, this is the kind of patients that we are faced with. This is a picture of Baba Amte's ashram. We started with 170 surgeries and we did around 2,000 plus surgeries the last 3 years. And I think the work is going to start again. Patients come with a lot of expectations and in huge crowds waiting for us the whole year. Next slide, please. So who will treat them, you know? We need to be aware that these are the people who are in very rural areas with very few ophthalmologists in that setup or with a few kilometers radius around it. Yes, next slide, please. So, you know, you need, there has to be a constant will to reach out to more people. Yes. And everyone cannot come to you because these people have this phobia of catching a train, coming to large cities, and they are scared. They don't know how to reach a city. So it's important that the people who are scared to leave their small little town or village and have never gone anywhere, so it's important for us to reach them. The only way we can reach them is go to them. And it was called camps earlier. They are no longer camps. They are no longer in makeshift rooms or OTs. They are proper certified OTs and a large institutional surgery procedure. Next slide, please. So we do two types where, you know, where patients from very rural areas who are far off are brought to JJ. And because, you know, like say for Uran, we have been doing 3 camps per year for the last 20 years in Uran, and they can come to the institute. We don't need to shift 40, 50 people over there. It saves a lot of time, energy. So people who are able to come to JJ, like Karjat, Kasara, Dhanu tribal people are all brought to JJ. And where the camps are very far, 500 kilometers, we go to them and we operate at the base hospital. Next slide, please. So what are the most important part of these large volume surgeries? So I think when I joined and when sir and I started doing surgeries, Dr. Lani sir is my guru. So it's always assumed that, you know, when you're outside, it's a training camp, or you experiment on the patients there. Now, if there is a complication at JJ, you can keep the patient for 1 more day. You count the patient for follow-up. For the outreach camps, you are not sure whether the patient will come back to you. It's so far that some people say that it's too costly for us to come back for follow-up visits. So the quality should not be compromised. That's the most important thing. So we need to create the same protocol and the operation theater that we have in tertiary care centers, so that the quality is not compromised. So how do we go about doing that? Next slide, please. So, you know, we decided to take everything, and that required, so we have microscopes. I remember when I was practicing, I had a 1FR microscope, which my dad bought for me in 97. And when I stopped practicing, he gave it to JJ and we still operate on it. So we don't compromise. We take our microscopes, we take our chairs, we take around 50, 60 set of cataract instruments, so they can be autoclaved and given back, disposable, everything. I mean, we carry things in thousands to the camp. It may be 10,000 10cc syringes, that many gloves. Next slide, please. So when you are transporting, especially in India, to around 1,000 kilometers, then you have to carry it in a dust-free environment. The first few trunks, we travel like the military with these trunks. As you can see that, and you know, why do we need to carry? Of course, things are available in Varora, things are available in Nagpur, but we need them in large bulk. They may not have 10,000 syringes. They may not have the quality of polydrape that we want. And they may not have 2,000 polydrapes. Of course, the shops will have, but it is few because they don't have that volume of patients. That's why you need to take everything. It has to be checked. It has to be checked for expiry, clean, the quality, packed, cling wrapped. And I always say that I'm the best packer and mover that's available, because I need to supervise everything and see to it that not a single mistake is made during the packing, because then there's no time during the large camp that we do. So this is very important. Next slide, please. So we have trucks to transport, and you won't believe it that it's not only the saman which is clean, but the truck also needs to be cleaned and sanitized and covered properly with a large black sheet below and above and around, so that the things go safely. So it involves a lot of efforts and lots of micromanagement and planning. Next slide, please. So what about the OT structure? The OT is certified, prepared, civil work is done. Next slide, please. And everything is as the guidelines. So, it is in a proper certified ophthalmic theater. Next slide, next, please. So it has to be inspected and prepared by a senior ophthalmic surgeon. So when we are doing large volume surgery, these OTs are certified by sir and me and prepared. All the swabs are sent, civil work. They are clean, they are, everything, they are serviced or they are changed. The water tanks are clean, the water is tested, everything is done, everything is done. So fumigation and everything is done. Yes, next slide, please. So these are the type of patients, as you can see, children, mature cataracts, the leprosy patients. So this is very, very important that they get treatment. Next slide, please. So these are the large, lines which await us when we go. So when you do quality and the patient gets result, they get food, they get quality results. They come back because of the love. We don't make them feel unwanted. We don't make them feel that we are doing a favor. Next slide, please. So it's very important that they are screened for diseases. What you can operate, you operate. What you can treat, like glaucoma, you give them drops. And what you cannot treat, the squints or people who require specialized treatment like diabetic retinopathy are called to JJ hospital. So this is how the screening takes place. Next slide, please. So it's very important to do a complete examination. So you don't compromise on any step. You do the fundus, you examine the patient's eye. Next slide, please. So this is me. This is the leprosy ward where they are kept, and then examining the patients again and again, because you might miss out some congestion, discharge, some people who hide dacryocystitis. Next slide, please. So this is me in 2005 examining and cleaning a patient's eye. Next slide, please. So this is a unique system of identification where numbers, because in India you will have lots of Saraswatis and lots of Mustafas, and everything is written here, the A scan, whether the HIV is negative, what type of cataract, hypertension, and then the next day the BP, the sugar reports, and everything is entered. Next slide, please. Yeah, I'll finish quickly. So this is the worksheet, and you need to data entry. The lens sticker, as you can see, is very, very important. Next slide, please. So this you reject. So they are not taken into consideration, and these are the patients who are treated later. Next slide, please. So next slide, please. Next slide, please. Yeah, so it's important to give pre-operative instructions. Next slide, please. Preparing the patient, washing the legs, because we are in a rural area. This is again a leprosy patient. There's a huge team, the name, people know us as, Dr. Lahane sir and me, but the doctors, the staff nurses, the ward boys, the sweepers, the NGOs who work with us are very, very important. Next slide, please. So this is the OT. As you can notice, it is a very beautiful OT with all microscopes, as you can see, assistants, and a perfect OT setting, not compromising on the quality care. Next slide, please. The leggings. So here it was the legging of the patient so that the OT is not soiled, because you do large volume. Next slide, please. Autoclaving, you can see the large, huge autoclaves. Next slide, please. Proper sets. Next slide, please. Disposables are discarded. Next slide, please. So post-operative instruction and examination, as you can see, 7 days and 1 month for refraction, and complete treatment is given. Whatever you do, you have to evaluate yourself. Next slide, please. So follow up till refraction. Next slide, please. So we have done a huge number of CAMs and a large number of surgery only at CAMs. Next slide. conclusion. So you have to treat these large volume surgeries like your own theater. You need to build up a team, make a checklist for everything, and keep a very good follow-up and a small margin of error. Next slide, please. So I would like to say a big thank you for giving me this opportunity. I'm sorry I overran my time because this is one presentation which is very close to my heart. And it is dedicated to all the patients, my teacher, Dr. Lani sir, and the whole team who made me what I am today. Thank you so much. I'm really sorry, Gitanjali, for
Great, Dr. Ragini. Fantastic it was.
Thank you, Sai Dada, for doing this for me. And thank you, Sumit, for making this lovely presentation.
Yeah, you have always been a role model. Those who wish to do such high volume surgeries, for them, this was a, perfect talk, I would say. Yeah, great. And great for the whole team as well. As you mentioned, it's a teamwork.
Thank you so much. Thank you so much.
Yeah. Let's now go to our next talk. That is by Dr. Anaga Herur. Again, Anaga needs no introduction. She is representing ARC in IROS as well. Anaga, over to you, please.
Yes, ma'am. A very good evening to all of you. And at the outset, I would like to pay my respects to all my respected seniors here, all the inspiring ladies and my role models, Sunana Malik ma'am, Ragini ma'am, and Dr. Gitanjali, Dr. Meenakshi, Deshpande sir, and everyone, Lane sir. You have all been a source of inspiration to me. And thank you, Dr. Gitanjali, for giving me an opportunity to speak in your IC. Is my slide visible, ma'am?
Yes, yes.
Yeah. This is a very interesting topic that Dr. Gitanjali gave me. It's about a woman entrepreneur. What are the triumphs and tribulations? This was one line that I really liked by Dr. Mrs. Kiran Mazumdar Shaw, that I really believe that entrepreneurship is about being able to face failure, manage failure, and succeed after failing. If you look at a lot of literature, there are a lot of problems and prospects of women entrepreneurship. But latest data shows that women are actually more successful than men. Yes, today we would think that we live in a patriarchal society where it's said it's a man's world, and the Indian woman is considered as the Abla Nari. And there is a lot of disparity yet between men and women. Even though we think that we are inching towards a gender neutral environment, I think we have a very long way to go. Now, this was a report by the World Economic Forum, and this says that there is at least 100 years before we can actually achieve gender parity, which is a huge time. And this report says that the gender gap is only getting more compounded in the coronavirus pandemic. So now, if is you need to have passion. You need to be hardworking. You need to have the self-confidence in yourself. You need to have a vision and have excellent communication skills, have administrative capabilities, being tolerant to all the problems, being a problem solver, and have a risk-taking ability. And yes, there are huge challenges faced by women in business. Now, if you look at the need for women entrepreneurship, the most important thing is, why does a woman want to start her own business? The thing is, she wants to set up her own identity. She needs to be independent. She knows that she has a bright future. Her confidence and positivity increases because of that. With her business, she creates greater employment opportunities. She makes better use of her education, awareness, and with the support of her family members, she develops an equal status in society. But yes, there are a lot of problems like lack of motivation, confidence, no financial support, a lot of gender discrimination, which is being done even today, and harassment. If you look at the problem of finance, a lot of times women may not generally have that much property on their names, which is actually required as collaterals when you go for a funding from the bank. So banks may consider women less credit worthy than men. Many enterprises started by women may fail because of this. They may face stiff competition not only from the organized sector, but also from their male counterparts, because they may lack the organizational setup required for starting their own business. Now, this was a lovely line. When someone says you won't do this because you are a girl, I can't rest until I do that. And this has been so inspiring. Now, limited mobility is one more problem that women entrepreneurs face. The problem is you cannot really move around a lot just like men because you're tied down to your family. A single woman, for example, asking for a room is still looked at with suspicion. A lot of times, officials have a very humiliating attitude towards women, which compels them to give up the idea of starting enterprise. Most of the times, women are supposed to be just family women. Like you are basically a housewife, so you need to look after your in-laws, your children, your husband, look at what's happening in the kitchen. So it's very rare that a family would actually approve of her going out and starting her own enterprise, missing out on the family responsibilities. So the support and approval of the husband almost seems as a necessary condition. So it all depends on the educational level and the family background of the women when they enter into business activities. It's very, very difficult, dear friends, to actually balance your family life, social life, as well as your professional life. More than anything, there is a big gender pay gap, not only in India, but also in developed countries like UK, for example. Female doctors are paid 34% less. And this is not just now. If you look at this graph, right from 2006 to 2016, things have not changed. If you ask women if they are feeling financially more empowered, look at these statistics. Even in 2019, larger number of women say that they are feeling less financially secure. If you look at the average loan sizes, you can see that women are funded 31% less than men-owned businesses. So in all, you look at the financial prospects, it becomes a more uphill task for women. If you look at this, who wins the money matchup, men versus women? If you look at this, 53% men feel confident of making investment decisions alone, whereas it's just 38% in women. Now, this was a line by Carolyn Fernandez. To me, a woman who is financially independent is very powerful. She has the ability to say yes, but more importantly, she has the ability and the strength to say no. That is what is more important. So if you look at factors that motivate women to become entrepreneurs, yes, you get good social status, you get your own personal identity, you become a role model to others. But more importantly, you get to understand, learn to face new challenges and growth. Female type leadership is required, and in COVID times, it has been found that yes, resilience, courage, flexibility is all that is so more important. There are a lot of factors that enable or constrain women's economic empowerment: education, skill development, access to good quality jobs, access to financial services, and social protection. So, if you look at women empowerment, me in my hospital, we made a conscious decision to have an all women team. It was an uphill task, and when I started practice, I was not only looking after practice, my in-laws, the family. It was a very difficult job to do. But as an all-women enterprise, we really benefited and we focused on our strengths, having better social skills, better team players. We think females are better communicators, and we use influencing skills rather than authority. Probably women are naturally good at multitasking. We value work-life balance more. We handle crisis situations probably better. And probably we view work more holistically than only financial returns. If you look at special needs in healthcare, women are generally more soft-spoken, empathetic, great listeners, less aggressive, and hence high emotional intelligence, which relates to our patients. As a woman leader, definitely there are a lot of criticisms that we face. For example, if a man is considered aggressive, a woman is considered pushy. If a man is considered exercising authority diligently, a woman is considered to be power mad. Many times people don't listen to or take directions as comfortably from women as from men. Women are who promote themselves are probably looked at disapprovingly. So basically, you need to break the glass ceiling. As it is said, it's very hard to be a woman. I was very fortunate to have good family support from my parents, my husband, and with a strong woman team, we were able to stand up for everybody else, and collectively we were able to turn our pain into power. I'm just finishing in half a minute. Many times on Women's Day and on Navratri, we get a lot of messages, but friends, who says it's just a man's world? Let the men speak for themselves. Even in COVID countries with women leaders was probably they were able to handle COVID crisis better. So to conclude, young women entrepreneurs out there, blaze new paths and don't allow yourself to be restricted by outdated traditions. Don't be a woman that needs a man, be a woman that a man needs. We have the power to change someone's life. All we ask is a level playing field. It's not that any one gender is superior to the other. Let's live harmoniously so that the society becomes a better place to live in. Never ever give up your dreams just because you are a girl and you don't have support from anyone. In fact, if people are doubting how far you can go, go so far that you can't hear them anymore. Thank you so much for your kind attention. Thank you, ma'am.
Thank you, Dr. Anaga. It was an excellent talk. Very, motivational for many young women over there who want to start their own hospital and own setup. Let's now go to Dr. Meenakshi Bhagli ma'am. She has been the past president of Pune Ophthalmological Society. Presently, she is the zonal member of MOS. She has also been the sub-broker for the stock exchange. So she is going to speak about financial literacy, how women should get literate about their financial management. Over to you, ma'am.
Just a minute. I'm so sorry. Just a minute. I'm just trying to figure out where my presentation is.
Meenakshi?
Just a minute. Yeah, I'm trying to.
No, it's okay. Don't get hassled. It's okay. Share your screen, then go on your wherever you put your presentation and double tap on it. It will start.
Just a minute. I think I will go to.
No? You're not able to?
No, I'm not able to.
Can you bring it to your desktop? Can you bring your presentation onto your laptop screen? Then it becomes easier to share it. That's what I generally do, actually. Try. Find your presentation, bring it to the screen. I think Gitanjali and Anaga are with you, na? So,
Yes, madam, I'm trying to help her.
See if you can help her.
Where is the presentation, madam?
Oh, it is on the desktop.
So open your desktop, please.
It might be in recent, if you have prepared it recently.
Can you see? Can you see?
No, you haven't shared yet. Have you pressed or have you clicked on share screen? First, the green button at the bottom.
Oh, sorry, other version. Minimize screen. Minimize. Yeah. It's called minimize. We want to minimize.
Don't worry. We are only missing part of the inauguration. Not a big deal.
No.
Okay.
Just
It's okay. It's okay. No issue. Take it coolly.
Madam, I'm Sai from Numerotech. Can I assist you?
Yes, Sai, please try to help her.
What is that you see when you click on the share screen?
No, we can't actually
Click on the share screen. Now it is there. Can you see now?
Yes.
Yes, now we can see.
Now you go to slideshow.
Go to slideshow.
Yeah, I will do that.
Yes. And start from beginning. From beginning. Yes, right.
Yes.
Right.
I'm so sorry for this inconvenience.
Not at all.
I thank MOS, Gitanjali, and everybody for giving me this opportunity. Like Dr. Anaga was saying, that ladies need to be financially literate. So I will give you a small talk on how ladies can become financially literate. We doctors are really good at wealth creation, but not very good at multiplication.
since we have limited knowledge of finance and investment, and most of us are self-employed and need to provide for building a clinic, repayment of its loan, taxation, hospital and family running expenses, etc. So it is very important that we have good investment ideas so that we can fulfill all our dreams. There are three aspects of wealth creation: earning, which we are good at, saving or preserving, and multiplication. There is a great power of compounding. Like if you invest 1,000 rupees at 12% return, then in 10 years it will become 3,262 instead of 2,200. And over 30 years, it will become 34,711. So you have to invest and stay invested. So bigger the amount, say if you start at the age of 25 by putting aside 1,000 rupees a month, say about 15% returns in equity, then your corpus at the age of 60 years will be 1.23 crores. If you start 5 years later, it will be half, almost like 60 lakhs. And if you start little later, from 35 age to 60, then it will be only 29 lakhs. So it is important to start early and stay invested. So let's see, if you do monthly saving or you do lump sum just once a year, what is the difference? If you invest 5,000 rupees a month in a mutual fund or something for 30 years and get 12% return, then by your 360 contributions, your corpus will be 1.74 crores. But if you just do over 30 years, 30 contributions of 60,000 lump sum every year, then your corpus will be 1.44 crores. So you are 30 lakhs less by just doing yearly contribution of the same amount. So it is very important to invest regularly and do a SIP or systematic investment plan in a mutual fund. Each one has different aims depending on our age and state of life. Like some want to spend money for building a house or hospital, some want to spend money on education or marriage. But the goals of investment remain the same. That is, your investment has to beat the inflation. There should be less difference between pre-tax and post-tax returns. You should be able to protect your wealth, and transmission of wealth to the next gen is smooth. So let's see what is inflation. Inflation is the rate at which currency loses its value or purchasing power. We are seeing that every day by hike in the petrol prices. When government says that there is 6 to 8% inflation, they are giving 50% weightage to food items. Whereas for us elite class, where we want higher education, leisure, holidays, the lifestyle inflation goes up by us, and your investment should get more than 12% returns. What is post-tax, post-inflation return? If you put rupees 100 in a FD at 7% annual return, you are earning 7 rupees, which will take away taxation. Usually we are at 30% tax slab. So you will get just 4.9 rupees. And if you consider inflation of even 5.9%, your post-tax, post-inflation return in a FD will be negative. So you have to choose your investments. There is nothing which is risk-free with high return. So we have to balance our risk. Asset creation products, and some are asset protection products. The asset creation products are financial ones like fixed deposit, direct equity, RBI bonds, PPF, mutual funds, etc. Some are physical assets like real estate, physical gold, diamond, silver, platinum, jewelry, and certain alternative assets like REITs or hedge funds or gold ETFs instead of physical golds. And there are some asset production products like insurances, personal health insurance, Mediclaim, term life insurance, professional indemnity insurance. All this will protect your wealth. For your stocks, there are certain hedging products. So let's see in different asset classes, what kind of returns have you got over last 37 to 38 years? Fixed deposit have given around 8.4%, gold has given 10%, silver 9%, Sensex has given 18% appreciation, and cash diminishes with time. So over from the history, we learn that doing investment in equities or equity related mutual funds, etc. is best. Then is gold, then silver, and then fixed deposits. So when you get the returns from investment, you can opt for regular returns like interest from bonds, bank deposits, or rent from properties or dividends. Or you can sell an asset and get capital appreciation. And depending on the time you hold it, you have to have long-term or short-term gains, which will have different taxation. So tax consideration will be the interest income from bonds and deposits will be taxed at usual slab rates, except 50,000 for senior citizen savings schemes. Dividend income is now fully taxable. Rental income has 30% set off as standard deduction apart from the allowable expenses like property taxes and maintenance fees. Long-term capital gains on listed shares and mutual fund is 10%, while short-term is 15%. But both are taxed at half the usual slab rates for most of us. And for different asset classes, short-term capital gains are different and long-term capital gains are 20% after indexation. So when you do asset allocation, according to the age, you should choose. Like if you are young, you can have more equity exposure, like 40 to 80% also, which will grow faster and it will be more risky. But as you grow older, then you should have more of debt investment, which is safer, and you should reduce your exposure to equity. At all given time, your exposure to gold should be just 10%. Common mistakes which doctors do, that they see insurance as an investment, they buy insurance of non-earning members or due to obligation for friends, etc. They don't define what is the age for retirement and they don't diversify. Instead, pump a lot of money into real estate of clinics, or they go on borrowing money for equipment or cars to save taxes. But if there is a calamity and there is incapacitation and you cannot perform your profession, then there is nothing to fall back upon. So you should have your investments which will earn for yourself, and you should have a second income as you grow old. So all of us should create that. So the tips are: total loan amount you take should not exceed 10 times your annual income. EMI should be not more than 30 to 40% of your carry home monthly income. Investing in oneself is essential, but reskilling and upskilling in profession as well as in the investment is very mandatory. Thank you.
Thank you, ma'am. Thank you, ma'am. Bagli madam, that was an excellent talk and very good tips for all of us. We all women should learn to invest, and COVID times also gave me the chance because I learned a lot about this financial management as well. Usually we like to invest in gold and diamonds, but as madam had said, that should be the third priority, if I'm not wrong, ma'am. Yes. Yes. So I would like to thank Sunaina Malik ma'am, Ragini ma'am, Dr. Bagli madam, Anagha, and everyone who contributed for today's webinar and this session. Women are always taking up challenges and they would take up the challenges. Women ophthalmologists have proved themselves already and they will keep on proving themselves. Thank you, ma'am.
Thank you so much, Gitanjali, for giving us the opportunity.
Yes, thanks a lot, Gitanjali.
Thanks a lot. Bye. Bye, everyone. See you in the hall below.
See you.